Good morning, everyone. Welcome back. Um, Today is rolling on. This is our day 2 where the theme is more about colon and hepatobiliary. So I hope you had a good time yesterday and enjoyed the upper GI and innovations and where the third space is going. Today is more about HPB and colon. So we want to keep it on time today. We have 3 different live streaming coming through from Kent, from Milan, from Florida. So thankfully, I won't be doing anything from Portsmouth. So we're very relieved of that. But there are lots of interesting talks. It might be a little bit confusing for people, but you'll have to make choices between hepatobiliary and colon. I'm afraid those who do both, they will have to make a choice because we'll run parallel symposium. So most of the hepatobiliary sessions are going to be next door behind. Is it Chichester Suite? Yeah. In Chichester Suite, just behind this auditorium. So please go there. For our virtual audience, thanks for joining again, guys. Just remember that we will only be streaming from our main lecture theater, the Mary Rose. So a lot of hepatobiliary sessions will not be streamed. So you'll only be watching the colon sessions for the virtual audience. Let's not hold back because we got some great faculty, great talks. But before that, let me introduce my co-chair, Dr. Keshwan Kandia, consultant gastroenterologist from St. George's. Keshwan, do you want to say hello?
Oh, hi, I'm one of the gastroenterology consultants, and I do interventional work in George's. So this morning we have 3 talks of how we do it. And the first person probably doesn't need very much introduction. He's a master trainer and master endoscopist. We all know him. And this John Anderson is going to tell us how to whip out that pedunculated polyp.
Just whispered him in, yeah, there's no choice today. Obviously, the people are going to be in this room doing colonoscopy. Just for the crowd online. Do the slides come up here? Yeah. Yeah, so what we're going to do is we're going to keep it nice and basic. I was conscious yesterday, for those of us who mess about in the third space, it was very entertaining. No, that's no wrong.
Oh, sorry. That wasn't what was on there.
That's mine.
Yeah.
We're going to get a little bit more down to basic stuff today, but I truly believe if you get the basics done well, big stuff is just lots of little stuff pushed together, really. But you've got to get the basic technique first. So what I'm going to do is I'm going to look at pedunculated polyps, often overlooked. And I want to thank Pradeep for the invite. And just remember today, if you want to ask questions, there's no such thing as a silly question. I haven't got any disclosures. And what I want to do is I want to teach you how I do take off pedunculated polyps. And then importantly, I'm going to tell you the rationale for why I do it as I do it. There are other options available, which I'll touch on. And I think importantly for you guys, when you're doing something, you have to understand the pros and cons of the technique you're applying. So do we pre-treatment, do we post-treatment, do we do both? That was a long debate for a long period of time, and the evidence base is not fantastic supporting one thing or another, and where there is some evidence, I will let you know. So what do you do before you remove a 1p polyp? Well, some of you do nothing, you just reach for the snare and stick your foot on the pedal. Some will inject, some will try an endoloop, and some put clips on, and there are obviously pros and cons to doing this. So just what do I do? First thing is I fully assess the lesion, because I need to know if there's cancer in the head, and I'll come back to that. I also want to know where the neoplastic tissue or the head of the polyp joins the stalk, which is effectively an elongation of the normal mucosa. And I want to make sure I know all the way around, in case you've got extension down the stalk, or you have an unexpected lateral spreading component to your pedunculated lesion. And then I will define the lesion in terms of Paris. So if it's a 1p, it's a 1p, but I also put some size on that to give me an estimation of the occult chance of having malignancy within the head of the polyp. So basically for pedunculated lesions, the bigger the lesion, the bigger the risk of occult malignancy. And then I work out where gravity is. And then I get the right snare size. And the snare size is usually the same size as the polyp head, or possibly a little bit smaller, because you can manage to move normal tissue down into a smaller size snare if you've got the right technique. Then I optimize the patient position, and I do that, and I try to get the polyp going from the anal to the oral side, lying at 6 o'clock. Sounds easy in practice. I want you to think about what you do next. So if you do nothing, what makes you decide to do something? You should be asking yourself this question. If I inject, what do I inject? Where do I inject? How do I inject? What am I trying to achieve by that? If I use endoloop, do you use it? If you don't use it for all your pedunculated lesions, why not? And if you put clips, how many do you put in? Where do you put them, and what you're trying to achieve with that? So just ask yourself those questions before I tell you what I do. And then you should be able to explain the same as me, what you do and why. If you can't, you're not really being objective and, well, shall I say, deconstructing what you're doing on a rational basis. So I pre-inject the stalk, basically at the attachment with the mucosa. And you'll see the polyps lying nicely there, and it's moving away from it. You've got a nice picture of a stalk. You can't see the full head of the lesion because it's behind the polyp, the fold rather, because it's rather big. And then what I do is I advance the scope. I bring the snare to the end of the scope, and I basically put the snare out, and I see what orientation the snare is at the end of the scope. Then I bring it back into the channel, so it's fully open back in the channel. Then I put my instrument to the head of the polyp. So the stalk's behind me, and I'm over the head of the polyp. Then I start advancing the snare out through the channel, so it expands over the head of the polyp, and I simultaneously will bring the scope back. And what happens is your scope expands, your snare expands over the head of the polyp, and as you bring the scope back, the snare comes back and pulls down nicely over the head, down towards the stalk. I then continue to retract back, and then I stop the withdrawal when I can see the base of the stalk. At that point in time, I move the snare gently back and forward, and this is what we call a push-pull technique. You push it forward, pull it back, push it, and it basically wiggles the snare down until you've just got the snare behind the stalk. And if necessary, I can open a little bit more and capture a bit more, so I capture the whole head. Then I bring the snare down, and it sits on the stalk, and I pull the snare open into the channel. So I've only got a little loop of wire around, and I've got the stalk in front of me. And then I ask the assistants to start closing the snare, which I have marked. And as they close the snare, I advance the plastic sheet simultaneously, so the back of the snare doesn't move. If you don't do that, they close the snare, the snare obviously closes in towards the plastic and will start pulling the stalk up the channel, and you don't want that to happen. The question is, where do you put it on the stalk? You want the neoplastic tissue, which is the adenoma, which is in the head of the polyp. So you could take it at 1, but you run the risk of an incomplete resection. So you either go for B or C. Most people say, well, I'm not going to go for C because that runs the risk of a perforation. So the sensible place would be B, assuming the stalk is long enough and your skills are good enough to get the snare in the right place. The other thing you've got to think about is the potential for cancer there. So there's an area of depression, irregular morphology of the polyp maybe. It's something you don't like about it. You have to think, well, I need to get the best pathological en-bloc specimen, in which case you're going to take it as close to the base as possible. And if you're going to do that, you would definitely need to put an injection in there to protect from a perforation or a delayed perforation. So you adjust your technique depending on your assessment of the polyp. So I will mark the snare, and then I used forced coagulation effect to 25 watts, and I just slowly cook the polyp. I gently move the snare back and forward, which adds a shearing force to this, and I count the time it takes for the snare to go through the polyp stalk. And that is a little bit subjective, so it's a big fat stalk that's going to take longer than a small stalk. Okay, so when I say to the nurse, count to 4, 1, 2, 3, 4, it should be through. If it gets to 5, it's probably not the end of the world. If you go 1 and it's off, you're dealing with a bleed. Okay? Have your stalk ready to re-grab the stalk if that happens. And then I'll look very carefully at the base, and I'll look for any oozing or bleeding, because that's when I'm going to treat with clips. If there's any bleeding present, I use the water pump to inject the base to clear and find the source of the bleeding. And then I use soft tip coagulation to stop the bleeding at source before I apply clips across the vessel. That's what I call a deconstruction of polypectomy. If you want to see more of it, we have a website which does a lot of that, which is up there called geeks.com. So this is an example. It's an old video, but the polyp head here wasn't great, and the stalk here was very short. So I was desperate to get as close to the base as possible. So this is the snare coming out over the head of the polyp, and you'll see we just pull the scope back a little bit, pull the snare down. Snare comes down, you tip down at this point in time, and then I'm going to retract the snare back into the channel. So the back of the snare sits snug on the back of the stalk. There we go. And then as it's closed, I'm sliding the plastic forward. So you see the metal moving, and then you'll see the catheter come into view in a moment. Just reposition it a little bit, get it right to the base. Slide forward. So you'll notice there's a bit of tattoo in the lift, actually, in this one. We've gone for a tattoo straight away here. And we slide it up. And then we just move it away from the mucosa just to make sure it's safe. And then we slowly cut through and we cook it. And you can see it being cooked because it's going white. So you then inspect the base. And if you look at the picture on the bottom left-hand side, this polyp is slightly unusual. Most pedunculated polyps have a big vessel going through the center. This has actually got 3, and we put 3 clips on the vessel to try and prevent the bleeding. And I think if you're going to clip post-resection, you need to be targeting your vessel. Another example of a vessel in the base, this time the clip goes right across the stalk. So the idea of putting clips on following your resection is to occlude the vessel in case the spasm is released or you have ulceration at the tip and it starts bleeding afterwards. When else do I clip? Well, there are some factors from the literature suggest if you've got a polyp head of greater than 20 millimeters, the cost effectiveness of clipping favors clipping. So you should clip the lesion after you've resected the head. If I see any post-polypectomy bleeding or oozing from the site, I will also put a clip on. And in our society in the UK, it's probably easier for you to clip than have the patient readmitted to hospital. With a bleed, it's cheaper to put the clip on, probably. As I said to you, if you put the clip in the wrong place, not only do you not prevent the bleeding, but you make the endoscopist's job who's going to sort out the mess a little bit more difficult. I have a tertiary referral practice, and I spend a lot of time seeing patients from a long way away. So if they're very elderly and they're not going to do well with the bleed, they live alone, they live outside the area, they've got comorbid disease, or they're going on anticoagulants, they will get clipped, irrespective of the size of the head of the polyp. Also, there's some people who just seem to have a bleeding tendency, even though they're not on anticoagulants or haven't got any disorder. And these are ones you biopsy and it all just oozes straight away. Or they've had a previous polypectomy and they've had a post-polypectomy bleeding, I'll also clip those. So the 1P risk is really bleeding. And as I said to you, it sits in the center of the vessel. And the bigger the head, the bigger the supply. So I mark the stalk to make sure I get a good capture of the tissue. And this is what I do. I bring the snare to the end. I open it fully down the channel so you can see, and then I bring it back so just the end bit is showing. And when I close to the mark and I mark the back of the snare, I know I've got that much tissue trapped within the snare. If they can't get close to the mark, there's more tissue than I think. If they go past the mark, you've cheese wired, and you don't want to cheese wire. I know there's a lot of people in the audience who will close their own snares without marking and they go for a feel. And that is fine if it works for you. I just don't, if I'm teaching it to my trainees, I can't teach them feel. I think Brian might differ, but we'll see. So I mark my snare. And then I think the diathermy settings are important, but coaptation and the current density you apply is far more important. And that's down to the person closing the snare. Okay, so if you squeeze it really quickly, you're going to cheese wire it, whatever you think, because there's a shearing force there. If you take too long, you're going to have a different problem because it will carbonize. So what happens is the tissue heats up. Once you've got carbon around the snare will then not conduct electricity. And then your only way of then cutting the polyp head off is by cheese wiring it. So that's when you strip the stalk off the vessel and leave the vessel standing up. Or you just evulse it right through the vessel and you've got bleeding. So you can either close the snare yourself to make sure you get the timing right, or after careful discussion with the nurse, you get her to count it through. And this is what coaptation is. Electricity will flow down from your snare down to the patient plate through the stalk. And when you close it, you get an increase in current density where it is nipped, okay? And this is an R-squared effect. So you reduce the snare by a quarter, the stalk by a quarter, the current density goes up by 4. And as I say, as it continues to heat off, what you want is desiccation before you get carbonization. So desiccation will seal your vessels and cut through the polyp head without carbonizing the snare and failing to conduct the electricity. So you've got to do it quick enough for that to happen, but not too quick so you get bleeding, and not too slow so it doesn't work. So it's a bit tricky. So I'm going to, one more minute really. So endoloops, I had this fantastic quote from one of the fellows here yesterday. I love endoloops, she said, I love them. Well, they're perfect when they work well. And then there was a slight pause, and then she went, but I don't know how to use them. And I think, for me, I'm not a big endoloop fan, but I don't use them. The guys who use them probably get very good at it. And my tip is, if you're going to use something, use it a lot. Get very familiar with it and make sure all your staff are trained about it, and it's absolutely fine. And the idea is you've got to choke the vessel so it doesn't bleed, and then it doesn't matter what diathermy you use above it, because in theory, you've occluded the vessel. But again, if the stalk is relatively thin, you can cheese wire it through, and there is some coordination required. It can also interfere with your snare. I've just talked to you about current density, in both your clips and your endoloop will have the same effect. So this is actually got this from Brian a long time ago. So they put the endoloop on, then they put the snare, and you can see what's happening. The coaptations cause the diathermy burn at the site of the endoloop, right on the mucosa, and they haven't lifted this. So there is a risk here that you will get ulceration there and possibly deep mucosal injury at the site of the endoloop. So this is something to think about if you're going to pre-treat. Last thing I'm going to say is, for the big 1SP lesion, they're difficult. So they start off like this. You put a snare around them and you close the snare, and you can't see the base, let alone whether you've got a linear plastic tissue in you, because you pull everything together. Okay, so these are difficult to see. And you have the same problem because it takes a long time to cut through. You're on the risk of your snare becoming carbonized, and the very big polyp doesn't cut through, and then you worry, and then you switch from the blue pedal to the yellow pedal, and that doesn't work. And you think, try to take the snare off, and that doesn't work either, and you start to panic a bit. So I've stopped doing that with these. Actually, I've just used ESD. It's wrong to do blue pedal, then yellow pedal, for the obvious reasons. You're going to coagulate the outside, then you're going to cut through the very thing you're trying to seal. That is illogical. And I've heard people come on the course saying, I use a bit of blue pedal and I cut through the yellow pedal. It is completely illogical. For the big stuff, I tend to resect now using ESD, and I appreciate you haven't all got access to ESD. So the other way to do it is to use something like this, clutch cutter or an SB knife, and you can cut into the very broad-based 1SP lesions. It allows you to control the vessels, and it usually allows you to give an en bloc section. So what I do is I inject the stalk, I mark the snare, I inspect the base, and I apply clips where needed. Consider getting some other sort of device for the bigger lesions so you can get an en bloc resection without not having the problems. And I would tell you that teamwork here is absolutely critical. If you're interested in another course, we've got one running in September. Thank you.
Sure, thank you. Thank you very much for that masterful explanation, walkthrough about how to do something that's thought to be simple. Next up, we have Dr. Noriko Suzuki from St. Mark's, who's a consultant endoscopist. Everyone's familiar with her. And she's going to tell us how she does EMR, although she's a master ESDist. And we'd love to hear what she has to say about this technique.
Good morning, ladies and gentlemen, and thank you very much, Pradeep, for giving me this opportunity. Ohayo gozaimasu, Abe sensei. So my talk is about how do I do it. Kesaban said how we do it, but actually, how do I do it? So obviously, if the lesion is over 10 millimeter, we need to apply some heat. What do? I do it hot colonic EMR in cold way. So namely underwater EMR. I'm a big fan of underwater EMR because you are asking how do I do it. So I want to explain underwater EMR. So I don't want to go much detail to the data, but underwater EMR, comparing to conventional EMR, definitely there is a benefit. So this paper showed the efficacy of underwater EMR for 10 to 20 millimeter lesion. Underwater EMR is superior in RZ resection and en bloc resection. So good for 10 to 20 millimeter lesion. So how about 20 to 40 millimeter lesion? Yes, underwater EMR is superior in en bloc resection and RZ resection. And then if you do piecemeal underwater EMR, the recurrence rate is much, much smaller than conventional EMR. And some people worried about you might cause perforation because you are not going to inject. No, actually, underwater EMR is very safe procedure. Look at this, intra-procedural perforation is 0%. So just talk about the theory of underwater EMR. So once colon is filled with water, that give you the optical zoom effect. So 1.3 times magnification. And that will float the mucosa and submucosa. And it's not going to thin the mucosa. Once you are going to blow the air, the colon expand, the wall become much thinner. So lesion is also going to float into the lumen. So easy to snare. And muscle stays circular underwater. So when you try to capture the lesion, very unlikely to capture muscularis propria with snare. And then when you cut with snare, this water protecting against the deeper burn. So reduce the risk of perforation. Sounds good. Very, really, I think, attracting. So I'm just going to go to how I do it. I'm just going to show you some videos. So this colon is already filled with water. And this is a 70 millimeter 2A lesion in ascending colon. So applying NBI or some image enhanced modalities, you can see the polyp very clearly. Now you can see now sucking water and just wait a moment. Look at this, now 2A become 1S. And this polyp has got a long axis. So I try to match the long axis of the snare and the polyp. So I rotate the scope and then just gently place the snare. So no injection required. The polyp is really inviting you to be captured. And you can grab with normal mucosa. And then instantly, you are going to cut. I normally control the snare by myself, just to see the resistance. And we need to inspect carefully after resection. So this is a case, very small lesion, transverse lesion, 8 millimeter, 2C lesion. This was referred as a non-lifting polyp. So after careful inspection, this is TXI mode. And there is no obvious, still genet 2A or 2B, but there is no walling appearance. So use NBI, which will enhance the lesion, and use near focus so you can stay on focus. And just wait a moment. Again, this doesn't float well, but you can easily grab this kind of lesion. If you inject this kind of lesion, normally non-lifting sign may be observed and then very difficult to capture with snare. So another case, this is a transverse 30 millimeter recurrence lesion. You can see fold conversion at the anal side of the lesion. this looks like a 2C plus 2A, but this is very modified from previous resection. So when you put the water, I will encourage to suck the air first. Otherwise, you need a lot of water, and the colonic wall is thin. So please aspirate the air. And again, change to NBI so you can see much clear view of the polyp. And this polyp doesn't have longer axis. So this 15 millimeter snare is gently placed down to the lesion. So this is a scar tissue. So when I grabbed the snare, it felt very tight. So I am slightly worried about causing perforation. So that's why I suck the water before cutting through, standby for perforation. But luckily, that tightness was from just fibrosis. And this kind of oozing can be treated with snare tip, soft coagulation. I'm just going to demonstrate. This is a hepatic 20 millimeter LSTG lesion at a hepatic fracture. And after inspection, there is nothing sinister findings. So JNet2A lesion. But the difficulties of this lesion is growing, traversing the fold. So this is a retroflex view of the lesion. Again, is inspecting and benign lesions. I do injection occasionally from the oral side to change the configuration of the polyp before underwater EMR. Underwater EMR with retroflex approach is not recommended. Somehow it will lose the effect of underwater EMR. So after making the injection, maybe I can put a snare with conventional way, but having water give me more secure feeling. So again, I try to match the long axis of the snare. And try to anchor the tip of the snare and very gently press down. And again, I get snare by myself and I feel the resistance. I'm very happy to cut through with forced coagulation, which is my normal setting of the EMR. So one last case I'm just going to show is again, this is a hybrid underwater EMR. This is 3.5 centimeter lesions at the transverse colon. So very difficult to see the oral aspect of the lesion. The lesion starts floating into the lumen, but still very difficult to see what is happening to the oral side. And if you can't do retroflex, I tried to do retroflex, but I couldn't do it at this point. So I start making injection at the oral side of the polyp. And I think Professor Fonda said this is a surfing injection. So just to try to ride on the wave. So making another injection at the oral side. So maybe I made a 4 injection. So another injection at the oral side. Now you can start seeing the oral side of the polyp. So never inject from the anal side on this polyp. So once oral lesion or oral aspect of the lesion become clearer, what I have done this to the lesion is, of course, put the water to see, but still a bit unclear. So I made a little bit cut using the tip of the snare, just save the money. And now anchor the tip of the snare and do underwater EMR. So in this way, I think we can somehow do en bloc resection safely up to 3 to 4 centimeter polyp. So again, just take a little bit time to do snare closure. And again, I control the snare by myself and try to achieve en bloc resection. So actually the base was not so big. Okay. So to summarize my talk, ladies and gentlemen, how do I do it? I do underwater EMR. This has higher complete en bloc resection rate for 10 to 40 millimeter lesions. And this is easy and safe procedure. And in terms of the technical tips, aspirate the air, use NBI or image enhanced modalities, and match the axis of the snare or and lesion. Thank you very much for your attention.
We'll have discussion together in the next session. So that was very, very good demonstration of how you do it. Next on will be Dr. Sachiro Abe from Japan. So we're changing this course now slightly from colon to upper GI. Sachiro, welcome back. It's a real pleasure to have you with us. And you're going to tell us about Duodenal EMR.
Good morning, everybody, and good afternoon from Tokyo. Suzuki sensei, ohayou gozaimasu. Thank you so much for inviting me and giving me the opportunity of the talk. Let's get my video talk started. I have a pre-recorded video.
You know, we always knew that National Cancer Center was world's best hospital. It looks like you now received an official award for being the world's best hospital.
Thank you so much.
EMR, how I do it. And see why. Endoscopic resection is technically the most challenging because of the narrow limit, which means the narrow one space during the procedure, which leads to poor scope manipulation. Additionally, the thinner muscle layer means that there is a higher probability of the serious complication, such as the interoperability or delayed preparation. The muscle layer is only 0.5 millimeter thick. One of the key points for successful duodenal EMR is scope selection. We normally perform histology and gastric ESD with the therapeutic gastric scope X260J or an X290P. And notably, X290P scope, maybe it is not available in the US. It's helpful to do EMR owing to good down angulation, almost 120 degrees. However, and it is something difficult to get close to the lesion and snare polyp, particularly in the deep subsequent portion of the duodenum. In that case, And pediatric colonoscopy, it has a thick shaft and bends downwards well. It's helpful to get close and smell the polyp. I'd like to show you a case of the conventional EMR. The lesion is located on the second portion of the duodenum and close to the major pillar. This patient also had a peripheral diverticulum here. So the submucosal injection is very important. We do the submucosal injection on the distal side to make a submucosal cushion and shift the lesion towards the proximal side. And then we create the pre-cap to insert the tip of the snare to get it stable. And then we slowly open the snare and apply the snare and close it, and then cut it down. The mucosal defect was completely closed with endoclips. The histology reveals fibroadenoma adenoma. The second case was underwater EMR. And underwater EMR has been more commonly performed in Japan, probably based on the favorable excellent result of the study in colorectal EMR. Here you can see the whitish duodenal tumor located in the second portion of the duodenum. And we normally check the lesion using an API and with magnification to delineate the margin of the lesion. And then we do a saline immersion from the water jet pump. And before that, it is very important to clean the duodenum and get rid of the mucus and bubble as much as possible. Here you can see the polyp. And we slowly open the snare and apply the snare, including the surrounding mucosa of the duodenal lesion, like this. And then slowly close the snare. And the risk of perforation is very low, I believe. And unlock resection was done. And after that, we usually perform the magnified endoscopy once again to make sure to know the area of the lesion, and particularly at the edge of the mucosal defect, like this. Similar to conventional EMR, the mucosal defect was securely and completely closed with endoclips. The histology reveals that adenoma. Finally, I'd like to show you a laparoscopic and endoscopic cooperative surgery, EUS. This procedure is almost similar to the ESD. Only one different thing is the closure of the mucosal defect. The defect closure is performed by a surgeon, zero muscular closure. Here you can see the large lesion, large flat duodenal lesion located on the second portion of the duodenum, as you can see. And the first procedure is the mucosal incision of the proximal side. We gently apply the tip of the Biliary and perform mucosal incision after the injection of the sodium hyaluronate. And small caliber end cap SP fluid is very helpful to enter the submucosal space. And then we perform the water immersion technique and water pressure method, which is developed by Professor Yahagi. It's very useful to do sufficient and safe submucosal dissection. And the submucosal space of the duodenum is very narrow, and we need to carefully and gently performs the submucosal dissection, fiber by fiber. Finally, under dissection is then. Here you can see the large mucosal defect, and then zero muscular defect closure is performed by hepatobiliary surgeon or plastic surgeon, and complete closure is then. Of course, if you are confident, you are able to close the defect endoscopy. Of course, ESD is a good option and better option for expert hand. Here you can see the data of the American Center retrospective study from Japan. And under resection rate of EMR decrease as the tumor size increase. On the other hand, under resection with ESD group is over 90% regardless of tumor size. And underwater EMR for the inferior resectability compared with the conventional EMR for relatively large lesion. However, there might be a selection biases because an underwater EMR can be performed for lesion indicating non-negative sign, and it is reported to be reduce the rate of conversion to ESD. In terms of the local recurrence rate, as expected, and overall local recurrence rate is significantly higher in the EMR group. And focusing on the region greater than 30 millimeter in size, and 2-year cumulative local recurrence rate was 22%. Based on the result nowadays, we are likely to select a B-less procedure rather than piecemeal EMR. In summary, the scope selection is essential for successful delivery of EMR. And underwater EMR has been more commonly performed. However, the further prospective study is warranted to compare the treatment outcomes between conventional versus underwater EMR. And ESD or DLEX require a high scale to avoid complication. And therefore, this procedure should be performed by a skilled experts. Thank you so much for your kind attention.
Thank you, Sachiro. That was a wonderful demonstration of how to perform duodenal resection. We're very impressed by your ESD technique in the duodenum. I think that is not for faint-hearted. Can I ask you quickly, in terms of the delayed bleed rate for duodenal resection, when the lesion size is more than 50 millimeter, for duodenal EMR, we go to delayed bleed rate of 30%. What is the delayed bleed rate after ESD? Is that phenomenally low?
Sorry, I couldn't hear you well. Maybe the sound was
Yeah, hang on a second.
not good.
Am I on? Yeah. Sorry, the microphone wasn't on. I had to
Okay,
learn
okay.
how
Now
to
I
switch
can.
the microphone on.
Could you please say that again?
Yeah, sorry about that. Your ESD technique was very good for duodenum, but that is not for everybody. But the advantage you showed us clearly was about the recurrence rate is very low. One of the biggest fear, apart from perforation for duodenal resection, is delayed bleed. And for EMR, for large lesion, delayed bleed is quite high, around 30%, I would say. What is it about ESD, the delayed bleed rate after duodenal ESD?
Yes, thank you so much for the question. Good, very good point. Actually, the risk of delayed bleeding is higher in the ESD, but there is a selection biases because the size of the mucosal defect is much higher in the ESD. And it is very important to absolutely and securely close the defect. And the incomplete closure is a significant risk factor associated with delayed bleeding. So I think the size doesn't matter and the method doesn't matter. As most important point is close completely.
That's a very good point, but complete closure of a defect is very challenging even in colon where the wall is thick, space is big. In duodenum, muscle is so thin, space is so limited. It can be extremely challenging for normal people like me.
Yes. That's true. That's why I prefer to selecting the laparoscopic and endoscopic collaborated surgery. And some Japanese experts can do complete closure even for the extensive large mucosa defect, but I'm not confident. So that's why I asked the surgeon to do that.
Thank you very much. We'll take very quick question before we move on to the next session. So can I ask Dr. Anderson if you can give him the mic? He's here, Dr. Anderson. She's my Australian fellow. She doesn't recognize British people, sorry. So John, one of the big challenge of pedunculated polyps is some of them are very big, they're lumen filling. We don't know where the base is. We don't know how to get the snare over it. What is your trick? How do I get my snare to the bottom of the stalk in a polyp where I can't see the base? It completely fills the lumen.
Yeah, that's a great question. So simple things first. So on the way in, if you've got a lumen filling lesion, just get some adrenaline and just inject it straight into the stalk. It will shrink things down a little bit. It'll make it slightly less vascular. And then complete your colonoscopy. When you come out, it will be a little bit smaller than it is, but it's still probably lumen filling. I think this is where your patient positioning becomes really important. And I would, if you're unable to position it so you can evaluate the whole of the base in one position, you change it to another position. And if you're still struggling, another thing you can do is come out and put a cap on. If you've never used a cap, you should probably get some and at least try them. It's a great technique to look at the base. And the final tip I would give, it was really on the back of what Noriko was saying, is take all the air out and fill it with water and it will float. And if you have water and a cap, you'll almost certainly be able to see the base. So just a few things to try, Freddie.
Thank you very much. Any question from the audience? Noriko, I was going to ask about EMR. Looks like you like a fish who doesn't feel comfortable when it's outside of the water, because the things that can be easily done even without underwater, you go underwater and do it.
I feel very insecure without water.
Without water. I could see that. But one of the, theoretically, I saw what you did there. The advantage is, but if we don't go underwater, the en bloc resection rate could go down, or the number of pieces required for resection could go up. Is that your feeling? Do you think you can take much bigger bites underwater than you would take without water?
Yes, conventional EMR, once you inject solutions, you basically stretch the lesion, you make the lesion bigger. So underwater, because of the floating effect, you can grab much bigger samples than the conventional EMR, and therefore RZ resection rate is higher, and then RZ resection, en bloc resection is higher.
But conventionally, when we always used to teach, the bigger you grab, higher is the risk of perforation. But obviously, it's the water that is preventing this.
Yes, yes. Muscularis mucosa propria stay circle. That's the key.
Excellent. There's a question right behind you.
Hello, I was just asking about the volume of fluid you're using, because those of us who use water to get a nice view aren't putting in a very large amount of fluid, and so we're not too concerned about hyponatremia or anything like that. But now we're talking about bigger volumes. Should we be concerned about that? Should we be using saline?
I think if duodenum or I normally try to use saline. But in the colon, normally if we deflate the air, it doesn't require so much water. And then we are doing the study, putting the water and then check the water volume in container. That is, I think, not much difference.
There are lots of questions. We have to take very quick questions and quick answers before we move on to the next session. So very quick, Adolfo.
Noriko, you showed how sometimes you close the snare out of the water, sometimes inside the water. You close snare by yourself, so you have the feel. But if you have to instruct your nurses, you tell them that it should take longer when you close the snare underwater because of the heat dissipates, and they say it takes like 30% longer. So if you try to cut at the same speed as out of the water, you get bleeding. What do you tell your nurses, depending on out of the water, inside the water?
As I said, I'm closing snare by myself. So I've got a feeling I can control the speed of the closure. So I'm not going to telling to the nurses, but I sometimes said, prepare the clip or prepare, just stand by coagulosper.
Excellent. One final question there at the back.
Question to John, please. John, just want to, I'm not very clear about when we are doing the 1P or SP polyp, the ideal position is 5 or 6 o'clock. But what about the gravity? How do you change the position of the patient to get the gravity right? And
Yeah, in short, yeah, we roll the patient, I roll the patient a lot, so we have a relatively light sedation. So if you're one of these guys who slows the patient, you're going to struggle because things become awkward if you can't use gravity to your advantage, both to move the fluid, but also to move the gravity dependent part of the polyp, which is the head. And it just goes with gravity and it pulls the stalk away. So I really encourage you to try rolling your patients and get the patient in the right position to give you access to the polyp. If you're really struggling, the channel is at 5 o'clock. If the polyp is not at 6 o'clock, as your accessory comes out at anywhere other than 6 o'clock, as it comes out, it occludes your view. So if it's at 9 o'clock or 3 o'clock, or worse still at 12 o'clock, you just got an accessory going right across your view and you can't see things. So you have to orientate it such it's at the bottom of the screen for virtually every therapy you do.
Excellent. I think, thank you very much. We got a huge session again on colonic resection. So we'll take a lot more questions and discussion. Can I ask our next panelists and moderators to take the seat? I think that involves John, Brian, Sunil from here. Michael, are you with us? Hopefully Michael Burke will be able to, look, I can see Michael is with us. Yutaka Saito, are you joining us? Is Professor Saito logged in, guys? Maybe Yutaka has forgotten. Sachiro, if you're still logged in, can you give him a buzz, please?
Yes.
Yeah, please let him know. He's supposed to be in this session.
Okay,
Remind him.
We'll do.
Hi, Michael. Good morning. Well, sorry, good evening for you.
Good evening. How are you doing?
Very well.
I'll just show you what delayed us. We just finished upper esophageal sphincter ESD full circa in the pharynx across the sphincter and into the upper esophagus.
That is your specialty, Michael. That's your trademark these days. You keep changing. You keep changing your geographical location of resection.
Yeah, well, my recurrence rate after EMR is less than my recurrence after ESD. That's how effective snare tip is.
Well, I think that's the end of the next session, guys. We might as well all go home now. But I think Michael has recorded a very good talk. So I think what we can do is, if we play Michael's talk first, and then we have a very good panel here, Michael, who are really gearing up to question you. So
very distinguished panel, I see. Some good friends.
Yes.
All good friends, actually.
Thank you very much. So can we get Michael's video to play now, please?
Morning, Pradeep and Shamila and all of the colleagues there. Many thanks for asking me to participate in this wonderful meeting. I'm going to talk about polyp resection. We'll play some videos. Of course, we have these two excellent guidelines. The European guideline is currently under revision and there'll be significant changes. And then, of course, the American guideline from 2 years ago, which very much mirrors the European guideline from 2017. When we think about removing polyps in the colon, we always need to think, what is the underlying pathology? Is it, broadly speaking, adenomatous or serrated? What is the size? What is the morphology? And both of those guidelines fail to consider this also very important point, which is lesion location. What is the site of the lesion? Is it in the right or left colon, rectum, or anorectal junction? We know that cold snare excision is totally established for lesions less than 10 millimeter. And I'm not going to talk about that. There's no doubt that almost all lesions less than 10 millimeters should be removed by 1 or 2 piece or perhaps 3 piece cold snare excision. I'm going to talk about things bigger than that. So in the previous guideline, both guidelines, either cold or hot snare polypectomy was considered for non-pedunculated polyps 10 to 19 millimeter. And this is currently the existing standard hot snare excision with thermal ablation of the margin. But increasingly, we'll be using cold snare excision for smaller lesions. So this is a 15 to 20 millimeter laterally spreading lesion in the colon. Sorry for that noise. So never start in the middle. We use a stiff thin wire snare. Wire diameter for these cold snares is always between 0.28 and 0.3 millimeter. And we cut through systematically, working from one edge to the other, water jet to expand the submucosa, make the cushion firm so you can push down. That's a cold snare protrusion. Generally no residual adenoma in that. And then just work sequentially. We use an injection and generally dilute adrenaline as well to minimize bleeding. And then if there's any doubt about completeness of excision, then it's always best to just re-excise. And you can make the defect as big as you like. Cold snare excision is very safe. There's virtually no risk of bleeding afterwards. There's almost completely no risk of deep mural injury or perforation, apart from scarred lesions perhaps. So it is the existing standard of care for lesions up to 10 millimeter, and it probably will become the standard of care for flat lesions up to 20 millimeter that don't disclose any features for high grade or early cancer, and perhaps even beyond that size. There are a number of randomized trials going on at the moment, including our own. We've also published our experience with serrated lesions, the primary experience, and also in combination with Nick Tucci from Brisbane. And then more recently, we published this large experience of piecemeal cold snare excision of large serrated lesions in comparison to the cohort of EMR. And you see the existing EMR cohort of 400 lesions versus cold snare, and bleeding negligible, in fact 0, and perforation 0 versus significant incidence. And then recurrence, first recurrence, not different, but slightly higher than you hope for, 5.4 versus 3.6. And then second recurrence at 18 months, very low, acceptably low out of these very large numbers. So this will be the way to go for serrated lesions, indeed in 2021 and now 2022 and going forward. So up to 20 millimeter, no doubt they'll all be done by cold snare excision. They have a low mucosal profile, thin lesion, soft tissue, very easily excised by cold snare excision. Lesions with dysplasia or early cancer, absolutely contraindicated. Of course, remember, serrated cancers, even though their mucosal profile is relatively subtle, they can be relatively advanced histopathologically. So they're not candidates for cold snare excision. So this is the sort of thing one can do. 100% circumference, maybe 6-7 centimeter long lesion in the proximal ascending. This patient can go home the same day. If you did this by hot snare excision, the patient would definitely have some pain and probably have to stop in hospital one night. And then in follow-up at 12 months, we don't see anything to be worried about, but there's a little bit of nodular tissue here, but the pit pattern's normal. But the beauty of cold snare excision is if there's doubt, just excise. So, so we can widely excise this area. Probably one snare excision was sufficient, but why not just make a large defect, be sure that we've removed all of the potential residual neoplastic tissue. In fact, all of this submitted tissue was histologically normal. And here's the technique. So we push down very firmly, aspirate gas, reduce the print of the lesion, and up, down, very, very firm. And then if it's stuck, you can use traction against the end of the endoscope. And to confirm there's no deep mural injury or DMI, water jet into the defect, make sure everything expands up. That was all histologically normal. So successful, fully circumferential cold snare excision with follow-up at 12 months. So if we then consider the larger polyps, 20 millimeter and greater. So in the colon, I'm not talking about the rectum, but in the colon, the large laterally spreading polyp is the domain of EMR. If there's a dominant nodule, then remove this first. It's unequivocally the standard of care. So we generally just cut this off with fractionated current, tap through, work sequentially from the edge of the expanding mucosal defect and just work your way across the lesion. Check each resection for DMI, water jet to expand the submucosa. And even I can make a little error like that, leave a little bit of adenoma behind. If you leave some adenoma at the edge, I suggest to excise it immediately because it's sometimes difficult to find later. So if you see that you've left a little bit of adenoma at the edge of the defect, just excise it immediately. It's best done at that time. You can take as much normal mucosa as you like. You don't need to limit that. Aspirate gas, get the snare to be, the heel of the snare sitting firmly on the mucosa, and 3-stage snare closure. Don't rush the snare closure. Make sure the snare bites in before you close. And that's the completed defect. We inspect for DMI. You can see the muscle underneath there. There's a little bit of non-staining. So we use topical solution, TSC, topical submucosal chromoendoscopy to confirm that that's not muscle. It's obviously not. And then this light touch technique of snare tip soft coagulation to ablate the margins is now the standard of care. Now, why is EMR the standard of care? Well, we did this study based on, I think, nearly 2,000 lesions, large prospective cohort. And we compared selective ESD, so ESD where we thought there might be cancer, versus universal ESD versus universal EMR. And the best strategy was selective ESD. If we did universal ESD, we only saved another 13 surgeries compared to selective ESD out of 1,000 cases. And the cost per surgery saved was $210,000. And this is in an era of EMR where we didn't know the snare tip would mitigate recurrence. So recurrence is all in this, but there's no recurrence now. So EMR is much, much more cost effective than universal ESD. Subsequently, we're able to show that thermal ablation of the post-EMR margin in the randomized trial reduced the risk of recurrence fourfold, from 20 odd down to 4 to 5. And then in the open label study of 1,000 cases, recurrence was actually only about 1.4%. Very, very low, because we realized that snare tip was so much safer. The earlier study included the sort of, learning phase, but this study, we knew how safe it was and we could be very aggressive. And then the next point is that even if you inadvertently resect a cancer, so-called covert cancer, then the outcomes are still relatively favorable. You shouldn't do that, but if it does happen, it's not so bad. We know that that these lesions in the colon, 5 to 7% have cancer, and about half of it's covert. We can't see it. And then if we look at this ACE data, like 3,400 cases, 143 cases of covert invasive cancer, 4.2%, and histological analysis in the majority of those In all cases, residual intramural cancer at follow-up could be identified by an R1 histological deep margin. So the findings, the important findings were that amongst patients proceeding to surgery for cancer discovered after piecemeal EMR, the surgical specimen does not contain residual malignancy in either the colon or the lymph nodes in 60% of cases. The risk factors for lymph node metastasis are very clear: poor differentiation in any resection specimen or lymphovascular invasion. In the absence of either poor differentiation or lymphovascular invasion, the lymph node metastasis risk is less than 1%. In fact, in this study, it was 0. So it's definitely less than 1%. And low-risk lymph node metastasis cases with an R0 deep margin have a less than 1% risk of residual cancer. In fact, in this study, no risk of residual cancer. So if none of the specimens show a deep margin involved and there are no risk factors for lymph node metastasis, then you can counsel these often elderly and frail patients, many of them negatively selected, sent for EMR rather than surgery, not that they should go for surgery if they're healthy. You can counsel them that the risk that they have residual disease is extremely low. So this is why EMR is really the standard of care in the colon, because it's so effective, it's so efficient, recurrence is negligible. And most of the time we can tell when there's cancer in the colon itself. Covert cancer is not common. And even if you inadvertently resect, the risk for residual disease is very low in the majority. So I don't see an argument for doing ESD in everyone. And what about ICV? So this is also challenging, best done in retroflex. Start within the ileum and then work your way. Around and so on. And then we see here, obviously a lot of fat. I think we've done a full circumferential excision of the ileum. This is, that's in retro. Yeah, that's in retro. Some snare tip for some persistent intraprocedural bleeding, and you see there a nice resection defect. So with these advances in endoscopic resection technique, these more difficult and challenging cases can achieve really excellent results. So these are other examples of ICV. And then when we compared the two cohorts, contemporary cohort of how many lesions, 66 versus older cohort of 76, you can see that recurrence is very low, 4.6 versus 20%. And commonly we use other techniques like cast and so on, which I'll discuss in a moment. So now anywhere in the colon, almost all lesions can be safely resected. The other challenging spot, I suppose the three spots are ICV, anorectal junction and appendiceal. Here's a periappendiceal lesion. This is a good indication for underwater EMR, I believe, because it's possible to better define the anatomy, expand up the appendiceal orifice, and identify just how far, and if at all, the lesion extends into the orifice, and perhaps even float some of the tissue out. If it's circumferentially involved and it disappears beyond your view, then you're not going to be able to remove it endoscopically. The patient will need also an appendicectomy. So you can see that always start in the most tricky spot. So you want to be sure that you've removed the tissue adjacent to the appendix, you have a clear margin there, and then the rest of the procedures very straightforward. And so on. So you see here the end result. So wide excision, some cold snare protrusions, and you can be very aggressive with the cold snare excision. Also, we were doing snare tip with these, and we did publish a significant series on this. If you can't, important to note, if you can't see the proximal aspect of the polyp, if it's extending down to the appendix, the patient must undergo appendicectomy. I think the risk of advanced pathology, either high grade or early cancer in this cohort was something like 15%. So these patients must always proceed to appendectomy. 15% in the resected appendix is what I'm saying. So what about previously attempted non-lifting lesions? These were previously argued to be good candidates for endoscopic full thickness resection or ESD or underwater. In fact, we just remove them by conventional EMR with follow-up cast, cold avulsion followed by snare tip soft coagulation. We first published this for non-lifting lesions a few years ago. I think 100 lesions or so in that experience. And then more recently, we've published the results in the previously attempted cohort, which I'll discuss in a moment. So you see this multiply attempted lesion, 5 centimeter residual. Look at it, it's terrible. Annual attempts over a 5-year period in the preceding 5 years, referred to us from a remote location. And extensive scarring. I think if you did this by ESD, this would be extremely challenging. Hours and hours of work. You couldn't do it, or you couldn't do it on block by endoscopic full thickness, and well, you couldn't do it, it's too big. And so we can easily do it by cast. So we just start in an area where there's good lifting and work our way towards a non-lifting area, perform piecemeal hot EMR, recognizing that we will have some deep mural injury here. The circumferential muscle fiber has been exposed, but the longitudinal still intact. And this is the sort of thing one will see. So fluid jet, and then snare excision. And so on. And then as we approach the center, you see now we have a scarred area that we just cold avulsion. Like so. Because the tissue is not attached on either side, it all frees up very easily. Then we do snare tip to the avulsion bed, start at the bleeding point. Remember, the blood spreads out like a fan, so treat the bleeding point first and then the rest. And then finally, if you're concerned about deep mural injury, you should be, because this is DMI type 2, then we need to clip that up. So we clip all of that up. So here you see the end result. And then snare tip to the margin. Now this lesion will not recur. The patient can go home same day. And very, very efficient technique. Another example, I'll just speed up through this. Scarring, this is in the proximal ascending colon or cecum. And hard to see the full extent of the lesion. We widely excise. We're not worried about deep mural injury because we're going to close it up. So you have to be aggressive. Patient has to be consented to this process, but and then at the end, some residual adenoma here, so we avulse that, and then snare tip soft coagulation to the avulsion bed, and then the final result, snare tip, and then clip closure of the focal area of DMI type 2. And again, patient home same day. So when we look at the results published in the American Journal, you can see that technical success similar, and recurrence was less in the previously attempted group. And in fact, when we divide it up to recurrence with and without snare tip soft coagulation, you can see that once we do a snare tip soft coagulation to the previously attempted lesions, recurrence is 0. So same as the naive. So before we didn't do it routinely, but more recently we do. So What about deep mural injury? How much time? Oh. So we're just about finished. I might skip over that. I'll just want to finish with a discussion about the anorectal junction. So these lesions can also be done by EMR, but in the rectum, a very important consideration is morphology. If there's bulky disease, then the risk of cancer, covert cancer, which is not expressed on the surface, is significant. We know that the rectum is different to the colon. When we look at this paper that's coming out in GIE, 3,500 cases referred to us. Cancer in the rectum was 15% versus colon 6%, and morphologically different. So granular disease more common, 2A or nodular disease, 1S and 2A plus 1S nodular disease much more common, and cancer odds ratio much more common, nearly twofold. So you see here high-grade dysplasia and advanced pathology much more frequent in the rectum than in the colon. And if you look at a flat lesion, we know that the accuracy for detecting cancer is very good. This is published in CGH by us last year, based on 2,000 lesions. Sensitivity in flat lesions, specificity very good, greater than 90%. But overall, not so good, and especially nodular lesions. So the failure in sensitivity reflects nodular disease. Flat disease, you can tell what's going on. Miscancer in flat disease is around 6 in 1,000. So if we see bulky disease like this anywhere in the rectum, and probably the sigmoid now too, then this needs to be done by ESD, and we do lots of this. So we never do ESD unless we need to, but we definitely do lots of it for these types of lesions. 2 cases every week. The trouble with the distal rectum is it's so vascular. So ESD there, I think, is it's really quite difficult. It's safe, but it's difficult because there's so many blood vessels. So you have to swap the devices out and avoid bleeding. Flat lesion like that doesn't need ESD. This paper will be coming out. A selective resection algorithm optimizes outcomes in the rectum. And you can see that overall there were 56 cancers out of all these rectal lesions. And when we used to do universal EMR, we weren't very good at achieving curative resection. But when we changed to a selective resection algorithm where any nodular disease was treated by ESD, en bloc excision, then en bloc resection was 90%, R0, 85%, 86%, and curative resection, 33%. Most of the people who weren't cured, not because of margins, they weren't cured because they had LVI. And there's a number of different ways to do it. I think for the really bulky disease that, nearly full circumference and extending down, or even more proximally, tunneling is a great option. And it's very fast, particularly if you do palm. It's similar to that, and you can establish a nice plane. The lesion can provide its own traction, and inside the tunnel you can work quickly. And then later in the procedure, as the lesion becomes more floppy, you can apply some traction, move the lesion around, and then you have good tension such that you can work quickly to divide the tissue in the deep submucosa just above the muscle layer. Bearing in mind, there's always lots of vessels, so you often have to stop and swap out your device, or hopefully you don't get too much bleeding. The bleeding certainly compounds your efficiency. And then you see here, I think the end result. Last cut. So huge excision, patient can go home again, same day, local anesthetic, intravenous antibiotics. So we'll probably call it there, and then we can have some discussion. I'm sorry I went a little bit over time, but thank you.
Michael, can you hear me okay? It's Brian
Yeah.
Summers. Hi, Michael.
Hi, how are you doing?
Yeah,
Nice to see you.
amazing tour de force as ever. Just to sort of wind it right back to the beginning, I mean, the majority of people in this audience, and obviously the majority of colonoscopists, are doing cold snaring for the vast majority of lesions. And we're pushing that frontier of cold snaring further and further forward. I wonder, what's your advice for the situation where you're starting to take on a slightly more bulky lesion and you can't cut through the tissue? The snare is actually stuck in the tissue. What's your approach there? Because the beauty of cold snaring is the lack of complication. You don't get delayed bleeding. Perforation is unbelievably rare, but we want to keep it that way. And what do you do if we're pushing the boundaries and the snare is stuck?
Yeah, it's a good question, Brian. Yeah, I mean, we're primarily doing it for flat lesions or those that have a mucosal profile of, say, 3 millimeter, 2-3 millimeter or less. And I think the ones that are sort of, starting to develop a dominant, 1S component, they probably need conventional EMR, at least for the nodular component. I think now that we're all familiar with how we should interrogate the post-EMR defect, that makes it so much safer in terms of the risk of perforation. We need to look carefully. And of course, in the right column, we should always close the defects. All the data shows that now from the 4 randomized trials. And yeah, so I think if you're stuck, that's a bit tricky because I don't think you should change to diathermy at that point. Maybe you need to release the snare. And if it's stuck, drive up the colon, just open the snare fully and drive past the lesion because the snare will come off. And then maybe reassess the situation and inject some dye underneath and maybe consider changing to EMR. Bearing in mind, you don't want to be sure you don't have any muscle drawn up into the nodular component. If it's a flat lesion and you're stuck, of course, you can just amputate against the end of the scope. That's very safe in the colon.
Thanks, Michael. That's a really lovely overview. Sunil Dolwani here. Just a question really that struck me. Do you think we call it cold snare? Most of the demonstration, I would say it might be just as well to call it cold EMR because we're lifting and cutting, whereas with the smaller polyps, quite a lot of cold snaring is without lifting. And if we're talking about safety being essentially quite an important advantage, do you think that is then decreased with the cold snare coagulation once you've done cold snaring for large lesions? Just wondered about your thoughts for that.
What do you mean by cold snare coagulation? Sorry,
when you do snare tip coagulation of the edge after a large cold snaring of a large polyp, do you think that then sort of negates some of the safety aspects of not using diathermy?
I don't think so, but I think we need a randomized trial involving large numbers of snare tip thermal ablation after cold snare versus probably just plain cold snaring. We still don't have all the data in. I think, to the best of my knowledge, no RCT of cold versus hot EMR is yet published for lesions 15 and above. I know there's a couple of studies going on. So we need that data and then we can move on. But probably we know the recurrence is higher, so they've definitely got to have a second procedure. But I suppose on the flip side now, with EMR and snare tip, you can probably send the patients away and come back in a year or 18 months. The only caveat for that is that the 20% of them have coexistent advanced pathology. So they definitely need early surveillance, not a 3-year surveillance. Yeah, so for us, we don't generally inject below 15 millimeter because you can go so quickly. But once it gets bigger, because there's a lot of bleeding, I think it's helpful to inject to see the margins, make the cushion firm, and of course, minimize bleeding if you use dilute adrenaline so that you can follow what you're doing.
That's really interesting. Thank you. I just wondered about our fellow panelist, Dr. Saito's views on the selective EMR versus choosing the modality and how you would approach it as to which lesions you would approach for different modalities, or whether you feel that most of these would be perhaps the efficacy might be better with ESD. Wondered about your thoughts, Dr. Saito.
Yeah,
Ah.
Yutaka.
Hi,
Yutaka.
hi. Yeah, Michael.
Yeah, nice to see you. But Yutaka and I are good friends, so I think he agrees with me 100%.
Oh, I'm sorry. No, not 100%. Yeah. I enjoy the Michael's talk about the selective ESD, EMR, but maybe I'm a little bit curious about the SM invasion rate in the ACE group's study, because the ACE study didn't include surgery cases. So I think there are some selection bias. That's why the incidence of SM invasion is really high in the ACE study. But we recently published our multi-center colorectal ESD studies of 2,000 cases. In the data we published in Digestive Endoscopy recently, the incidence of SM invasion rate, yeah, of course, a little bit higher in the rectum, but even in the right side column from 10% to 20%, even after the pit pattern or JNET evaluation. Therefore, I think, of course, starting the ESD is rectum is the very nice location, but maybe even in the right side column, there are some cases is necessary for en bloc ESD.
Mm.
We've got a microphone going around the audience. I'm sure there are lots of questions. Just put your hands up if anybody with questions. John.
Yeah, Mike, can I just, great talk, by the way, John Anderson here. Mike, can I just ask about sessile serrated lesions? Because I think people are increasingly becoming aware of this. Cold snare is great for it, cold snare piecemeal EMR. But the problem is the dysplasia. And it's one, recognizing the dysplasia, and two, do you switch from hot to cold? And do you just want to give some background to that? And the other thing is, do you see this in Japan as well? I might as well throw it over to you both.
Yeah. Let's ask Yutaka, like not many serrated lesions in Japan.
Yeah. Recently, it's also increasing. We encounter lots of SSL as well.
Oh. Yeah, how much? What percentage of large polyps in the colorectum or colon would be serrated in your data set?
In our data set, the largest cell maybe less than 10%.
Less than 10, yeah. So most of us are around 25%, I think, in the West.
Oh,
but maybe you're becoming more West because of Westernization. You think that SSLs are increasing?
We are eating the beef steak, McDonald's. That's why.
But maybe then, maybe your endoscopy will become more Western.
Oh, yeah, I don't think so.
Maybe not. Maybe not. Yeah, I think the dysplasia, it's a very, very important question, John. And so when you look at every lesion before you remove it, of course, all the panel know this very well, but you must carefully interrogate the lesion. And it's common for us to take 20 to 30 photos. We're not Japanese, but we're trying to be Japanese, you know. So we take a lot of photos and we look carefully. Is it homogeneous? If it's homogeneous, a serrated lesion that's homogeneous, it doesn't have dysplasia. But if you see a disruption to the overall homogeneity, then that is probably a focus of dysplasia, particularly if there's a nodule. There should be no nodule in a serrated lesion. And then you need to look carefully with NBI, and you can see that it's darker, it's nice types 2, and you can see that the pits are different and so on, it's villiform. Well, that can't be removed by cold because it's an advanced lesion and you need the submucosa in the excision. So you need to be careful that it's not a cancer, and then you know, you can go ahead and do it by EMR most probably, but you take the dysplastic focus in one large piece.
So do you then soft tip that SSLD?
Oh yes, we would. I think SSLD should be considered like adenomas, because we know from that excellent study by Mark Bettington published in Gut in 2016 from Brisbane. They looked at all the big pathology service. They looked at all the serrated pathway cancers and all the serrated lesions and all the serrated lesions with dysplasia. And they were able to show that the serrated lesions with dysplasia patients were about 65, and then the others were about 12 to 15 years older. But the patients with serrated lesions with dysplasia and the serrated pathway cancers, they were the same age. So these are, that by inference, these are rapidly progressive lesions and they turn to cancer quickly. So you need to make sure you excise all the lesion and there's no risk of recurrence, and they definitely need scheduled follow-up early, like at 6 months.
Just changing the topic a little bit, Michael. I mean, the issue with the margins of the lesion, you've got a big lesion in the colon. We know the main complication really is recurrence, and we want to minimize that. Hence, your studies on soft tip coagulation of the margins. But I wonder, do you ever, I mean, you could go a step further than that and actually use a knife and cut around the lesion to undermine it and really be absolutely certain of a complete margin at the edge, and then still do a piecemeal excision, which is, I think, is something that we do quite a bit, particularly for larger lesions. What are your thoughts on that?
Yeah, I think, equally that would be a good way to do it, and it would be a good stepping stone to learning colorectal ESD as well. For those in the audience who want to learn, of course, you need to start with smaller lesions. I mean, we just started with this idea in 2012, a little bit on the back of what you'd done, Brian, and with the Brooker study published in 2002 in GIE. But we knew that the snare tip would give us a more homogeneous and predictably deep destruction. And it's of course so easy to do. It's also a good stepping stone for ESD because the movements are very circular. So you learn how to make these movements. But I think you could do it with a knife and take a decent margin. Maybe.
I've got one simple question for both of you. How important?
Can I ask?
Sorry.
Do you go at 5 millimeter, or how far out do you go from the lesion?
Generally about 5 millimeters, yeah. So you've got a healthy margin. But question for both of you, how important is en bloc in the grand scale of things? We've got underwater EMR where we can push the boundaries of size to perform en bloc EMR. We've got ESD. How important is en bloc? Is it something we really should be doing in a large number of cases, or does it really not matter that much for the vast majority of cases?
Yutaka.
For SSL, I think I completely agree with Michael's opinion. SSL without dysplasia, maybe piecemeal or piecemeal cold snare polypectomy would be fine. But for LST, adenomatous lesions, including the adenoma intramucosal cancer, SM1 cancer. So the problem is, even using PIT pattern or magnified NBI, the differential diagnosis between M and SM1 is really challenging. But that's why in Japan, the ESD indication is early colorectal cancer, including intramucosal and SM1. And the tumor size is maybe more than 3 centimeters in diameter. Recently, underwater EMR technique could treat the 2 cm until 3 centimeter LST very effectively. So the LST, especially not homogeneous, LSTG, nodular mixed type, or LST non-granular, larger than 3 centimeter, we never try to do piecemeal EMR. Of course, the incidence of SM invasion or recurrence is very low, maybe 5% or less. But we also experienced some cases of invasive recurrence after piecemeal EMR 20 years ago.
Thank you very much. We've got one very quick question from the audience. Cesare, you wanted to ask something?
Yes, Mike and Yutaka, when excluding the rectum, do you always attempt to close any post-ESD or EMR defect by clipping, or you have a somewhat selective approach?
That's a simple, Michael, please.
Well, we know from the data that like every right colon lesion should be closed. So excluding cold. Cold, you never need to clip, ever. Maybe if someone's on Xarelto or something, but if it's a standard patient not on anticoagulants, you never need to clip. But after hot excision, then every right colon lesion should be closed. The 3 big RCTs, including our own just published in Lancet GastroHep, show the same results. Reduction, it's almost identical from 3 completely independent centers. Reduction of bleeding rate from around 9 to 10% to 3%. But the bleeding risk in the rest of the colon is very low. So in the transverse, it's only 2%. And in the left colon, it's 3 to 4%. And in the rectum, it's 5 or so. So definitely the right colon, but I don't think you need to close the defects elsewhere. I think in the rectum, probably you need to coagulate all the vessels effectively. But most of the lesions you see in the rectum, they're generally large because the small ones are removed by the referrers because they feel safer. And they're often recurrent lesions as well. There's a bias towards sending recurrent lesions because they've been removed elsewhere. And the trouble with the rectum is it's not compliant either. You can't sort of drag large pieces of rectum together because it's relatively fixed. So, but the rest of the colon, so I just say right colon is my answer. Sorry.
In Japan,
Yutaka does everywhere.
Yeah. In Japan, in the right colon, of course, after polypectomy or EMR, we routinely close the defect. But after ESD, the defect is really difficult to close. And also the incidence of delayed bleeding is very low. So we never close. Only when some muscle damage or small perforation occurred, we close such kind of defect. That's it.
Thank you both for a really stimulating discussion and for an excellent first session. We'll bring this to a close. Thanks all very much.
Thanks, everyone.
Thanks a lot, everyone. That was a great session. I think everybody who need to know anything about endoscopic resection in colon should know what you need to do. So now we're going to move on to the next session. We have 2 parallel sessions now. In this main lecture theater, please stay in if you want to watch the live link from Milan and Kent, which will be a HPB session and a colonic SSD. And in the next room, right next to us, it's a session on diathermy. All you need to know about diathermy and endoscopic clipping. So within 5 minutes, we'll resume both these sessions. So take a quick break and be back with us in 5 minutes, please. Thank you.
Like busy that there wasn't much time for kind of
No.
checking these things.
Never mind. It's,
Yeah,
I mean, it's,
okay.
the presentation
So
itself
you
is
won't be
pretty.
able to, you'll have to ask someone to move the slides on is the only thing.
Okay, so this one is.
So this is screen sharing on Zoom from that laptop.
Ah, okay,
Yeah.
okay. So I can't control the video then.
If we can get a wireless mouse for you, then we can.
Because it's.
Yes. Yeah, that's it. No.
Well, that's for this computer or not. There's definitely a mouse in it.
You have one supply. You also have we will promote thank you. Okay, yeah, we will come to you with everybody. He said we go. So I'll go and you guys yeah, we have a big event for IT. I think they have all the for
lentamente en una vez en la cabeza.
I know that we lost some of our audience to the diathermy session, but we're going to start again. We have a live link with Milan as well as with Kent. What we'll do is we have, can we get our panelists here, please? I think Manu, you joining us through virtual link. We can see you. Nice. Thanks, Manu, for joining us.
Good morning, Pradeep.
Morning. Thanks a lot for joining us. Andres is here. Thank you. And Eduardo is here. So we're going to get going. Looks like Milan is all set and ready. So good morning, Milan. Thank you for joining us. Can we put Milan full screen live, please?
Good morning.
So Ale and team, if you could tell us the case and then we get going.
Yeah, thank you. Thank you. Welcome back. So happy to broadcast from Milano today. And as you can see, I have my team all here. It's a prevalently female team. Here, Roberta, she is the operator. She takes care of the patients. Giusy, my nurse. Marta, my fellow, and Alessandra, my anesthesiologist. So I'm very well surrounded. And we're proposing today a case of a Zenker diverticulum in patients with symptoms since a couple of years. He have been diagnosed about 1 year ago. He was proposed either endoscopic treatment or surgical treatment. It took some time to make a decision, and afterwards he was referred to us. So typically these patients, they come to us, they have a lot of symptoms. And what we do normally is a diagnostic approach. We just perform esophageal series. We take a couple of pictures at the level of the cricopharynx just to identify the pouch, to estimate the size. And afterwards, we go straight forward to endoscopic treatment. So I'm so glad that Roberta can perform this procedure. She has done so many in our unit, and I know she will do a great job with the patient. So Roberta, stage is yours.
Good morning also from my side. I show you the case. This is a 77 years old, and Ale already told you about his history. What I've already done, I hope you can see the images of my screen. I already placed an orogastric tube. You know, you have different ways in which you can treat endoscopically the Zenker diverticulum. So today I'm going to show you the so-called POES, per-oral endoscopic sectotomy, because if you see here, if you watch here, we have nice pouch, but the septum that is dividing the esophagus from the pouch is not so long, is let me say around 2 centimeters or less than 2 centimeters. And this is why we propose, and we are going to do a third space approach. That means that I will inject, I'm already inside with my needle knife, with my needle. I will inject on the septum, and from this point of view, injecting the submucosa, I will cut the submucosa longitudinally alongside the septum, and I will enter in the third space to face the muscle that later on I will fiber by fiber cut. So the orogastric tube is crucial to always remember between these two, let me say, holes that we have, which one is the esophagus and which one is the pouch, just to remember the anatomy and not to get lost during your procedure. So we start injecting, needle out please, and we'll inject, as I was saying, directly on the septum, okay? Go, more, go, 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 stop. I will inject a little bit on the other side, okay? Go. Good. Okay, I'm happy with this, and we'll shift to the hook knife. That for this type of procedure is very nice because allows you to really grasp the fibers and to nicely and precisely cut exactly wherever you are.
Hi, Roberta. This is
Here with Roberta.
Hi,
The
Alessandro.
amount of injection is it's very minimal, so we are not injecting too much. We don't want to create a big submucosal cushion. It's just to create the condition to make the mucosal incision and expose the submucosa.
Alessandro, do you hear us?
Yeah, sure.
Okay. So I was wondering, do you ever think about placing the Cook diverticulum, the overtube?
No, you know, I learned the technique from Paolo Sagai in Sao Paulo. So I went there to understand how to do this about 20 years ago. So they were using just this cup-assisted technique. So they never use the Zenk device. So I never did this. So, and you know, when you are familiar with a specific approach, things goes well. So it's very difficult to change your practice. I know this is an option, but of course, we need to recognize that it's not easy to place, and also sometimes with a small size diverticulum like this, can be also challenging to have in the proper position. This is why we normally use for 100% of our patients. We do about 2 to 3 patients per week on a regular basis. So we do about 100 patients per year since many years now, and we have done all of this just using the standard cap-assisted technique. But we have changes over time that we moved from traditional septotomy to this third space procedure for diverticulum of relatively small size. You see, you can nicely identify the muscle, the muscular septum, and afterwards you can work all around, create the space for the incision afterwards.
Okay.
Okay. So you see, she's taking care of creating nice space and submucosa to work with. Okay. Some little minor bleeding may happen over the procedures. They are not disturbing too much.
Hi, Alessandro, Roberta. I'm Eduardo from Spain.
Hola, Eduardo.
Hola. I agree with you. I feel that a free technique is the best one. So just a cap is enough. And even I don't use the nasogastric tube because the space is so narrow. So for me, I try to have all the free space that I have. So once you are in place, you have all the time the diverticulum in your left side and the esophageal lumen on the right side. So I believe that you are not getting lost in any situation, Roberta. So.
No, it's a good point. You know, again, we have this tradition. We put the nasogastric tube. What makes me feel safe, especially when sometimes it may happen, very rarely, but we had a couple of very torrential bleeding, and having the nasogastric tube in place has been extremely helpful to us. So I understand you can easily do without any nasogastric tube, but we feel a little bit safer. We remove it just afterwards, so the patients get out of the room without any tube.
So, Ale, can I ask you a very quick point? Very interesting observation.
You're the course director, so you can ask whatever you want.
Thank you. That privilege should be maintained forever.
Okay.
What I'm watching here is Roberta is cutting the septum as well as dissecting both at the same time. Not tunneling and making space, isolating, and then cutting.
No, it's a very small septum. Yeah, it's very small septum, so you may not need this. And the question is how long you cut. Normally we cut until we see that the muscle become as thin as the regular esophageal muscle. You see, still it's a little bit thick. And Roberta is doing a great job because he's carefully watching a single vessel. You see, sometimes she's coagulating rather than just cutting using endocut. So probably how we can show the setting of the herb machine. So the cameraman can turn the camera in front of the herb machine, please. Devi togliere il respiratore, devi spostare il respiratore. Okay. So we almost done. Probably Roberta, the last few fibers.
Ale, also, can you comment about the knife? Why hook knife? Is there any special advantage?
Because we like to hook sometimes. Okay. When you are in trouble, you can hook fibers easily.
Yeah. That's very, very beautifully demonstrated. So we can see your setting.
Okay. Okay. Now Ale, sei in fronte alla camera, grazie. Sei molto carina, ma just in front of the camera. Don't worry. Just Ale, un secondo. Ale. Keep calm, Ale. Okay. You know the anesthesiologists, even though they are female, they are sometimes confusing. So, can you see the setting of our camera?
Yes.
Through the camera, you see the setting of the device.
Very good. Yeah, we can see endocut eye, effect 1
Yeah.
and force coag 4.
Yeah. So and now I think Roberta is going to close the hall.
I'm
So,
happy
Roberta.
with it. I would like just to close my entrance. I will show you again. I don't want to inflate too much in this third space, but here we are at the end of my myotomy. On the right side is the esophageal side. On the left one is the, let me say, outside side. So I will close the gap.
So differently from the technique has been shown yesterday by Amit Maideo from India, we do not make the incision above the Zenker, but we make the incision just alongside the septum. Probably this may be a little bit easier in the final step when you want to close. So you nicely see what you have to close, and there are no main problems with the space, because in the cricopharynx you have a very limited anatomical space and may be a problem.
That's very good. Roberta is controlling the clip herself very nicely. While Roberta is closing that, can you tell us your management plan for this patient? Are you going to do a swallow, a contrast?
No. We do all of this every day as outpatients, so they will stay with us until 6 o'clock. So we normally, except today for this live procedure, we do as a first procedure, first one or first two procedures, and they are kept in the endoscopy unit for about 6 to 8 hours. Over afternoon time, if everything is okay, we double check vital signs, and also we look to the neck to see if there are any sign of crepitus or sign of free area, free bubbles. If there is nothing, we ask the patients to drink a clear fluid at 6, 7 o'clock, and they can keep drinking a little bit of clear fluids overnight. The day after, they can start eating a softer diet, and that's it. We don't give any antibiotic prophylaxis. We don't care too much.
No contrast swallow? No need to do a contrast swallow?
Zero.
Oh, wow.
I think we have done more than probably 700, 800 up to now in the last 10 years. And this is a practice that we have now. So all patients that are coming, the oldest that we have done is 102 years. The youngest is 39. And we treat basically all in the same manner, except that those patients who are extremely sick, or they have appendicitis pneumonia, they have serious medical condition, we hospitalize them, but according to our data, 93% of our patients are done in an outpatient setting.
That's
Alessandro Manonaya from Newcastle. It's in your experience, what is the risk of bleeding and perforation in your series?
So I would say over 500 patients prospectively followed. We had just one case of leak that required surgery, but it was just surgery to treat the abscess into the neck, but wasn't a main surgery. We got 2 cases of delayed bleeding. I would say minor bleeding, just requiring hospital readmission, but no blood transfusion. And of course, as you know very well, half of these patients are very old. They take a lot of anticoagulants. So we use the standard protocol recommended by the European Society of Gastroenterology and Endoscopy for withdrawal of anticoagulants of the therapy, and they start after 24 hours.
Thank you.
Overall, you see, it's about in expert hands, it's about 10-minute procedures and nothing else. Of course, Roberta is super good, but probably my hands will be a little bit longer, but no more than that.
Beautiful demonstration.
I was going to say, this is a super fast demonstration. This is what you get if you have all women's team. So I think most of us should look at our teams and go that way. This is the future.
We have the privilege of having such a beautiful team. Yeah.
Thank you, Ale. Any quick question before we go to Kent?
Roberta, congratulations for the quick procedure. I'm very clean. So don't you think that very few patients have symptoms after the septotomy due to the pouch persistence, because there is a mucosal persistence and a small pouch? So do you feel that it's a good idea also to cut a little the mucosa in the middle of the septum and to flatten as much as possible the diverticulum? What do you think about this?
Yeah, you know, this is exactly the reason why we chose and Ale thought about this POS just for short septum diverticulum. Otherwise, you're totally right. You can leave some mucosa there that create a sort of step, and the patient still have symptoms, although the muscle is not there because you already cut it. So according to us, you should really target the patient, and the indication of this third space myotomy for diverticulum should be only for short septum. Otherwise, you will go directly for full standard septotomy. I mean, you will cut mucosa, submucosa, and muscle. So no ways to make this a little bit more difficult approach.
Thank you very much. I think that was super good demonstration, guys. We'll join you again later on.
Thank you.
Yeah, ciao.
Bye-bye.
Bye-bye. We ready to move to Kent now, where Zach and his team are patiently waiting. Can we get Zach live on the screen, please? Good morning, Kent. Are you live with us?
Yeah, good morning, everybody. Good morning to all the audience. Thank you once more for the kind invitation. I'm sorry I missed the dinner last night, but I had to come back so we can actually run the live case. I can see there's no pressure at all. Thank you for doing that. It was great, great schedule. I have to say, as you can see, I've been surrounded by surgeons. You know, if we had somebody who would tell me that I would do this kind of procedures after 5 years ago, I wouldn't believe that. So I want very briefly to introduce the team. On my left-hand side is Mr. Joseph Sebastian, the colorectal surgeon. He's going to actually commentate with me during the procedure. On the right-hand side is another surgeon, Mr. Zaidan Shadi. He's actually also the advanced fellow for the complex polyp service. And there's also the anesthetist Manjoy and his team as well, Manoj, sorry. And also the rest of the endoscopy nurses, which are quite a few, I would say, here. So we're going to Shadi to actually play the slides for the patient, and then we can actually ready to start.
Thank you, Zach.
Good morning, everybody. So we're presenting to you a case of speedboard submucosal dissection. We're also using a gel condenser platform to help with the process. So this lady is 84 years old. She came to us through the symptomatic pathway with change in bowel habit and mucus from the rectum. As you can see, she's got some past medical history, including AF. This is her diagnostic colonoscopy, and it's been described as a mid-rectal polyp, about 3 to 4 centimeters large polyp. So we've discussed right now complex polyp MDM, and we thought that the best way forward is to offer her a speedboard dissection. She was actually booked for a dissection a few weeks ago, and this is the reassessment on the day. However, she ran into AF at the time, and it was meant to be safer for her to wait and treat the fast AF and control it before we proceed. And then she went to cardiology, and now we're back after we controlled her AF to get the procedure done. We think this polyp is maybe about 60 to 80 millimeters in size, and lateral spreading non-granular. It sits about in the mid-rectum. It's mostly on the lateral wall. It's actually the right lateral wall. Most of the polyp when I was examining them before the case. And we already inserted the gel point and used the air seal as a way to control the pressure inside and have a stable environment for the dissection. I'll hand back to Zach to proceed with the procedure.
All right, so we'll let lights off, please. So I will just show you, I don't know, can you see the screen, Pradeep?
Thank you.
Can you see the screen?
Can we go? Yes. Okay, we can now.
So I'm just here. This is the oral margin, the proximal side. I'm just giving an idea of the size of the polyp. As Shadi said, there's a biopsy was taken there. I don't know, but yes. And as you can see, if you go around, it's actually mid-rectum. It's quite large. Yeah, I think it's semi-circumferential. I'm trying to follow the margins. And then we actually go down to the most oral side of the polyp, so the most anal side, sorry, the distal part. It looks very benign to me, and that's why we didn't, on the MDM, we didn't ask for any kind of scanning, like MRI. We did assess with NBI, we did assess with a PET pattern, with a endoscopy, and I will just start now, make a start. I will ask my colleague, Mr. Sebastian, to give you an idea about the air seal and the A taser that I did describe yesterday.
Yeah, thanks, Zach. Can you hear me?
Yes.
Yeah. So I think what Zach, he's given you a fantastic lecture, obviously, yesterday about this A taser concept. And essentially, he's bringing a surgical platform to endoscopy, isn't it, Zach? You would agree?
Absolutely,
So
yes.
the gel point is a device very commonly used by surgeons for TAMIS, for example. And over the years, we've incorporated that into, I mean, when we started off, we didn't, we didn't use these kind of devices, but then we've incorporated that quite regularly, especially for rectal and left colon ESDs. And besides the gel point port, we're also using air seal. Air seal is, again, a device used in laparoscopic surgery to maintain constant, pneumoperitoneum. And we, one day we had a brainstorming moment, and we thought, why not use it for rectal SSDs, isn't it? And it turned out to be a
yes, and I think
success.
and I think it's not only for the rectum. We have done cases.
We've used it for other,
yes, for sigmoid and descending lesions, absolutely. So thank you, Joseph. So we're trying to do the first injection orally to do the very nice dissection. Stop. As you can see, I'm using the normal injection catheter because I believe when I use a bit more colloidal solutions, like this is a it's a gelofuscin with a mixture of carboxymethyl cellulose, which is like the tears, and this is really viscous. So I'm trying to use that just for the mucosal injection. And then during the submucosal dissection, I'm actually using the speedboat inject device. Stop. I don't know, Pradeep, do you usually mark out these lesions? Because we don't. We use only, actually, you see very nicely, it's demarcated here.
I think after injection, the boundaries, margins are so well delineated that I'm not sure what else you're going to get with the marking. But in tricky situations, it's always good because marking gives you a sense of direction when you can't see the margins, but otherwise not routinely. So I see you're going to start your incision on the oral side first and open up the mucosa there.
Absolutely, that's
okay. So our audience are desperately waiting to see when this speedboat is going to come out of the garage and start sailing. So can you please bring the speedboat out?
Now, yes, now do that. Okay, give me the speedboat, please. This lesion we have estimated is roughly between 8 centimeters by 4 by 5. So that gives us a roughly about 60 square meters centimeters.
Yeah.
So we actually think that we possibly remove that within the next 2 or 3 hours.
Excellent.
If you have a speed of about 10 centimeters, 10 square meter per hour. Okay. Bleed here.
Zach, sorry.
Hi, Eduardo.
About how are you doing? About the technique, how much space are you gonna open in the oral side? Just a small space for the tunnel, or you try to open all the oral side from left to right? Which is your strategy?
I'm going to use actually quite large, quite extended.
Okay.
I'm trying to use usually between 10 o'clock to 2 o'clock. So it's quite wide open, right up.
This is very good demonstration of how the speedboat is cutting so smooth, clean margins. Only thing I'm thinking about, Zach, is that you pointing the knife straight towards the muscle. The normal principle of ESD is we keep our knife parallel to the muscle. Your muscle is at 90 degrees straight, straight in front of your knife. But you are happy because you got a big lift. Is that why you're happy to do like that?
One is a big lift, and the other one is because it's advanced bipole energy, buddy. So it's very controlled. You see, it actually goes exactly on the point of contact.
Yeah.
So it is not being transmitted right up.
Very nicely demonstrated. Zach, we are running a bit late, so we might have to come back to you intermittently to catch up with your progress. But can you just briefly talk me through your plan? So you're doing a mucosal incision on the far side. Once you've done that, you will move to the anal side and start tunneling?
Yes. So we are actually trying to complete you see that's the proximal incision.
Yeah.
We try to go a bit deeper and more extensively to the right and to the left until we see up to here.
Yeah.
And then when we do that, then we just come on the most distal side here, and we do a smaller gate from this side, and try to do from here, from let's say about 7 o'clock to 5 o'clock to the tunneling, and try to do big tunnel. So you can go follow this all the way to the this side, maybe not or to open the tunnel, but then when we open the tunnel, we isolate the margins from the right hand side, from this side, and then we go to the left hand side.
Yeah.
And then we're trying to use the in to out approach from the inside out. So from the tunnel, we go from the tunnel out.
Yeah, brilliant. That's excellent. Thank you very much, Zach, and we will join you shortly again to catch up with your progress. Bye for now. Thank you.
Thank you.
Thank you.
Thanks a lot. Could we move to the next session and invite our panelists for the next session, please? That is... So we're going to have a colorectal MDT now, which will be case-based discussion. So Eduardo is already in chair. Brian is
Back to
around. So
normality.
Brian, please wake up, Brian. Please. Can we get a coffee for Brian, please? And then our surgical colleague, Mr. Khan, was supposed to be joining us. Do you know if Jim Khan is here? Anybody seen Jim?
I'm here, Pradeep. Thank you.
Oh, Jim, you are virtual?
I was told to be virtual, but
God, even, can you? Oh, sorry, guys. I unmuted myself. Can you mute me? Yeah, thank you. This is a strange world, Jim. Even my local host who works here with me is joining me virtually. This is unbelievable.
This is the post-COVID new NHS for you.
Okay, thanks, Jim, that you could join. So the plan is we will present a series of cases and we can stop and have discussion as we go along. And you can give your opinion where you disagree if the endoscopic approach was right or wrong and what else you would do. Okay, you don't have to disagree just because you're surgeon, Jim, though. Please remember that. Okay, who's going to present? Yeah, yeah. So.
Oh. So we are muted now, right?
Sorry?
Mute.
I think so.
Can somebody come over here and bring the talks up, please?
We're mute, right? Are we on mute? Yeah.
Okay, yeah, because we're going to have some polling during the session. So please, oh, there's no scan. I thought there was a QR code, but maybe go to this website, slido.com. We used that yesterday as well, and put in this code so that you can answer. So even the virtual audience, you know, the 400 people out there, please go to slido.com and put this code. You can then join us for the polls from home. Make sure you do that. Do you want to carry on? I think let me close this chat box. I don't know. No. Yeah. There's so many things open. Can you?
So I'll stop sharing and then
Okay, that's the QR code. If you don't want to go to the slides website, use this QR code with your phone so that you are in there. And please, because we really want to know your opinion. Do you want to just take a chair and sit down? Yes. Okay. Yes.
I'll just present it from here, right?
Yeah.
Yeah. And sharing. Okay. This is the first case.
You're going to present the history bit before we start the video?
So we've got case one, who's a 34-year-old female who's got pan-ulcerative colitis, who was diagnosed at the age of 12. She's also got primary.
Hang on a second.
Oh, we're
Yeah,
not on.
we are now.
Oh, okay, okay. Yeah. So starting again. So our first case is a 34-year-old female who has pan-ulcerative colitis, which was diagnosed at the age of 12. She also has primary sclerosing cholangitis and autoimmune overlap. A colonoscopy was performed for surveillance. There was possible low-grade dysplasia seen on right colonic mapping biopsies, no visible lesion, and she was referred for an assessment.
Can you stop there for a second before we move on? Brian, how frequent is this in your experience that you get colitis patient after surveillance being sent to say they didn't see anything, but biopsy showed dysplasia?
Yeah, I mean, we do see that. Usually people nowadays do see a lesion, biopsy, and then refer on. And of course, the key thing with any referral is not to affect the field of view and not to over biopsy or to affect the lesion itself. So that's absolutely crucial, particularly when it's a flat lesion where you get submucosal scarring. I mean, this patient has got all the risk factors for colorectal cancer on a background of UC, early age of onset, pancolitis, primary sclerosing cholangitis. And now we've got
don't bias the audience as to what you think should happen, please. We want to have the poll from the audience.
I would say, compared to 10 years ago, less so just a straight referral where dysplasia was found in a biopsy, not that frequently now.
Exactly. Yeah. Multiple centers around us. So you can play the video now, please. So I think we can see a polyp. Obviously, this wasn't seen. It is flat. It depends on how the bowel prep was, what kind of endoscope they were using, who was the endoscopist. I'm not going to blame weekend endoscopy here. No, without chroma. Very good illustration with TXI. So what's your thought process here, guys?
I mean, so you've got we're not sure where, we are sure where we are in the colon because you've got the scope guide imager there. So we're actually in the right colon.
Yes, you're right.
Unless it's a very big loop, Pradeep. Is this one of your very big loops?
I can make very big loops, but this is a beautiful loop if I made a loop like that.
So we've got a lesion which is roughly half the circumference of the bowel wall. So it's at least 4 centimeters in size, possibly 5. It's a Paris 2A lesion.
Yeah.
It looks as though it might have a non-granular component to the top of the lesion. So it's probably a mixed granular, non-granular LSL.
And do you want to see anything more now at this stage?
I'd like you to clean the lens.
Clean the
I'd very
lens.
much like to do that.
Okay. Anything other than cleaning the lens?
Yeah, so we need to interrogate it with narrowband imaging or blue light imaging. This is actually, you've got the 1500 series here, have you? The new Olympus. So you've got TXR.
It's Portsmouth, doesn't mean we can't afford that. Just don't be so opinionated.
And I'd like to have a look at that NBI, and it's really important to look at the whole of the lesion, particularly that bit up at the top, which is slightly out of focus.
Sure. Anything in particular, Eduardo, you want to see in this, apart from what Brian said, is that assessment of the surface?
Apart from this, is to make a good, complete colonoscopy to assure that there is
Rest
not
of the colon.
another missed lesion.
Yeah.
And I want to see, of course, the top nodule of
the, on
detail.
Adolfo, you want to make a point?
Yes. Also, so you were doing this procedure because they had found they detected dysplasia with no obvious lesions, but you selected the scope with no zoom. You rely on the virtual chromoendoscopy with no zoom for this.
We'll come to that, Eduardo. I think that's a very good point. Once you get habituated to using Zoom, you become dependent on Zoom. Like how we become dependent on scope guide. When you take the scope guide away, you feel a little bit vulnerable. I don't think Zoom is that crucial in detecting. When it comes to assessment, it will become important. So we'll see. Can you move on to the next clip? Yes, sorry.
Why are we so confident that the biopsy on non-visible mucosa was done on this lesion? Maybe this patient has this lesion and then have non-visible low-grade dysplasia.
Very, very good point. Cesare is finally woken up. The coffee is kicked in. That's why I think Eduardo made a very important point that before you talk about this lesion, what about the rest of the colon? So we've done a very good job, Cesare. Believe we do a good job. So we are sure there's nothing else. Just show this lesion, otherwise we'll be here till evening. So that's what Brian was questioning, that surface. Carry on. Don't need to pause it now. It's okay.
Sorry, I'll get it back.
So I think that video was going to show NBI delineation of the margins, which I think we rapidly rushed through. So what we're doing now is just play video. Yeah, and don't touch anything now, please. Take your hand off. What we're doing now is using NBI to perform careful assessment. I did say don't touch.
She touched it. That was me. I did not touch it.
We tried to copy Rapichi's message of having all female team, but please don't touch. In my mind, what Brian said was very important to assess the surface of it. But the even more crucial thing for me was that can I see the margins and delineate confidently or not? So this is what we're doing now, is trying to see if we can see the exact margins or we are struggling with the margins.
The other quite important point here is that the background mucosa looks relatively normal.
Yes.
Without much in the way of inflammation.
Yeah.
And of course, this is a characteristic feature of PSC. The cancer risk is high, but actually often the amount of colitis is relatively minor.
That's very interesting.
And that needs to be taken into account as well. But it's you're getting a nice delineation of the lesion now.
Exactly. So that was the crucial thing in the decision-making process was A, the background mucosa, is it inflamed? Then we know we will be struggling. And B, can I see the margins or not? Eduardo, you happy with the margins or you're not happy?
Really happy.
Yeah. Well, I think Adolfo is not very happy. He's pushed himself back. There's no Zoom. He doesn't want to engage anymore.
I'm happy with the margins. Only was wondering if you would use additionally indigo or not in this situation.
Yeah, we can. I mean, again, I would personally say old-fashioned dinosaurs like us get dependent on indigo. Where even when we can see everything, we still want to put the blue dye. It just gives that psychological satisfaction. I personally don't think it adds anymore with these modern endoscopes. But there's no it doesn't do any harm. It gives you more confidence. Yeah. So are we going to have a poll? So don't bias the poll.
I'm not biased. Just a point, a teaching point. If you're going to do surveillance in IBD, you need to schedule them to have long enough to do dye spray. If you're not doing dye spray, you shouldn't be doing surveillance. It's inappropriate. And I have to say, it's easy sitting in the audience when they've frozen the image. But if you've dye sprayed this colon and the bowel prep is good, you'd have to be a blind man on a very dark night not to see that lesion.
So you have to leave the use.
Okay, you got to use it though. Yeah, you got to use it. You can't just say, well, there might be something out. I'll press the button now.
Can you hold, please?
So we've seen the lesion.
Sorry, yeah, to make a comment because the problem with electronic chromendoscopy is that there is no protocol on how to do it. This is, we created this video for the scenic that shows that you go to the cecum, you begin in the anti-gravitational side and you spray the dye and then you go back and forth in a small segments, but we don't have any learning resource on how to do electronic chromendoscopy in a protocol fashion in these patients. I think that's what's missing here. I know. I don't know how many.
So in the chat, I can see people are putting their answers. We would really welcome you to go to slido.com and poll there. Please don't share your answers here. So can we see the poll results of what people, keeping in mind that what Brian highlighted, the patient's background. So, okay, let's have a look. Wow. This is the ESD biased meeting. So there's a massive selection bias here. But Brian, do you want to comment on that?
Yeah, I mean, it's a mean question because, of course, what would happen in reality is that at that point you would back off. You might take some additional biopsies if there are any areas of concern. You'd certainly take your background biopsies from the rest of the colon to make sure there's no invisible dysplasia. And then you'd sit down and you'd have a very frank discussion with the patient. The long-term cancer risk for this patient is really very significant. The lesion does look endoscopically resectable, so it's technically feasible to do it. I think if you were going to do it, you would want a complete excision of it en bloc. So I would push towards ESD for if the patient decided they wanted a local excision. But the question is, should you do it? And that's the tricky one, because long term, this colon is going to be quite difficult to survey. It means for the patient a lot of endoscopies, very frequent bowel preparations. I actually think a limited resection, you haven't put it in here as an option, but an ileorectal anastomosis, if the rectum was extremely well preserved, might be another option. Because that's, you do want to know, has the patient had a family? Do they have plans to, have a family? That seems very important in terms of surgery. So there are all sorts of things that need to be taken into consideration here before you can just simply come down on one side or the other.
I agree completely. Eduardo, what's the view from Spain?
No, the view is that this kind of lesions, even that when the appearance is quite benign, they have at least high-grade dysplasia. Yeah. So now there is a worldwide Delphi ongoing, led by the Netherlands. So when almost all people are agreed that this kind of lesions needs an en bloc resection, and if I was the patient, I wanted to be my colon at least my left, my half colon.
You want to keep your left colon at least.
Yeah. So it's true that the metachronous lesions are very high, but I don't know if you live without going to the bathroom only 3 times a day instead of 7 or 8 a day.
That's very, very important
for
point.
many years.
I agree.
I think that is important to see also the perspective of the patient.
The quality of life is very important. Do you want to make a quick point, Adolfo?
Yeah, so of course, what Brian said is very important to discuss it frankly with the patients, because we may tend to want to do an en bloc resection and think about the lesion itself, but it's the whole colon and the patient what we have to think about. And there's a high risk of other metacronous lesions. The patients will need a repeat colonoscopies, and they need to know exactly the lifetime risk of cancer if the bowel remains situ or not. So I think it's very important.
I had a very frank discussion and long discussion. She's a young woman with PSC. It's a huge undertaking to do endoscopic resection. It is the way you put the information to patients. It's very, very important. If you give any sensible person an option of preserving their colon, avoiding these kind of drastic surgery, no sensible person in the world will say, take my colon out. So yes, we all say need to talk to the patient, but talking to the patients is very biased, whichever way you put it. Either you say there's no chance of doing endoscopic resection here, then there's no question. But if you offer an option, no patient says, take my bowel out. So it is a very difficult one to have that discussion and how to balance that. I personally feel most of us have a preconceived bias in our head before we go into that discussion of which way we're going to lead that patient. Do you agree?
I do agree. So interestingly, we discussed at our place having a trained nurse, trained by a surgeon and a physician, given the balanced debate to the patient, not the clinician, because the clinician is, I think, is biased. The point I wanted to make is, before, you're right, Brian, you have the discussion with the patient, but let me just put another scenario to you. You decide you go for an en bloc resection. Why are you doing that? In case it's cancer, you get a complete resection. Have you put to the patient, if there's cancer in the specimen, what they want to do next? Right? Because if they're going to have an operation anyway, it doesn't really matter how you take the polyp.
That is taking it too far. There might be 15% chance, 20% chance. So I'll say to the patient that 80% chance your bowel will be preserved. So you're not swaying me that way. I still want 80% chance of preserving my bowel.
Okay, but I'm talking about the technical approach of doing an ESD in the right colon, right? So it's worthy of discussion, because if the outcome is going to result in the same if it's cancer, the technique you take it off is irrelevant.
Yeah, and the risk related to it
is significantly different.
Risk. I think we'll carry on discussing more. I know. There's a lot of questions, guys. I'm really sorry. Quick. Yes, Sam, but the things are changing in the world. Things are changing. I'm not completely convinced. I came from the same thought process. We now have a huge cohort of patients that we've been following for 15 years. They haven't lost their bowel yet. So I know what you're talking about, all this, but the things are very different with how we are skilled, how we train, what kit we have. I think we can see a lot of things. So not necessary that every single person in this situation will lose the bowel. So can we carry on? Otherwise, we'll be here till evening and nothing else will happen. Well, obviously, there was a bias in this clinician's mind, but they are very vascular. That's another issue about this bowel is very vascular. So this technology is really good. RDI helps you. I do a lot of now full resections under RDI. It just makes me calm. It's just so nice to do that. The next challenge in these colons is fat. They're vascular. They have a lot of fat and they have a lot of fibrosis. So what John was highlighting is it's not about the risk of cancer. It's about the challenges we're going to face and what harm we can do in the process of this. That is very, very important. But you see how we use one side using the gravity and done the easy bit. Didn't realize the difficult bit where it's now prolapsing is becoming, the access is becoming difficult on that side. So we turn the position around. So remember, this is not Europe where we have free-flowing propofol. Anybody coming in the unit gets propofol. Here we still do a lot of this work under conscious sedation. So you can see the big vessels in there and underwater, while we use saline, immersing in saline
highlights these very, very thin plane that you see. Otherwise, it becomes really, really difficult to find the right planes. So keep going. So finally, we get out of the water again.
A quick question. What do you do when you have such amount of fat?
Yeah.
Are you using, for example, the lumen to exchange a lot of times the endoscope, or?
Yeah, well, the lens does get coated with fat. Two things. One is I change my dissection current from coagulation current to cutting current. That comes with the increased risk of bleeding. And that's why this RDI is very helpful. You can observe your vessels and use it only when you're sure. But otherwise, if you use any of the coagulation current, fat is melting, sticking to the cap. It's very, very frustrating.
Do you increase the power of the settings?
Yes, absolutely. So what's the histology? Now is the crucial bit.
So the ESD was carried out and the histology showed a tubular-villous adenoma with low-grade dysplasia, R0 resection. What next?
There is a higher risk of cancer in these patients, we know, even when we can't see. But I think sometimes these things do cloud our opinion base. There is a high risk of cancer in these specimens, but still you can see that looks a little bit suspicious, but everything is low grade. And it's R0 resection, Brian. What are you going to do now?
Yeah, I mean, the most important thing to do here is not to get too carried away with your success, because it can come up and bite you at any time. But no, the point is to get it across the patient. They all feel amazingly relieved. They'll be very thankful. They'll think this is great. They want to go off and start living their life and enjoying their life. But they need to be aware that they must comply with surveillance and quite active surveillance after that.
That is the main point. Was this is a decision that has to be made before you do the resection. This is a very educated, clever woman who's very conscious about her own health. And if you don't sense that, then this is the wrong way to go. So it is a huge undertaking for the clinician as well as for the patient. And if both of them are happy, then this is a good partnership.
At St. Mark's, we have one of the highest post-colonoscopy colorectal cancer rates in the country because we have 600 of these patients on surveillance. And no matter what you do, however careful you are, you will get small submucosally invasive cancers occurring. And the patients need to be very, very aware of that.
I agree, Brian, but because if we do something wrong, doesn't mean we do another thing wrong. We need to sort out our surveillance program rather than do anything. Sorry. Do you want to set a pause there?
No.
Sorry, Pradeep. I'm just raising a point that has to be considered as well with these patients with colitis is how their overall condition is being managed over time. There's going to be a spectrum of some patients who have very minimal symptoms and are well controlled with minimal medication. Other people are onto their third biologic and struggling to maintain any quality of life at all. And I think that does need to be recognised in terms of if you're just onto your third biologic and likely to lose activity within the next 6 months, you're not going to be doing them any favors by going ahead with this kind of approach.
Okay, I think we got to move on to the next case quickly first. So what's the case?
So we've got a 70-year-old male who came in for a colonoscopy for a change in bowel habit. He has a past history of cardiac stents and is on aspirin.
This is a very surgical history.
That's because I wrote the slides.
Oh, yeah, my fellow is a surgeon, so I agree. That's very good. I like it. Yes, let's move on to the key thing.
I thought we were going to see an ECG for a minute there.
Definitely not.
So we are in the cecum. This is a polyp, which is, you can't find the appendix. The polyp is in the cecum involving the appendix somewhere within or there. So that's the cecal, the appendicular orifice. There a bit of adenoma around, and it's almost going in inside the appendicular lumen. So we had an excellent talk from Michael. Eduardo, what are you thinking?
I need to see better the orificial. The orifice. So maybe with water, you know.
Yeah, put water.
Yeah.
And see better. Yeah, I agree. We go underwater, cap, all kinds of things. Is there a poll? Do you want to ask the audience quickly?
I mean, it's also the relationship to the ileocecal valve. That's important.
Yeah, no, it's clear from ileocecal valve. So it's purely within the cecal pole involving the appendicular orifice. Okay. So can you please poll what you're going to do? Maybe for convenience sake, guys, you don't have to go into this presentation mode. You can keep your slide mode.
Yeah.
Then you'll know what's going on.
Yeah, 'cause
Don't keep changing.
You want to poll if it's not in.
Yeah. Dr. Anderson finally woken up to poll. I think as people are polling, we can ask our expert panel as to how they're going to deal with that. The problem is we have a very biased panel as well. So I can see how they will be thinking here. So Brian, what are you thinking?
Well, I mean, assuming you've had a really good look at it and it's completely obscuring the appendix orifice,
Yeah.
you don't know how far into the appendix it's going. The average appendix is between 5 and 10 centimeters in length. So, you know, it could be going an awfully long way down there, and you do want to resect the whole thing. So the looking at the lesion, as we did with narrowband imaging, it was a granular LSL. There didn't appear to be any high-risk features for cancer. Yeah. I probably would get cross-sectional imaging just to make sure there was no concern beyond the cecum, which I assume was normal. And then, I mean, my preferred route for this is to do other. I would go for other. Other.
Okay, Eduardo, that's what people are thinking. Definitely the same.
I'll tell you about other later.
Yeah. What you thinking? I don't know. What you think?
No.
That's the most favorable choice. Yeah.
Yes.
We have Mr. Khan also logged in. If
Yes.
Jim is still awake, we can talk to him as well.
Yep. So if the polyp is not going to the appendix and you can inject a bit just on the edge of the appendix and you see that there's some distance, then go for endoscopic treatment, which would be, I think, PSMA EMR probably for this patient, which looks at benign lesion. But we would discuss in the SPEC MDT, and we have, of course, surgeons there. So if the polyp is going into the appendix, we would decide a cystectomy.
Okay, excellent. Jim, looks like you charmed my audience. They want to go for surgery. Can we unmute Jim, please, and let's have Jim's
I can
opinion.
talk with you. Yeah, I can listen and talk. I think there are two answers to this very interesting case. One is a practical answer that will happen across this country in many places, which is shown in the poll that you will send it to surgical resection. But then the other one is that if you have a great department with excellent skills in EMR and ESD, you probably are going to explore the endoscopic option. I like Brian's comment about having cross-sectional imaging to understand what's happening outside the cecum and also how far down the appendix orifice this thing is going. I mean, with you here, we had great experience of resecting them into the appendicular orifice quite successfully, and we had significant success stories. What I would say to my surgical colleagues who are on the call, or even gastroenterologists, I think a right hemicolectomy should not be taken as a very easy operation. It is surgery, and at the end of the day, still associated with significant risks and complications. And a limited ileocolic or ileocecal resection in a fit patient might be fine, but the numbers and dynamics change a lot when you're looking at a 75-year-old or 70-year-old, as this patient is, with a stent, with a cardiac history, an ostomotic leak, and then weeks in the hospital and months in recovery, and may never get to baseline function afterwards. All of that has to be factored in when you're balancing pros and cons. At the end of the day, you're going to play to your strengths and what system and what practices you have set up in your local hospital and what expertise you have around the table. And all of those have to be put into an MDT kind of discussion with the team around you to make the right call for that patient. One thing which is in the other section here, which I would like to say, is about the lap-assisted, endoscopic assisted lap resection, which could be a very simple staple resection of the ileocecal pole if it is away from the valve, along with the appendix, can be done rather than doing a full right hemicolectomy.
think that's exactly probably Brian was also thinking in the other option. And that's very, very well done. I think we, for the sake of time, move on to, I can't remember what we did. So I don't know, maybe you're right. So we're using, so my thought process here was I'm using this Pentex knife called case snare, which gives me the ability to convert the ESD into a knife assisted resection at any point in time. So we evaluated that very well. It was going into the appendicular lumen. As Brian said, I didn't know how far it is going, but our thought process was if I can cut around and dissect all the way up there, and I can then put a snare around and take it out, and then decide what to do. So what you see here is we've gone with ESD all the way, and now we're using this new traction device, the traction wire from Medtronic. So huge big flap, put the traction wire, and I think this is going to change where we're going to think. I don't think, Brian, I can pull 5 centimeters of appendicular lumen here, but the traction is phenomenally good. And it shows you exactly where the base is. You see here, all the way, I could see the lesion pulled out and dissect right under it. And this was, again, a very good outcome for the patient with the R0 resection. To be honest, I didn't know how deep it was going, but when we were in the right plane, what I knew was I'm not going to do any harm.
Really nice resection, Pradeep. When we send patients to surgery, we don't have to forget that there is a fixed rate of mortality in this cohort. So it seems, okay, we have sent the patient to surgery and we forget what happened afterwards. So there is a fixed mortality rate, even in young people, for a right colorectomy. So from my point of view, I will try the same. We try the same. First of all, endoscopy, and afterwards, okay, surgery. But
yeah, I mean the other alternative is FTRD to go across. And in some ways, you've almost done an FTRD here because you've almost closed the appendix lumen with the clips. My slight concern with that is that there may be a higher rate of appendicitis or complication around the tip. And then if you get the thing out and it's not an R0 resection, you might still have to go in and do the cecectomy anyway. So it is a balance. There is a risk. I mean, a stapled anastomosis is still an anastomosis and there is a leak rate. But equally, this can't be without risk as well. So I think it's a very delicate balance in decision making.
I agree. And as you can see, we still found a focus of high-grade dysplasia, although it looked a very benign lesion. On histology, there was still a focus of high-grade in this. So we were surprised, but it was an R0 rate. And because of our experience of FTRD, where we have done all these full thickness excision, none of our patients so far have had appendicitis. So I said, why not I clip this as well? We're using that big clip to close it. So that's why we did. We did think about appendicitis, but what do you think about the risk of appendicitis?
Well, it was interesting. In Prague last week, I was talking to various people about FTRD, and they were moving away from using it in for appendix lumen lesions because of the 15% risk of appendicitis and potentially not entirely clearing the lesion.
Yeah.
The other thing to remember in this context would be the risk of mucocele of the appendix. I mean, even if you don't get appendicitis, and if there is a mucin that's accumulating, it's going to distort and distend the appendix, which will cause a lot of radiological concerns in the follow-up for such patients, and they'll be taken for appendicular mucocele and eventually end up having an appendectomy.
Pradeep, the good thing, of course, I think the decision was right because the outcome was very good for the patient. Now that we know the result, but even if it had been an R1 and there was a risk of a lesion in the appendix, it would have been easier for the surgeons to remove just the appendix than the whole cecum. So that's a good
very good thought process. I agree. Excellent. I think on that thought we go more forward, please. Okay. Yeah.
Yeah, so the next case is a 60-year-old male who presented for a colonoscopy as part of the bowel cancer screening program. The following is found in the sigmoid colon. Fit and well, no other medical history.
I like short history. Why not? Okay. this is one of those polyps I was asking John, that when it fills the lumen, you have no clue of what is what. And then you see on the head, you don't always get these views. You can't assess these things properly because they fill, it's difficult to assess the surface. So underwater is very good, cap is very good. All those things to make an assessment of where the base is, what the surface is, that all is really, really important in decision making and assessment here. Is there a poll before we ask our experts? Okay, that's an interesting poll. What SMSA level would you give to this lesion? Can you please poll? I'm not sure everybody remembers the scores, but the levels they should know by looking at a polyp. So it's good that you didn't ask the score of SMSA. Maybe we can share what just 50 of our pollers have shared so far, so that we can ask level 3. Okay, consensus looks like between, well, 3 is increasing and 4 is shrinking. So more and more are going for 3. What do you think, Brian? Is this a level 3?
I mean, in terms of the SMSA score, the most important one is the access. And that's kind of difficult to tell just looking at a video. Yeah. But where was the lesion? Was it in the
sigmoid? In
the sigmoid. So often in the sigmoid, the access can be quite tricky because the bowel is mobile. So it probably is 3/4.
Yeah. I think sigmoid, I find access even more difficult than anywhere else in the colon when the polyp is bulky. Bulky polyp in a tight sigmoid is a nightmare access.
So, I mean, the problem with these lesions is that they've been there a long time to get to that size, and they've been moving around and twisting, and the base is, the central part of the base will be quite fibrotic and stuck down. And you can actually sense that from looking at the base of the lesion. You can see the mucosal folds are slightly distorted coming into the polyp.
Yeah.
That doesn't necessarily mean it's cancer. That's probably a sign of fibrosis. But it does mean that a clean resection underneath it becomes much more difficult.
I agree. I think, do you want to move on to say what's the management plan? Oh.
Quick question. Would you use
a pediatric gastros? You mean pediatric colonoscope? Can we go into a slide mode so we can see what is next?
I mean, sometimes it's useful to retroflex and come back onto a lesion. So sometimes gastroscopy can be helpful from that point of view. I think the cap is certainly helpful because you can manipulate the base. You can move the head of the lesion away from the insertion into the base and actually see, that's the key point, because that's going to be your point of cut.
And gravity. Gravity is very important here. A cap and gravity. Maybe some water.
So it looks to, on assessment, we thought first we thought it was a pedunculated polyp. But when we did a very good assessment, it wasn't obviously pedunculated. It was a broad-based polyp, big, heavy on a broad base, which was pulling its base to make it look like a pedunculated polyp, which you could call as 1SP polyp. But it was quite a broad-based polyp. What will be your approach?
For me, is to put the base on top.
To put what?
The base of the polyp on top.
Oh, okay. So rotate and bring the base at the top, and then you just get your knife out and start cutting.
Yeah. Cap, gravity.
Cap, gravity, and knife. You don't need anything. Yeah. Brian, any other approach?
Yeah, I mean, the first thing I would always think of in a lesion like this, if say it's the first time you've seen it or you've seen the patient, is the duration of the procedure, because it's likely to be significantly longer than you think to resect this, and the comfort of the patient. If you're in this mid-sigmoid and you're moving around and you're putting gas in, the patients get very uncomfortable. And I would probably reschedule this for a propofol list where I've got anesthetic support, and then there's no time pressure. And the patient's comfortable, and if you have a complication, you can relax and treat it. But I'd be thinking about an ESD type resection here, to try and cut sequentially underneath it, possibly on both sides, down onto that area of fibrosis. If that doesn't work, and I'm convinced that the lesion is benign, I might also consider actually removing it piecemeal and just debulking it down onto the fibrotic area.
Okay. We will also like to hear from Noriko. Could you go ahead, whether she'll go underwater?
So
Noriko,
yeah, depends on whether or not you've done the endoscopy previously on the patient, because if the patient was referred, the way that these polyps are described are really tricky. The size, in terms of size, of shape, it's difficult to rely on the refer if it hasn't been done with a cup. So I try always to see with a cup and underwater the base. Because if it is not very broad, then you can even do en bloc with underwater with a snare. But if it is a broad one, then you have to go for ESD, or if you can do piecemeal in some elderly patients, but the base, there's a 40% risk of muscle retraction according to Professor Toyonaga. So where I think that if you do ESD, probably frequently you have to stop, or that's what I do when I find the muscle retraction. I know Noriko plays a clip, but if you do piecemeal EMR, that you are more used to doing that, you see that the base is very white tissue. You know if it's a cancer, if it's fibrosis. So anyway, I would do with the anesthetist in theaters, allowing enough time.
I mean, we did all the assessment underwater with the cap, and that's we noticed the base is quite broad. Also, we noticed on the head that there was a depressed area, very suspicious looking area right in the top of the head. So both alarm bells on both sides were ringing. So before we take the question.
Sorry to come back to you. I've got a patient very similar to this, exactly the same sort of size lesion in the sigmoid. He was symptomatic. At his index colonoscopy, he had 9 other polyps between 5 and 25 millimeters, which were easily resectable. This one is a level 4, which I didn't feel comfortable removing. What would you advise as someone who's receiving a tertiary referral? Would you want the 9 other polyps removed first before getting that referral?
Yeah, I mean, I think if you're reasonably confident that an endoscopic solution for all the polyp burden can be achieved, then you might as well, yes, it'd be quite okay to remove the other polyps, place a tattoo well away from the bigger one. And you might take some additional biopsies from any area on the bigger one that was of concern that Pradeep was mentioning, and then refer.
That's very good point.
Just if the polyps are in a resectional field, you're better to take the big one out first, because if it's cancer and they have a resection, they're going to remove the other polyps anyway. The thing about this polyp, Rob discussed something similar with me earlier this morning about removing this piecemeal. It is possible, and I have done it, very vascular. You run the risk of having horrendous bleeding with a polyp filling the lumen. You think you're not going to finish it and you bail. Adolfo's already mentioned muscle retraction, which I think is a big risk for a big snare. You've got to be really careful about that. And Pradeep's mentioned the changes on the top, and there are 2 reasons for that. One is overt cancer, and secondly is something called epithelial misplacement. So as Brian said, the polyps roll around and they get battered and their tops get damaged. So just because you've got surface change doesn't necessarily mean invasive cancer, but clearly you need to get off as low to the base as possible.
Can you follow the next one?
A nice 3 area on a big sessile polyp in the left colon. I was sent directly to the surgeon. I don't believe in, I mean, if it is nice 3, it is for surgery.
Yeah, well, it depends on whether it is nice 3 or not. There's a lot of misinterpretation of that. And that's where the whole confusion is. So obviously, I didn't know there was a poll coming up. I've biased everybody now. So I don't know. Let's poll anyway. My team told me there was no poll. So we went underwater, did the assessment underwater, injection on the far side, but the most important thing here is not to over-inject. If you inject too much in this small pedicle, so-called small pedicle, you then don't have a pedicle. everything gets injected. So it's very, very important. So what we're doing now is using the knife to cut from one side of this presumed base to open it up. Once it's opened up, switching over to the scissor type knife. There are a couple of different types of scissor knives available now. And then that makes it quite safe and easy to do as long as you stay underwater, because as soon as you put gas in, it moves away from you. Now this is where, did you see that? Now, what is that? Is that a muscle? Is that fibrosis? It says retraction of muscle. This is something you learn with experience. This is a very difficult decision-making process. You see that? You've done that, and now you got even bigger pulled up. That is certainly a pulled up muscle into this big base of this polyp. But our thought process was that this is been there for a long time. The muscle has been pulled up into it. If we can safely resect it, this muscle, we can always close it. So we went, once that was cut, that pulled up muscle, there was no need to carry on pushing my adrenaline levels up. So we got the snare on it now very safely, right to the base, underwater. We knew exactly, the snare was marked, so we knew snare is closed, because a lot of time you just get the head into it and there is no chance of knowing whether everything is in it or not. And we saw this vessel. This is what happens with these polyps. Throughout this process, I coagulated at least about 12 other big vessels. And finally, this spurter just gave me about 20 seconds, just a trickle before it opened up. We got the co-grasper, coagulated the vessel, and then it is the clip closure of the entire thing. There's no damage in the base, but still we need to close this kind of defect. So it is a calculated thought process. Look at the little Buddha sitting there. So I think you can achieve good outcome based on your assessment and what technique you use. Would you done anything differently, Adolfo?
The only thing with the muscle retracting sign in these polyps that 75% of them more or less are malignant. So when I'm deciding to cut it in according to the NAGA, so it depends on what you say is a muscle retraction or not, but this one was clear. You will tell us a histology later.
Yes.
But so at least I do discuss with the patients about this sign beforehand and tell them that we may need to, and I ask them if they're happy for us to go ahead in case that we need to.
No, I completely
because
agree.
if it's a cancer and you make a perforation there, you're going to change the stage of the lesion.
It's very tricky. I think can we move on?
Yeah, so the last case is Prof. Saunders' case.
Yeah.
So we'll actually, I think it's been recorded, so.
Where will we play that from? That computer?
Play it from there.
Okay. So Brian, we'll play if you just take a stand there. Can you play?
I'll stop sharing.
Jim, were you itching to take that sigmoid colon out?
No, I would have had full trust in my colleagues' abilities to take it out endoscopically. I agree, they are not easy, they are difficult location, but sigmoid resection again is not without problems, and especially we don't know the histology yet, but if it is benign and you have saved him from an operation, it was worth it.
Yeah, thanks. Okay.
Great, thanks very much. So it's always a great pleasure to be here at Endoport. I've got a sort of fairly challenging case for us. If we have the next slide. So this was a 77-year-old chap who was a tertiary referral, and his presenting complaint was mucus discharge and frequency for about 2 years. But in the last 6 months, he'd had some really quite unpleasant urgency and incontinence. And his past medical history is slightly complicated in that, can you get rid of the box in the middle of the screen for me? I can't see the slide.
You can't see. Can you get rid of that?
Do I just click? I'll just click on it. Does that get rid of it? Yeah, so complicated past medical history in that he'd quite recently been diagnosed with myasthenia gravis. Now, you all know about myasthenia gravis, don't you? And he was under a neurological review, but obviously there is this concern about a myasthenic crisis with surgical intervention, or in fact, any intervention.
What's happening in there?
Bloods were normal. He had a colonoscopy, which showed a really huge rectal polyp, filling virtually the whole rectum, starting at about 6 centimeters from the anal verge and going right up into the distal sigmoid. And it was circumferential over a significant amount of the rectum. But there was no proximal abnormality, and histology was very benign, low-grade dysplasia, tubulobilus adenoma. He had cross-sectional imaging, which was all satisfactory, including an MRI scan, which didn't suggest any muscular involvement. Next slide. So what would you do next? Pradeep, what would you?
Sorry, I was trying to find out where Milan is.
Okay, Eduardo, we'll let him off the hook. Let him off the hook. Eduardo, what would you do next? This has come through your email. It's landed on your email. You've got that information. What would you do?
Maybe I would try to have some information about image, any kind of CT scan or.
He's had CT and MRI, and they're fine. Okay. There's no local regional nodes, no liver mets.
So if somebody referred me so big polyp, I perform a rectosigmoidoscopy to make a good assessment of the lesion and to see if I'm able to resect. Not only able, if the lesion is able to resect, it's fit for EUS-D or EMR. Okay. So I will do a second look before doing anything else.
I think that's a really good point. So now, certainly with my tertiary referral practice, I do a lot of I do a diagnostic check so that I can not only meet the patient, but also see the lesion directly and work out what is or isn't feasible. And I think rather than bringing a patient up into a slot where you've booked maybe anaesthetic and an entire half day, it's better to have done that diagnostic check initially. Of course, the other thing that I thought about doing was saying, why don't you go to Portsmouth? But next slide, please. So he had a diagnostic flexible sigmoidoscopy and a polyp clinic appointment. At the same time, he also had an anaesthetic assessment by one of our senior anaesthetists regarding the myasthenia. And he was then subsequently discussed at our polyp MDM. And at the diagnostic flexible sigmoidoscopy, he had a very extensive lesion. You can see here we've got 4 centimeters, 10 centimeters, 24 centimeters. We're starting to get normal mucosa in the distal sigmoid, but the rest of the rectum was just plastered with this circumferential polyp. All look very, very benign. Granular LSL, Kudo 4. There were some nodules, but none of them were particularly prominent. So the entire thing looked benign. So next slide. What would you do next? Pradeep, have you got a comment now? You have time to catch up.
I'm getting old. I'll send him to surgeon. It's a huge undertaking.
So which of these do we have? How many surgeons do we have in the audience? How many surgeons? Got a few. Okay. So put your hands up. I guess we could do the polling slide, or maybe in the room. What we'll do is put your hand up. I'll read them out, and you put your hand up for which one you want. Low anterior resection with covering stoma.
No.
No. Low anterior resection with primary anastomosis. Okay, that's pretty bold.
Yeah.
EMR. Few. ESD. A few more. Transanal excision. Few. Who would do nothing and monitor with flexible sigmoidoscopy? Nobody. Right, okay.
Can we ask a surgeon what he would do?
So, Brian, thank you. Yeah, a very complex case, as you say. It looks very benign looking at the images that I have seen. MRI does lose its kind of extent in the assessment of a low rectal lesion. So we will probably, the only additional thing we might want to do is an endorectal ultrasound to check for any muscle invasive disease. But I think the problem is going to be an extensive long lesion, which with TEMS will be very difficult to take out without the risk of significant stricturing and stenosis, and it's going into the proximal or distal sigmoid. So it will be really massive undertaking. Or you can do the segmental TEMS to assess for histology if there's a doubt for the lower end of the tumor, but again, that's not going to treat the problem. Surgery will remain an option, and the patient is young, and if he wants to consider surgery with or without a covering stoma will be an option. But the last point that you made, do nothing and monitor with flexi, I think we need to give some more thought to that option, because as a surgeon or as an endoscopist, if you are kind of keen to do something with the patient, sometimes doing nothing in the setting of a very benign but significant lesion might not be a bad thing to consider.
Yeah, but in this particular situation, he's very symptomatic from it. So that really wasn't an option. But I think for a right-sided lesion or a lesion that's not giving the patient much in the way of symptoms, I think that's definitely an option. So can we have the next slide? This has got sound on it, and it's sort of, I'm here with a colleague, Adam Humphreys, and we're sort of discussing the case as we go along and what we're going to do. So if we could have the sound and just listen.
Hi, we're back in room 2. I'm here with Adam Humphreys and Nicola Pearson's anaesthetising. We have an extraordinarily large polyp here in the rectum. It's starting about maybe 4 to 5 centimetres up from the dentate line. But as you can see, it's a conferential through the mid-rectum and extends right up to the sigmoid colon over more than 20 centimetres of the length of the rectum. So it is a very significant lesion. We've had a good look at it. There doesn't appear to be anything concerning in terms of possible mitotic change, but it just keeps going. And eventually we get to here, there's a little strip of normal mucosa, and then we come up to the sort of rectosigmoid, distal sigmoid, where we're clear at the top. The Paris classification is it's a G-type LSL with some prominent nodules. We've got nice regular crypt structures over the top of it, Kudo 3-4, and the bowel distends normally, but it's just the sheer bulk of this lesion. Surgically, it would probably mean a low anterior resection with the likelihood of a stoma. So the plan, after much discussion with the patient and cross-sectional imaging, etc., is to consider an endoscopic excision, but this is just too big to resect in one go. So my plan is to resect the proximal side first, the oral side first, and then come back and do the distal side. So what we're going to do is we're going to create what I've described as a fire break, where we cut using probably piecemeal EMR across this part of the polyp, and then clear everything from here upwards, and then come back at a second sitting and try and remove the distal part. Now this thing is really so big, it is going to be challenging, so hopefully...
Brian, it's interesting the biology of these lesions, that you can get such a large lesion that is entirely benign, whereas we can see cancer in sub 10 millimeter polyps.
It is extraordinary, isn't it? I mean, whatever genetic changes, it's stopped before the crucial change.
Just move it forward now towards the end.
Bad theory.
Just move the video forward. Okay, well, not to worry. Anyway, if you can just show us the end shot of the video. I can't control it from here.
The video is so big, everything's frozen.
Ah, okay. Well, just go back to the slides then.
Surgeon is very confused.
I was surprised that the surgeons would do a primary anastomosis for that, because it would be quite low. Would you not normally defunction?
I think, Brian, I can take that. There is a movement now. I think with technology improving, with the stapling getting better, the blood supply assessment getting better with fluorescence and all that, I think there is a role for fit patients when the anastomosis is healthy and you're happy. Stomas create more problems as well with high output blockages, reversal issues, hernias. So it's not without issues, and you have to balance the risk of a leak versus complications from a stoma. And that's a very, very patient-centered decision making.
Just take the video right to the last sort of 10 seconds or so. take it forward. So I mean, the plan here was it was too big to resect in one go. We've got the anaesthetic complication of myasthenia gravis, and so the procedure was done under a spinal anaesthetic, not propofol, not GA, because we're concerned about a myasthenic crisis. Leading up to the procedures, we got the neurologist to see the patient, and the patient was on 10 milligrams of prednisolone to reduce any risk. And then the plan was to do it in a staged approach. So in the first session, I stripped all of the proximal side of the lesion. The reason being that that area is then going to narrow slightly in stricture. If you do the distal bit first, you won't be able to get access onto the proximal bit. So here we are at the end. We've stripped off all of the top portion of the lesion. And you can see nice clean resection. There'd be no point really doing ESD here. It would take too long. Again, we didn't want the procedures to be more than about 3 hours in total. That was the anaesthetic advice. So that's the first procedure. If we just move on now, next slide. So this is what it looked like 3 months later. And on the left panel, you can see that you see the scar from the proximal resection. You can see the residual polyp unchanged in the middle panel. And then we resected as much as possible in a second 3-hour session, again, using piecemeal EMR. But actually, it needed 3 sessions. So next slide. This is what it looked like 6 months later. We've now got some residual polyp just untouched in the central part of the view. You can see the granulation tissue at the top. You can now see a completion resection, and now we've got the whole thing off. There was the beginning of a small stricture in the mid-rectum. Next slide. And this is what it looked like at 9 months. You've got nice granulation tissue forming in the central area. And the incredible thing was, from a 20 centimeter plus polyp, the actual area of narrowing was only over about 2 or 3 centimeters. And the distal part of the rectum was preserved. So a year later, next slide, it now looks like this. And he's got a sort of 2 centimeter mid-rectal narrowing. There was a tiny bit of recurrence that was treated, but his bowel function is manageable and he doesn't have any incontinence and he's back playing golf. So I think we managed to get on top of it in the end. But the reason for presenting this is that sometimes actually if you do a staged approach, you can still be successful. You don't necessarily have to go for, and I think the concern would be some people might say, well, why didn't you do an ESD and remove the whole thing in one go? Well, an ESD in that context would probably take 10, 15 hours and you run into major anesthetic complications and problems, as well as all the logistics of teeing that up. So sometimes a staged approach with a slightly more cautious, progressive approach is that you can still have success.
That was brilliant demonstration. I was going to say we had a similar situation a few years ago where we did completely the other way around, where we started from the bottom end. My surgeon said I need only about 7-8 centimeters of clear rectum to do a resection in a primary anastomosis. So we cleared the bottom 10 centimeters from dentate line upwards. That healed, and then they went and did a surgery with a primary anastomosis. So that's another option and the way to think about it. Thanks, Jim, for joining us. We're running a little bit late, and Milan has got a patient lined up for us. So you're going to go to Milan. Those who want to go to parallel symposium on decision making, it's in the next suite. You can go there, please. But can we go to Milan live? Who's the chair for the Milan session, please? Everybody there?
Sta venendo. Io non sento Aldo, Aldo, alza.
So, Milan, we come live to you. Manu is joined already from through the virtual link. Nadeem, you here? Nadeem's joining us, and Amin is joining us as well. Thank you. Milan, we are live to you.
Okay, thanks, Polyp. So we're here with another case. So let me introduce the other operator. This is Alessandro Fugazza. He's the director for Biliary program here in Humanitas, and is going to present a nice case. So Alex.
Oh, thanks, Professor Epigi. Hi, Pradeep. So, he's a patient with 66 years old with a head pancreatic cancer that 3 months ago placed a metallic stent in another center. Now, and she started chemotherapy. Now she stopped chemotherapy because I had a very bad cholangitis with positive of Klebsiella multi-drug resistance, had jaundice, and we saw pus coming from the stent. So in this case, we use a single-use duodenoscope because he's a very fragile patient, is immunocompromised, and moreover, the patient had a multi-drug resistance. So in order to avoid the risk of contamination of our duodenoscope, we use a single-use duodenoscope, an EXALT scope.
So Pradeep, this is an interesting case because this is a sort of summary of...
Can you guys hear us okay?
Pradeep, can you hear me? Pradeep?
Would you check if they can hear us okay?
Pradeep?
Lava.
Can you hear us?
Yeah, now we can hear you. You can hear me?
Yeah, we can.
So I was
just got
trying
a
to
very
say...
quick question before you so thanks very much for sharing this case with us. So when you placed the stent, did you do an endobiliary RFA pre-placing the stent, or you
never,
place the stent
never.
and then consider RFA if needed?
No. We do not consider RFA in this case. It's a typical malignant distal strictures due to pancreatic cancer.
Right.
So we were discussing about the indication of single-use scope because this is typical situation of patients who is sick and immunocompromised under chemotherapy, pancreatic cancer. She got cholangitis, and the cholangitis is related to multi-drug resistant bacteria. So we don't want either to contaminate with other bacteria these patients, but also we don't want the channel of our standard reusable duodenoscope being contaminated with this kind of bacteria that can grow easily on the biofilm or the working channel or the elevator. This is why it's a standard policy in our medical facility. When we do this kind of ERCP, we fully adopted the disposable scope. And now we are going to use the exalted disposable scope. And Ale, can you tell us, in terms of performance, technically, how does it look like in your hands? You feel different from a standard scope?
Thanks for the question. So the good performance is very good. The problem is only at the beginning. So is another scope. So at the beginning is strange, but after that is a very useful scope with a good performance. Also the elevator, the function is very good. The position in the duodenum is a little bit different because it's more strange.
Can you see, Floro? No, it's not exactly the typical D2 duodenoscope position with the standard scope. In general, the scope is much lighter, but the tip has a different deflection angle. It's a different possibility of being rotated. So you need to pay attention when you're transversing the upper sphincter and the lower sphincter, esophageal sphincter, because there may be a little bit more challenges in going through these two parts of the esophagus, but in general, the performance is very similar. So I saw you cannulated the
we cannulated the stent. So now we start with the cholangio in order to understand. So there is some sludge and something inside the CBD. For that reason, the patient had cholangitis, because we saw that here there is an ingrow of the stent. It was a partially covered stent that was placed. So we performed the cholangio. And after that, I would like to place another stent inside with the stent instack technique. I ask
Ale, it makes any sense to pass a balloon?
Could clean, be, yeah. To
clean the
yes, we can without any problem. So I asked to my nurse to open the guide wire because we are using the rapid exchange system with a 260 guide wire. So we pass an extractor probe balloon in order to clean a little bit the CBD.
One of the other things to mention about while you're doing that, while you're trying to clear the CBD, one of the other things to mention about the disposable duodenoscopes, you have to slightly prepare it before you intubate the esophagus. You have to try and straighten it out and make it as flexible as possible, because it is a rigid scope. That was our experience when we used the EXALT scopes. So do you have Now, is this standard policy for you to use disposable scopes in patients who present with cholangitis or multi-drug resistant cholangitis?
Yes, thanks for your question. So in patient immunocompromised with multi-drug resistance, so in our unit, you use this type of scope in order to avoid the risk of contamination of the patient and to contaminate our duodenoscope for the next patient. So the indication is very high for this patient to use this scope. So now we introduce a balloon. We inflate here and we clean a little bit. Okay, here. We check because probably we have a problem with the balloon. Inflate. Okay, deflate.
Are you able to zoom
Okay.
into your
Inflate.
fluoroscopy images, please?
Okay, we clean a little bit, right? Go. Inflate, we perform cholangio, we perform a pressure cholangiography. Ok, si è gonfiato tutto? Gonfia tutto. Ok. So we saw the cystic duct. Deflate.
So Ale, what's next?
Next, we place another stent. I would like to place another fully covered metastent, fully covered metastent in order to reduce the risk of ingrowth of the distal part. And I think you agree to place a longer stent, because this one, it was a 4 centimeter stent. And you see that when we have something inside of the stent, the guide wire is inside, so the CBD is straight. But at the beginning of the procedure, there is a bend between the stent and the CBD. So for that reason, I place a longer stent in order to avoid this risk. And you saw the elevator that is in titanium of this stent. The performance is very good because the risk of misplacement of the guide wire is very low. So we place a wall flex stent 10 millimeter for 6 centimeter. It's a rapid exchange stent because the risk of cholangitis and the risk of contamination is not only the duodenoscope but also all the device. For that reason, you use all the RX system.
So can I ask, you saw pus coming out of the stent and you're obviously using a disposable duodenoscope. Would you still give this patient antibiotics? Yeah,
we saw the patient had a very bad cholangitis, so we check the exam in the next days and we check. If the exam improved, we stop everything and we will see.
I guess one of the other consideration is if this patient has still got gallbladder in situ and you're opting to use a fully covered self-expandable metal stent. I guess, would that be of any consideration in terms of future problems?
No, I put a fully covered metal stent in order to avoid future problems, in order to avoid the risk of overgrowth of the stent, and in order to have a good performance of the stent, a good drainage in the CBD. So we started with the risk of the stent.
About the risk of getting the cystic duct obstructed, pancreatic duct obstructed.
No, in our experience, we have no problem about that. I don't know, Prof, if you agree. And we start. So we go. Bye. Okay. We start. So we saw the distal part of the stent here in endoscopy, and in the floor we follow the release of the stent. Okay. Okay. Go, go, go. Okay. Okay. So we saw the opening of the stent in the proximal CBD. Is no problem for the confluence. We are below the confluence. So we continue the opening of the stent. Thanks, Josie. Go. Okay? Okay? We are in the point of no return of the stent, so we check in the fluoro. The fluoro, it is okay, the placement in endoscopy also, so we continue and we release the stent. We check in endoscopy, no more fluoro. Okay, and this is fully open. So now we close the stent in order to release, and okay. And the stent is done. So now we deflate, we remove also the guide wire. You see hair inside of the biliary system. There is a lot of hair, so there is an indirect sign of the function of our stent. There is a little bit of more sludge, but
you can put a gastroscope up there now and check everything. It's so wide.
Nicely
done. You're right. So, guys, any question? Because we're done.
Beautifully demonstrated. This is fantastic, Ale.
Thank you so much.
So, can you show what we're doing at the end?
Guys.
No, just have a look to what Ali is doing with the scope.
Now, we have finished the exam. We off everything. So, we remove the duodenoscope. Okay. This is our scope. So, at the end of the procedure, we put the duodenoscope into the trash. So, we have finished also for our nurse. Is a good work. They don't not to clean the scope. Everything is finished.
Okay.
Thank you very much. Well demonstrated. Excellent. Bye. Bye. Ciao. Ciao, guys.
Ciao. Bye. Bye.
Ciao.
Ciao. We get to Kent, please. So, Zach, we're back with you. Mr. Haji is eagerly waiting to find out what you managed to achieve.
Yes. Hi, hi, the rest of the panel. So, welcome back to East Kent University Hospital. So, we got this low rectal to mid rectal polyp. I think we have done a huge progress so far. I can show you very nicely the isolation of the proximal mucosal incision, which is followed by the right, and then goes back to the left. This is roughly between, I think, 6, 7, maybe larger centimeter polyp. And then we have done a very nice tunneling. You can see now the tunnel now, which is from the distal side. I don't know, can you see the tunnel? But is the connection good?
Very good. Very good.
Okay, so that's the tunnel, and we just done about roughly, I would say, 60%. And then I thought I'd be struggling to continue the tunnel because the muscle was going a different direction. Give me the scope, the stack close to me, please. And that's why we decided to actually start working on the sides. As you can see, the gravity side is here, is on the top. So that was really favors, to continue. So this is the bridge formation technique that we apply here in this tent. And using, of course, this kind of platform with the air seal. And now we actually do symmetrical submucosal dissection from the in to out approach after having isolated the mucosal margins. And then we do again from the left to go into out approach. Again, trying to use all the features of the speedboat inject device and technology, trying to, as you can see, we have not damaged the muscle at all. It's quite clean, very shiny. There is a bit of a mass split here with a very severe bleeding. You see a big vascular bundle over there. It took us about a couple of minutes to control the bleeding, successfully use the microwave coagulation very precisely. Now, as you can see, despite this severe coagulation, there's no coagulum left on the muscle bed, which is actually part of the super high frequency of 5.8 gigahertz. It's very confined controlled coagulation. So the plan is to continue dissection with using the in to out approach. I think we're almost 90 minutes operating, so we're just doing very well. You can see we're up to here. Doing another possibly 90 minutes, and I'll always come back and give you another update. Any questions?
Yeah, so a couple of points really. Your strategy usually for these type of cases, you normally just do a circumferential incision early on. Do you find that's helpful? And also, does it hinder your progress in terms of ensuring you don't have a cushion below, or do you always just make a circumferential incision right at the start? So it'd be interesting to know your strategy in terms of your technique.
Yes, I mean, I don't know if you can hear me. The line is breaking from my side, but I have not done circumferential incision from scratch. I did first the proximal incision. Then we did the distal incision to create a tunnel. And after the tunnel has been completed, I think we don't need any more the tension from the mucosa. So that's why then we free up the lateral margins on the right and on the left hand side, because we know we have the guide, which is the guide now is our tunnel and the bridge formation technique. So that's why we free up and connect the distal with the proximal gate. We do that later, not at the beginning. I don't know if you can hear me because the line
we can hear you very well. I think we see a very nice tunnel. Your tunnel is a bit narrow. I'm sure you widen it up. Almost look like a Dartford tunnel soon when you widen this up. Looks like there's a lot of tunneling to be done, Zach. I think you'll still be going in a couple of hours.
Yes, can I show you something before you go, Pradeep? It's I want to just demonstrate something which is very crucial, and it's quite different compared to the other devices at night.
Please.
This is the in-to-out approach. It's, I think, something almost everybody is actually following. But with this device, you can see I can actually change the axis. So I can go, from 6 o'clock to 12 o'clock and actually get more tissue than a normal knife. As you can see, and that's why you have this extra out this. You see, you have extra. It seems that you have a lot to be done, but by getting this device, you can get a lot of tissue compared to other knives. It's
I see.
I mean, it has a similar feature to the RT Nano, and now I'm just playing with microwave, and I'm just gently trying to, use more like a surgical device, very, very gently, so I can get more tissue back a bit. So that's it really speeds up. So this is a point which we have to be very careful to go very close to the muscle there. But as you can see, by using the hull on the muscle, which protects that, trying to avoid any kind of muscle injury, we can get more tissue. And then right up a bit. With our device, possibly it will take a bit longer. Again, you're right, it's a lot to be done still. I'm just waiting for you to show you the tunnel. Now I will try to speed up a bit.
Good. This is a very, very good demonstration of how the knife works. Very nice, clean cut. And the way you can use the traction to your advantage. That's very good. So here, when you're encountering the vessel, do you change anything?
No, I just go to the microwave. You see now this is a bubbling.
Yeah.
I apply 10 seconds of microwave. If I'm not happy, I can go one more set of 10 seconds until we have really nice degradation of the collagen fibers of the vessel wall. And when this is happening, I'm just going to be gently cut without so much traction, try to see if it will bleed. As you can see, there's no.
Yeah, beautifully demonstrated. I can see. Thank you, Zach. I think you keep going. Shall we quickly see how you control this bleed, please?
Yes. It will take us about 10 seconds. I think that was the previous vessel. It's possibly need another set of 10 seconds. It's very handy to have the microwave, in hand, and not to exchange any instruments. I mean, personally, back when I was using the Dion knife and IT Nano, which the IT Nano has a very efficient coagulation. Actually, I haven't used coagulator for a long time. Out more, please. You can see the nurse is controlling the device for the deployment. He is actually an endoscopist. And Jomel, yes, back.
Excellent. That's very good demonstration. Thank you, Zach, and we'll hopefully join you later to see your finished product. Thanks a lot.
Thank you.
Yeah, bye for now. So now we're going to move to another parallel symposium, which is one on hepatobiliary, which is coming from Nagi Reddy in India. It's been next door, but unfortunately, they're still talking polyps next door. I think the love of polyps in the audience is so much that they just don't stop talking polyps. So Nagi, I'm really sorry. We will be live with you in next 5 to 10 minutes next door. But here we have to start the polyp session in this room with the same people who are talking polyp next door. So go and grab your drink, come back in 2-3 minutes, guys. I'll grab the polyp people back to this room. I'm sorry about this running around.
Would you consider some injection at this point?
Yes, yes. So let me get a bit more of this. I think
you're winning nicely.
Yes.
Yeah.
I just want to make sure I
mostly
utilize
the lateral aspect.
Yes. Can you please take the headset out, please? And then go back to my music. Thank you. It's a bit tight over there. Let's get to keep on this one at least. So the comment from Amin Haji, did you hear that?
I didn't hear.
Just now. Yeah. Amin said, what did we release from scratch? I said, we did not release from scratch.
Oh, I see.
Then he goes out.
Yeah.
But he was not there. He was not there actually.
Yeah, he wasn't there.
Yeah.
Zach. Clean it with Kleenex wipes.
You see?
The phone.
The phone, yeah.
And some injection. Need lock, please. Need lock. Inject. Stop. Bring it back. Any lock? That's a bit too quick over there. Inject. Wait. Inject. Stop. Bring back. Yeah, much better now. Yes. What do you reckon? All agreed? Better injection now?
Yes, yeah.
Out. Just do myself. That's it. Out. Out. A little bit too much. Some mucosa here. No, that's right. Out. Left up. Right up. Right up. Right up. You don't go right up, just go right up more. Follow the front of the bowel. Out, please. You see how it goes like this out? Now slowly go right up. Right up. Well done. Oop. No. I prefer this 6 to 12.
6 to 12,
so
yeah.
9 to 3.
Instead of 9, yeah.
Because you can see the muscle there. No. Out. Yeah, out. Out more. No, sorry, back. You don't have to go so deep because we're on a muscle there. Back. You see, that was muscle there. You shouldn't go too deep, you see? Shouldn't damage the muscle there. Out. Left out a bit. That's it. Joseph, are we doing all right? He's not here. Who? Joseph.
Joseph, he's asking you, is he doing okay?
Yeah. Yeah, don't leave me alone on my ward here. That's it.
Can I screen share now?
Yeah. So I think
Out. Just a bit more. Out more. Left up. So this tiny vessel.
Arterial vein.
stop that.
Yes.
Tell him to stop.
Arterial, exactly.
He's still sharing. Zach doing the transmission.
Oof.
So do you want to start?
Oof. That's a big boy there.
Mm. Yeah, yeah. Do you think so? In such situations, yeah, do you think? So in such situations, do you think that injecting will lift it away?
Yeah, that's the one point.
Just a minute. So thanks. I think next door HPB session will start. Nagi, we're having a bit of a technical problem for next door. You can stay with us for now, but very soon we'll switch you next door for the HPB session. So all our virtual faculty who joining for HPB, we will be switching you to our next door room. Just bear with us. We're going to start with the polyp session again here. This is going to be a debate, friendly debate. This is a first debate in colorectum about complex right-sided polyp management, where we'll look into surgery versus EMR versus ESD. And we are grateful for our excellent chair. We got Professor Sunil Dalwani. You already heard from him this morning. Susie Green from the South Coast, and Professor James East from Oxford. So thank you guys for joining us. I think we should start with our surgeons first, because we never give them enough opportunity. So can we invite Professor Jim Khan to come here and share his views? I think surgeon is doing a very unusual presentation, no slides, nothing. He's just going to stand here and talk to you. Okay, so Katie wants to do a poll first before you bias the audience. So even the virtual audience can poll now. So this is a 55-year-old male with the 50 millimeter LSTG in the ascending colon. What would be your treatment of choice? No obvious concerning features, but a large LSTG. Don't forget the risk of delayed bleeding and recurrence and all those things. EMR, ESD, surgery. I know that we have 3 or 4 at least colorectal surgeons here. So poll now. I think people are just waking up. Virtual audience, also you can do the scan this QR code and you can poll as well. We want to see who can convince you at the end of this debate. So please poll. I'll give you another 30 seconds to finish voting, please. John, can you poll rather than text, please? Good. I see you texting. So I think we'll stop in another 10 seconds. So please poll now. So we'll 50 people. I think can we share? Just press the button. Well, I need to know which button, but I'll press anyway. Okay. So that's the conclusion for a large right colonic polyp. At the moment, our audience thinks almost 55% thinks EMR, 36% ESD, very small, just under 10% who think surgery is the right choice for a 55-year-old gentleman. So it's all for you to convince them otherwise now. We can stop sharing this. Jim is just going to talk. What do I do? Press a button?
Leave it on.
Leave it on.
Leave it on.
Okay.
Let's see if it changes. Well, and people can keep on voting. No, Pradeep, thank you so much. Absolute delight to be here this afternoon, this morning. I can see 4 surgeons out of those 50. So I was feeling really worried because I thought I was the only one. So it's nice to see there are 3 more. I've seen, so I'm feeling a bit more comfortable. But that's the debate. And I need to convince you about the role for surgery for these polyps and where does it stand and how can we make a case for surgery? And I think let's just unpick this. I mean, go back 10 years ago, and you know, iPhone did not exist 15 years ago. Can you imagine life without an iPhone? You did not have the LED monitors. You did not have all the ultra high definition views that you can look at and assess polyps and assess tumors and perform surgery by the same token. So what I'm trying to say is that things have improved a lot in the last 10, 15 years in terms of safety, accuracy, and technical ability of people to do what they were able to do before. One of that example is reflected in the mortality rate after resection for bowel cancer or bowel polyps and surgery for bowel disorders. It used to be 5% was the ACP-GBI accepted mortality. There are many centers publishing less than 0.5%, less than 1% elective mortality at 90 days for all comers. And when we talk of all comers, we're talking of people who are 80 and 90 years old because we're all living longer. And Portsmouth is by far, my catchment area is not the fittest in the world. They have all sorts of comorbidities, high propensity of obesity, diabetes, blood pressure, all sorts of comorbidities. But with proper medicine, perioperative care, good surgical techniques, you can get them through surgery quite safely. So the argument of high mortality from surgical interventions is null and void. Obviously, there's a patient selection and there is a situation where the patient may not be very very low risk for surgery, and you might have to alter your approach. But the ballpark figure is that the mortality does not stop surgeons from operating nowadays. In fact, nothing ever stops surgeons from operating, but nowadays you can see that the mortality rates are low, so you can operate. The big thing for us is the possibility of a cancer in that resected specimen. So we discuss at the MDT often the cases, the specimen had been resected, 4 centimeter polyp in the right colon, Yes, it was low-grade dysplasia or high-grade to begin with, but then you have a focus of cancer. And then if you have a piecemeal EMR, you're not sure about the resection margins. Pathologists cannot make any head or tail of the specimen that they have got on their table. And you are now humming and hawing about the risk of lymph node metastasis. And we have nothing really good right now to tell us how much the risk of a person in that particular scenario for lymph node metastasis would be. You can as well toss a coin, or you can look at, okay, we'll find, I'm going to do a CT scan to see what the lymph nodes look like. There's no real navigation intraoperatively right now, which is tumor specific. So you end up having a discussion with the patient, tell them what you want us to do. And they look at you as a doctor and say, well, you tell me, you are the doctor, you're supposed to know what you should do. And we say, well, equipoise, I can monitor you every 3 to 6 months with a scan, or I can do a colectomy now to resect for what may be a residual focus of cancer or some occult lymph node metastasis. So that dilemma carries on. And with the healthcare resources that we have in a practical way of running that service, we just don't have the logistics to do these things on a 3-monthly basis, to do a scan and follow-up review again. And very often these pathways fail because of the waiting times. And hence, if there's a rationale where you can have a big polyp in a fit patient and you can perform surgery with low morbidity and mortality and can get them through, that seems to be a quick fix. Now, that might not be an answer for an 85-year-old with lots of comorbidities, but by the same token, if you're going to do a right-sided colonic EMR or ESD, which is going to take you 3-4 hours under anesthetic, don't underestimate the impact of that on those patients as well. So there's a balance to strike in those things. The recent advances in surgery with training, especially with robotics coming into view, you can now perform a 90-minute procedure with suprapubic docking. All the ports are in the groin crease. I didn't want to show you any fancy videos or clips of those, but you all know, obviously it's very, very topical nowadays, but you can do surgery through a very low fen and steel scar with 4 ports and a couple of centimeters of extraction site. So, and the patients usually go home within day 3. So the mortality and morbidity of that surgery and the long-term outcomes are really good. It's a question of selecting your right patients for that. So I would probably say that there is evidence now to suggest that the elective morbidity and mortality is very low, especially for the surgeons who are trained in the technique. If you have discussed the patient properly and a good preoperative imaging to discuss and endoscopic images, and the patient is well consented properly with informed consent, I think there's a role and a case to be made for a surgical approach, especially given the circumstances that we are living in with the NHS, with limited resources, with not having the ability to bring them back in a timely fashion to monitor and do further scans and further endoscopies. Surgery still has a role to play, and don't underestimate that. I hope with these kind of arguments, some of my colleagues might change their approach, but we'll see. Maybe a repoll after all the 3 speakers have presented their view might be useful. Thank you.
Do we have our second speaker?
Thanks, Sunil, James. Susie for inviting me to this talk about how to deal and manage with proximal colonic polyps. Of course, there's no single best answer, which is always correct in all circumstances. I guess Jim will explain about the advantages of a right hemicolectomy, which might be quicker than an ESD. And Yutaka will talk about the advantages of a single fragment ESD resection, and both those have advantages in certain occasions. But I guess I don't need 6 minutes to do what we would all do, i.e. first think about an EMR for a lesion. Unfortunately, there's no RCT that I can point towards that has actually compared the outcomes with the same SMSA polyp removed either by ESD versus piecemeal EMR. And I think it's unlikely that we'll ever get one, because the largest polyps situated in the most difficult locations are not even considered for an ESD. They're thought to be too difficult. Now, if you look at the literature, you find that most ESD series don't even include lesions from the proximal colon, of course. And that's because resections here are more awkward, of course. It takes longer to reach the area. You might lose maybe 15 minutes of your therapeutic window, which in my books is usually around 60 minutes. 15 minutes just to reach the lesion and tidy it up to see what you're dealing with. You might at that point have a bit of paradoxical movement because the splenic flexure or the sigmoid loop keeps coming back with a dip in the transverse colon, so you don't have a perfect one-to-one. And the patient, for all these reasons, might be a little bit fractious. So your therapeutic window might be shorter than an hour. And of course, it's important to maintain rapport and trust with the patient, particularly when, I say when, not if, there is a complication. The advantages of an EMR, I think, are obvious. It's basically quicker, safer, and easier than an ESD. We all know that. And it's both cheaper and safer than surgery. Furthermore, you can usually achieve a single fragment resection if you go for a 2 to 3 centimeter stiff snare, say like the MedWorks flat band snare, and place that around. There's a risk, of course, of a perforation with these big stiff snares. But if you want a single fragment resection or as few fragments as possible, those are the tools to go for, the stiff big snares. Now, I don't buy this argument that the only game in town to achieve a complete resection rate with no local recurrences is an ESD. If you pay a bit of attention and you look behind that blind fold that you can't quite see if you removed all the polyp, you check all the edges, even the ones that you can't see initially, that you have to labor to kind of find, to look behind, an APC, anything that looks dodgy. I think you can get your local occurrence rates back to single figures, the same as you would with an ESD resection. On the topic of complications, I usually quote a 1 in 100 risk of a perforation for a piecemeal EMR. Why would you undersell it? You might have, well, we understate the risks. And of course, the risk of a perforation is greater with an ESD. I would quote probably 1 in 20, or something like that. But of course, a small microperforation, provided that you recognize it properly and clip it closed straight away, is not a big deal. Now, the risk of a post-procedural bleeding is the same, as you would expect, is the same with either an EMR or an ESD. So, when do I hesitate to offer the patient an EMR? I don't have any qualms about removing an innocent-looking LSTG lesion by piecemeal EMR from the proximal colon. Of course, in the left hemicolon with the big sessile lesions, I think that it's preferable to remove those by ESD. This is because if you have a 4 centimeter big sessile polyp and you put your big snare around it and resect it, you're going to end up with an immediate horrendous hemorrhage, of course, which is going to take ages to sort out. And I think it's more elegant to dissect through and then deal with the vessels as you approach them by ESD. You can do it in a more kind of controlled and relaxed manner rather than this smash bang, oh God, it's bleeding kind of approach. But of course, in the proximal colon, you have the issues with the difficulties in dealing with doing ESDs in the proximal colon. So there, I think even a big sessile lesion, you might have no option but to remove it by piecemeal EMR. I do worry though about lesions which look a little bit kind of dodgy, I should say. They might contain cancerous change. I worry about removing them by piecemeal EMR in the proximal colon. Not because I feel sorry for the histopathologists wrecking their brains about diagnosing cancer. They can diagnose cancer. Whether they can diagnose cancer at the deep edge is a different matter. Now, my main worry is that sometimes when you remove a big lesion from the cecum, you might end up with 10, 15 fragments, maybe more. Usually, it's very difficult to fit more than half of them into your retrieval net. Do you feel lucky? The one that showed that this is cancer, is that in the piece that you managed to retrieve, or is it in the one of the pieces that you dropped on the way out or still floating around in the cecum? Difficult, and quite often at the end of a long difficult procedure there simply isn't an opportunity to soldier back in again, unless it's done under GA of course, to soldier back in again and go to the cecum and retrieve another trawl of the lesions, and that worries me. And that's an argument for single fragment resection of dodgy looking things in the proximal colon. Now, I have it like a dial in my mind, I think. I think all of you have it like a dial in the minds. And if you have an elderly patient with significant comorbidities, or if the surgeon said, look, this patient's not he's not a surgical candidate, my dial swings towards abort, so nudges towards abort before I even seen the patient. And then when I do the consent and the patient tells me he's had a bad experiences before, or he doesn't seem to trust me, what I'm doing is the right thing, I swing towards abort. Patient who cries out when I intubate the rectum, I go far towards abort. But a comfortable, relaxed patient, even if he's elderly with comorbid, he's relaxed, he's comfortable, it's good access to the lesion, I will remove a lesion. I find myself swinging towards attack. But as I said before, a suspicious lesion or a large lesion, which I think may well harbour malignant change, I will swing towards abort. And of course, at the end of the day, to give Jim some credit, a right hemicolectomy is not that a big deal. It's not massive surgery, is it? And quite often it's a quick and easy option compared to a 3-hour EMR or ESD resection. I think that's all I got to say on the matter. Thanks for listening.
Yutaka Saito from National Cancer Center, Tokyo, Japan. It is my great pleasure and honor to be here. No COI. Is ESD necessary only for rectal tumor? This is a paper published in Endoscopy from NCCH. In order to clarify the SM invasion risk, we need to include not only EMR ESD, but also surgery cases for T1 colorectal cancer. In LSTG, there are no correlation in tumor location for SM invasion. The same incident of 15% in right colon and 16% in left colon. This is our recent published paper from CREATE-J group. A total of 2,074 ESDs were enrolled, and finally 14 colorectal ESD in 1,740 patients were analyzed. As shown, right colon also showed 13% SM invasion and 5.6% deep SM invasion. Combining the growth type and morphology, we found SM invasion in 17% of LSTNG and 27% of non-LST in the right side colon as well. Second question, is ESD necessary only for SM1? Even in Japanese multi-center study, the clinical outcome ESD getting better and better in recent 10 years. In a previous multi-center study, including 1,111 colorectal ESDs, a percentage of SM1 cancer was only 10%. 47% were mucosal cancer, and 32% were adenoma. But is it possible to choose only SM1 from these ESD cases using magnified NBI and IEE? I think it is not possible. LSTG mix located in the cecum, JNet type 2A, pit pattern type 4. No endoscopic finding for cancer, but the en bloc ESD was applied for this lesion due to the tumor size. 1,000 micron from the tumor surface due to the destruction of muscularis mucosa. Retrospectively reviewed, this SM deep invasion was difficult to predict before EMR. Another case, LSTNG in the cecum, JNet type 2A or B, type 2B. Pit pattern, type 3L. And 3L or type 5I, low irregular. 5I, non-invasive pit pattern. But during the ESD, we found the severe fibrosis of SM invasion in SM layer. En bloc resection was achieved, but final histopathology showed SM deep invasion, venous invasion was positive. Non-curative resection was achieved. Let's summarize my presentation. JNF2D with non-invasive pit pattern is indication for en bloc resection, not non-elective, but also colon LST need en bloc resection when the tumor size is more than 3 centimeters. ESD for SM1 only is theoretically impossible. In Western countries, magnified pit pattern is not common. Type 5 pit with conventional diagnosis is T1B or deeper, which is not an indication for ESD, but indication for surgery. Therefore, intramucosal cancer larger than 3 centimeters is an indication for colorectal ESD. Thank you very much.
Thank you all very much. They were great talks, which for me just highlighted how complicated our conversations with patients about what the best thing to do is. But actually more positively has also highlighted that they've got 3 really good options here available to them in the right hands for the right lesion. Jim, could I ask you, both personally and because I think because other people would also find it helpful, as an endoscopist, when we're trying to decide whether to remove a lesion or whether to send it for surgery, really what we're thinking about is how difficult that surgery would be for the patient. And as a non-surgeon, I'm often not very good at knowing that. I was very interested in hearing earlier people talking about removing the cecal part of a lesion that was going into an appendix because the appendicectomy would then be easier. So I'd really like to hear from you how much easier is an appendicectomy rather than a cecectomy, what the difference is between a right hemi and an extended right hemi, just where that balance lies and how difficult it is for the patient.
That's a very good question to understand the complexity and the implications, not only for the surgical team, but also for the patient when you offer them the choices. An appendicectomy, we all know, is a very common procedure, quite safe with a very low risk profile. Obviously, things can go wrong with any procedure, but it has a very significant degree of safety attached to it. So doing an appendicectomy is simply fairly safe. A cecal amputation or a cecectomy is something that we often do for non-cancerous procedures. So my question would be how much we are worried about this polyp being a cancerous polyp, because going back again and performing a second procedure, if this was done as a benign procedure and then you find a focus of cancer in it, which means that you have not harvested the lymph nodes, is quite difficult. So if you have a suspicion of a cancer, then you're performing a cancer-based surgery, which will be based on the high ligation of the feeding vessels, and a proper ileocolic or a right hemicolectomy would be the right word to use for that. But if we have enough confidence that it's a benign pathology that we're dealing with, lymph node harvest doesn't matter. Preservation of blood supply will be good because you will have less complications from an anastomotic leak and abscesses because your blood supply is good. And you can perform a very limited cecal resection or ileocecal resection, which is of 2 types. One is if there's an appendix base problem with a polyp, like the case we saw earlier, which is going into the appendix base, you can perform a stapled resection of the part of the cecum with the appendix. So I call it an extended appendicectomy, where you take a little bit more of the cecum and all you need is a 5-minute procedure to fire a stapler and take it off. And that is quite safe without any significant risks attached to it. On the other hand, if we are doing a cecal polyp or a right colonic polyp, which is non-cancerous, we can perform a limited ileocolic resection, which means that you take about 5 centimeters of the terminal ileum and maybe 4 centimeters of the cecum and perform a small joint next to each other. In this case, you will not harvest any lymph nodes, and you have to be confident that it's non-cancerous. The last point is about the role of right hemi and extended right hemi. I think the 2 are seen quite similar, but they have different implications for the patient. And that happens if the polyp or the offending lesion is in the right colon or in the cecum, then a right hemicolectomy, which means that you'll be taking the ileocolic vessels, is a standard operation, and it is tolerated very well. The moment you move that polyp into the transverse colon, and then you're looking at the proximal to mid transverse or distal transverse, you are now going to be taking out the middle colic vessels as well, which means that now the anastomosis is going to sit between the terminal ileum and the descending colon, or the sphenic flexure of the colon. It does three things. One, it adds the complexity to the operation because you have to spend more time to mobilize both the flexures, and you're working very much close to the root of the mesocolon near the stomach, which leads to longer recovery time with functional problems like ileus and delayed gastric emptying. Patient takes a lot longer to recover. And third thing is the function of the patient afterwards. Obviously, you have removed about good 60% of the colon, then the ileodescending anastomosis functionally give patients significant symptoms as well. It might be just some more frequency, but at the worst case scenario, it could be diarrhea as well. And sometimes the way the anastomosis is constructed after resecting the right and the transverse colon, the anatomical configurations can create anatomical difficulties for those patients for the safe passage of bowel contents, creating a partial kink, giving rise to functional obstructions. I'm sorry, but a very long answer, but I thought you asked a very important point as to what the impact of various options could be on the patient, and can you choose a bit more sensibly when you have to choose between an extended right hemi versus an ESD for 3 hours. I will go for an ESD anytime if it was me as a patient, but that's my personal choice.
Can you record this?
Yeah, it's a really interesting perspective. Can I ask both Jim and Yutaka? We heard from colleague Saichiro Abe about duodenal EMRs in the morning and using a combined surgical endoscopic approach. And what you feel the role is in this sort of situation where you've got some complex polyps where you can do either colonoscopic assisted laparoscopic cecectomy or laparoscopic assisted ESD or EMR, and whether you feel that there's a good role for that in the interest of organ preservation and safety. So comments from both of you would be very helpful.
Sure, Sunil, thank you. I can start, and then I'll try to give a very brief answer this time. And this came some time ago, probably about 15 years ago. It's been talked about laparoendoscopic approach for complex polyps, and can we be better in terms of removing less length of the colon and be very targeted of where the lesion is. And I think the technique is very good and safe. You need a good endoscopist and a good surgeon working together. I think where it fell out of favor was the logistics of doing it. And because we all want to work in our home grounds and we like our operating environment, you like your endoscopy suites and you have everything available, you know what you're playing with. For us to come into endoscopy suites and do surgery, or for you to come into theaters and do it with us, have not come across many centers or places where this has been well set up. And that's where it lets it down. Putting gas inside the colon, doing a laparoscopy, it takes some technical understanding by the surgeon to understand the limitation that they will be able to do once you have got the inflated colon inside the abdomen. So there's a technique to it. It's just not combining the two together and making it happen. So people who are interested in doing it should pursue a proper training. And I'm sure Brian will have more experience on that from St. Mark's, and he'll be able to share some thoughts on that.
Thank you, Jim. Yutaka, what about your thoughts on that?
Oh, thank you very much. Now, for considering about the Lex procedure in the colon, maybe the indication is really difficult to choose, because in Japan, also Lex is now going up and up, and the Lex procedure for gastric gist or duodenal complex region is still the procedure, number of procedure is increasing. But in the colon, when we consider the indication for Lex procedure in the colorectum, it is difficult what kind of region will be the good candidate for Lex procedure. And also, if we do the Lex procedure for the complex polyp in the colon, and when the histological result will be the submucosal invasive cancer, so additional laparoscopic surgery with lymph node dissection will be necessary. So considering the patient QOL, if we are going to do Lex procedure for colorectal region, maybe laparoscopic surgery could be the same QOL for the patient. How do you think from the surgeon's point?
So yeah, I think a laparoscopic or robotic surgery, depending on the environment and the circumstances you work in, would be a good alternative. My personal view on this is the where things are going from the surgical side. There's a lot of work going on agents which are going to be specific for colonic adenomas and tumors. So we're going to have a more targeted resection of these lesions with a combined laparoscopic, robotic, stroke, endoscopic approach and a natural orifice approach. With the new robotics platform coming in with endoscopic access, we will be able to use dyes. We have some dyes available that we use now, like ICG, indocyanine green or blue dye, but they are very non-specific. There's one dye that has just come out for PSA specific agent. So it binds with PSA and you can have targeted lymph node resections. Polyp cancers will become very important, that if you've done a polypectomy or EMR or ESD and we are worried about risk of lymph node metastasis, instead of doing a completion right colectomy, we'll just go in and do a targeted lymph node resection, like a sentinel lymph node mapping. And that concept has been around for a while, but there's a recent interest in it because we are getting better at targeting them.
Oh, thank you very much.
Perfect. Just to kind of finish off the sort of surgical endoscopic interface, that there have been developments on the endoluminal side as well, and Japanese colleagues doing balloon-assisted enteroscopy ESD to try and get stabilization in the right colon. We heard from Bjorn how difficult it can be to get stable, and there are a number of new platforms now available to help us, and associated traction devices. Saito Sensei, I wonder if you would comment. It is just possible that not all Western endoscopists are as skilled as Japanese colleagues at ESD. How you think we might achieve your good results? Because while I think we are catching up in the rectum, I know the rectal debate is coming, the right colon is still very thin-walled and maneuverable. Are there pointers you could give us to help us be a bit more endosurgical without needing the assistance of surgical colleagues?
Yeah, of course. Maybe the biggest achievement in the easier and safer colorectal ESD, I think, traction method. And until now, the traction is only commercially available in Japan, but now recently, the Boston Scientific and also as a medical company is selling the traction devices. That is like a surgeon's left hand, making the good traction, and we could see the submucosal layer directly. So in such a situation, we could proceed the ESD safely, even in the right side colon. Another platform, yeah, I think also some maybe single balloon endoscopy or double balloon endoscopy, which stabilize the colonoscope even in a proximal colon, even in a redundant colon. But that is another candidate for safer and effective ESD.
Thank you so much. I think the idea that we might get surgical triangulation in the colon is maybe a great place to leave it. Thank you very much to all our speakers, and I think we're going to move straight into the rectal session.
Yeah, thank you. So can we have our rectal panel here, please? Adolfo, are you here? Good. And Jim and Amin. So Jim, Jim, can you please pay attention? Are you going to do your just stand up talk, or are you going to slide? No slide. Just stand up. Surgeon, very surgical. So shall we go with Jim first and then Amin? Is that right? Yeah. Okay. Two surgeons with two different approaches. So guys, over to you, Adolfo.
So Pradeep, what am I supposed to talk about? TENS or surgery?
Well, for us, both are surgery. You tell us. The debate is about the low rectal polyps, and it's about surgery. We are debating mostly TENS, not surgery.
Yeah.
because it is TEMS which competes with ESD,
yeah,
not surgery. So please use on TEMS.
Thank you. So I probably will share a little bit of both in that sense. I think that the debate for rectal polyp will be a little bit more easier, I think, as compared to the colonic polyp, because I think the skill set and the technology is a lot better on the endoscopy front as well for rectal polyps, and some very good quality work is coming out with EMRs, ESD, and local resections, which makes life a lot easier for us. When I have a chance to work with Pradeep in my unit, it's a lot easier because we know they can tackle most of the problems, and we only get referred things that are really complex in that sense. Nationally, in the UK, there's been a big move towards having a national polyp MDT at local level, and the significant polyp, which is a SPECT, it should be discussed. Anything between above 3 centimeters in size should be evaluated properly, discussed in an MDT to come up with the right kind of way to manage it. The prerequisites for this will be, we all agree that anything which is more than 4 centimeters would probably be better off assessed with a pelvic MRI for muscle invasion, but MRI does lose its ability in the lower rectum. So if you're looking for T-stage more accurately, combining or complementing that with a endoanal ultrasound is always helpful, because you have a much more accurate idea of a T-stage. And often we have sizable polyps, 5 centimeters or 4 centimeter rectal polyp. You do an MRI and they stay at the best is T1 stroke T2. And you do an endorectal ultrasound and you find no muscle invasive features at all. So you can be very confident that if it is T1, SM2 or SM3 at the best, and ESD would be very well placed to tackle that in that sense. I think the 2 or 3 things I can say in this context which are relevant from surgical point of view, and which comes to the MDT quite often. I'm quite lucky that I work with Pradeep in that MDT. So we have a great collaboration, and we know that the workup is always done to the proper levels. But often we get out of area referrals where patients have not had a baseline MRI with a large polyp. Now you have done a polyp EMR or ESD, and now you find that there is a focus of cancer. You're trying to go for a post-treatment MRI. What is fibrosis? What is post-op healing? Lymph nodes enlarged? Were they present before or not? It's all sorts of dilemmas for the colorectal MDT at that stage. Could be resolved with a workup before taking those polyps on. In the lower, well, TEMS is something that I've been doing for some time, and TEMS is obviously local excision. The technique is not new. Since 1980s, it's been going on. Those of you who have seen TEMS probe, you have to see it once and you will not want to see it again, because it's such a massive piece of kit, about 4.5 centimeter diameter probe that goes into the anal canal. You have got an operating microscope attached to it. You get a 3D view as a surgeon sitting down and looking, and then you're cutting, and it's beautiful. The views are really good. And the depth perception is very good, because you can go full thickness or partial thickness depending on what you're trying to do. And then you can suture it as well. You have the ability with the instruments to suture. Ergonomically, it's quite a challenging operation. So imagine somebody who's tall and leaning forward and sitting on an operating microscope and trying to do it for an hour or so, 90 minutes. It's still a lot of ergonomical challenge for those people who are working in that situation. TAMIS is used as TEMS, which is straight instruments with laparoscopy, and you have a gel port and you can use those instruments. You're looking at a big screen. The problem with that is that you lose your 3D view, because only seeing it in 2D unless you have a 3D scope and glasses on. And then you're looking at a bigger picture and you're operating in a small area. And that conflict in the brain creates a lot of conflict for the surgeons who are not used to TAMIS. So it's not an easy technique that you can just pick the tools up and start resecting polyps endoluminally with the laparoscopic approach. Robotics has put a new spin on it. There are robotic platforms available which can access the lower rectum up to 12 centimeters to 15 centimeters. And then you get the triangulation inside. You have 3 arms. The basic Achilles heel for us is the triangulation. Can we have the retraction with the 3rd arm? So putting that on a retraction and then working with the 2 arms and then suturing with the endorist instruments inside makes the ergonomic challenges quite simplified. So watch the space. There's a huge development happening with new robotic platforms coming for transanal access, which will make a local excision a very quick procedure. I've been using the robotic platforms that are already in place for transanal resection of these tumors with TEMS technique. And we have shown that the operating time for these procedures is no more than 30 minutes. The biggest part of the operation is getting the patient in the right position, right lateral, left lateral, face down sometimes to get the legs out of the way, bring the robot in, attach to the ports and put the gel point bath in. And then you have 3 arms inside to retract, cut, dissect, suture. The actual operating time is 30 minutes or so. So if that you are comparing with an ESD of 2 hours or 3 hours in the rectum, yeah, you have to then have the facility. expertise, availability of time, and aesthetics to do all those. And then I think it's more generalizable technique to train people. I'm not sure my colleagues will tell us what the learning curve for ESD is. It is a complex procedure and will take you enough number of cases and volume to learn that. But doing that with a technique which is safe, simple, quick, and can be taught easily, you can train more surgeons in a DGH setting who can do those kind of things. Last 2 points I want to make about the decision making in this, because in the upper limit of the rectum is fine. You can get up to 15 centimeters. You can be intraperitoneal. When I'm doing thickness resection, we can be intraperitoneal planned, and you can suture and close it, and you'll be surprised how much you get away with it without defunctioning these patients. So they don't necessarily need a stoma. The key questions are, do you need a full thickness resection or a partial thickness resection? I think for TEMS, with the transanal surgery, and I have kind of carried on that service in Portsmouth. In fact, you don't need it because we have got Pradeep who can do pretty much everything with endoluminal approach. So you can argue why you need TEMS surgery, but we have kept it going for selected cases. And you can resect full thickness. I will not need to do partial thickness resection with TEMS, because if that's the case, I'll be going down the route of ESD or EMR in that sense. But if it is a full thickness resection to get a single specimen for the pathologist to tell us about the tumor characteristics, invasion, margins, then a full thickness TEMS resection is the best way to do that. And the pathologists love that specimen because you get all the information from that. We can suture close the defect, so the problem with sepsis and leaks are not there. Our results from TREK trial got published in Lancet a few months ago. The Star Trek trial early series is coming out in ASCO meeting next month. So watch the organ preservation approach to rectal polyps, which are significant and cancerous or potentially cancerous. It is a good approach to remove them, also in combination with some neoadjuvant treatment, which could be short course radiotherapy. So if I have a T1 cancer or T2 cancer in the rectum, the patient is fit, we can consider short course RT, delay of 6 weeks, and then perform local excision with TEMS. The only place where I will want surgeons who are in the audience or listening to this to be very mindful of these kind of full thickness TEMS resections is in the very low rectum. That is something, and now I see it all the time with the endoscopic approaches. On the dentate line, it's not an issue. You can dissect from there upwards and take it all out. The difficulty for us is a positive margin at that level changes the whole scenario for that patient, and the choice between a reconstructive operation with an ultra low anterior resection and intersphincteric coloanal anastomosis is gone once you have done a TEMS with full thickness excision at that level with a positive margin, or you've done an ESD for the sake of argument and you got a positive margin, then those planes are gone for the surgeon. And that choice of an ultra low with a reconstruction option will be off the table. And similarly in women, anteriorly behind the vaginal fornix, the tissues are very, very thin. So again, an aggressive ESD or a TEMS in that position will have a risk of fistulation on one side, but going back in to salvage that with an anterior resection is not that easy. You end up with fistula of the vagina, and healing is very poor in those areas. A lot of data coming out that the salvage surgery after TEMS or after ESD, when there's a complication in positive margin, is associated with poorer outcomes long-term as well, just because the technical difficulties you face. You can deal with them easily. It is higher up in the rectum, but when you go right onto the lower rectum, last 6 centimeters, 2 centimeters above the levator is the Achilles heel for us as a surgeon. But thank you.
Thank you. We're going to listen to Amin, and then we can have a discussion later on. Please, Amin.
Presentation. I've got a short presentation. I just wanted to summarize really, an approach to managing these rectal tumors. There we are, and share a few slides. Let's start with that. That's great. So I think, I could stand here talking to you about data, pro ESD versus data pro TEMS, but the difficulty with a lot of the randomized trials is that, first of all, they're not very many. And the ones that are there, we're not really comparing the right sort of lesions in terms of, we're really comparing apples with pears in terms of what the morphology of these lesions are. So I'm going to spend 10 minutes really talking to you about a practical guide to decision making. And the disclosure for me is that I do both ESD and TEMS. But interestingly, over the last 10 years, the amount of TEMS that I do is very, very low, and probably about 5 or 6 now a year, whereas it used to be about 30 or 40 a year. So I think rectal polyps are a special case. And the reason for this is because we know that surgery in this particular complex area can be with complications. So we need to make the right decisions for patients. and ensure we make the best decision first time rather than redo surgery after doing a full thickness resection. So that initial decision making is very, very important. And I think in terms of TEMS or TAMIS, I think there are two groups of surgeons in the UK. There's one particular group, which is probably the majority, is that we would just do full thickness resection for all comers. All patients that would have rectal lesions, they would have a full thickness resection and suture that close. And then there are a few amongst us that would do a transanal approach with injection and submucosal dissection using diathermy. And that's the same plane that you would be for ESD. And I think you need to those two are really important, because I want to talk to you about planar dissection for the next few minutes. And also then you can compare, what the optics are with the laparoscope and what the optics will be with an HD endoscope. And you'll find that actually the optics using the endoscope is much more superior in terms of getting close to a lesion into the submucosal plane. In terms of outcomes post-ESD, this is borrowed the slide from Noriko's talk. Really, the outcomes post-ESD, the perforation rate, I think Bjorn was saying about 1 in 20, that's really intraprocedural perforation, but most units now will have a perforation rate of less than 1%. In our particular data, 1 in 300 patients would have a perforation that requires surgical intervention. So low risk. And delayed bleeding as well. In most series, the risk of delayed bleeding is very low, and less than 2% would be the quoted in most expert centers. So in terms of rectal polyps, what do we do? Well, we need to actually evaluate these very carefully. And this multimodal endoscopic evaluation is the key. And what we would do is look at morphology, we would magnify and look at the magnification, and then we'd also do ultrasound in addition to MRI. So this is standard for all patients that have rectal lesions. And then you make a decision, what you need to do in terms of TEMS or ESD, or we would not do any piecemeal resection in the rectum. So that assessment is, I think, of paramount importance for rectal lesions before making a decision. And if you look at the endoscopic evaluation is the most important rather than biopsy. But interestingly, MRI also is very good in expert hands. So if you look at a lot of Gina's data, Gina Brown's data, the actual local staging for MRI is extremely good in her hands in terms of looking at T1 SM deep invasive cancer or not. So, but endoscopic evaluation is much more sensitive and specific for looking at these lesions rather than biopsy. So do that well. And of course we would magnify, and then we would identify which ones are cancer. We would look at JNET classification and then make a decision. But these are the type of lesions that we'd see in the rectum. So we have to make a decision about what we do with them. And actually in the rectum, it's all on block because even the LSTG homogeneous type, and this is the data when I was at Show University with Professor Kudo, even if you look at the data for the large LSTG homogeneous type, which is greater than 40 millimeters, in the rectum, it's just too risky, that 2% risk of cancer. And therefore, we would need to do en-bloc resection in the rectum. Because if you have piecemeal resection in the rectum, then that means you're subjecting the patient to quite a major operation. So really, this sort of argument is in the rectum, always do it en bloc. And so practically, this is what we would do. Let's think about plane of dissection. So if we've got benign pit or 5i in the rectum, and we think this is endoscopically resectable, then actually we would stick in the submucosal plane. And you may want to use ultrasound to help you with that if there's some difficulties. And we saw that Yutaka was talking about that even if you've got LSTG with small nodules, mixed nodular type, and you've got benign pit, you sometimes miss that deep submucosal invasive cancer using even magnification endoscopy. So the ultrasound really is saying, is the MP clear? Can I stick in the submucosal plane? And these patients would have ESD. Now, if you've got 5i pit or 5n pit in the rectum, then we need to think about what sort of plane of dissection I need to be in. Because I think if you subject all these patients just to doing TEMS, then patients who need subsequent surgery after TEMS, we know that the data for doing low anterior resection is, there are much higher complications with that. It's much more difficult to do low anterior resection after doing full thickness resection, particularly if it's an anterior tumor, particularly if it's a low tumor, and you may subject these patients to having an AP. So we need to think about, are we going to stick in the submucosal plane by ESD, or can we convert to even going intramuscular using ESD to preserve the longitudinal fibers and to preserve the mesorectum? So it's all about, I think, preserving the mesorectum as much as possible if the patient's undecided regarding subsequent surgery. So what we would do in that situation is we would do ESD, and then if the patient wants to have local resection and have organ preservation, and they're absolutely certain about it, fine, you can go on to do full thickness TEMS and do chemorad. Patients make the decision. Or if they're not sure and they want to make a decision based on histology, let's preserve the mesorectum and stick in the submucosal and intermuscular plane. So I think that decision about preserving the mesorectum is really important. This is an example. This is a lesion you can see. It's deep submucosal invasive cancer. It's been previously treated, and the MP is clear. And if you look at the top left image, what you'll see is that's a still image of during ESD, and you can see that it's in the mid submucosa. You've got a plane just below that, and it's very similar on the ultrasound. You can see the plane that the MP is clear. And here, actually, we're preserving the muscular fibers. And this is an SM2 invasive cancer that doesn't have any other prognostic features, and the patient can be treated endoscopically. So really important to then make a decision about we're going to stick in the submucosal plane, because a patient may want to go on to have laparoscopic surgery. We don't want to disturb the muscular fibers for subsequent resection. This is a patient actually, who was uncertain about whether they wanted to have a laparoscopic low anterior section. It is biopsy proven cancer. And when Gina Brown looked at the MRI, it was a T1 cancer, but he was not sure about whether he wanted to go for an anterior section. And actually doing a TEMS very low anteriorly there, what you would do is you destroy the plane for subsequent resection. So what we did here, and you can see that in the bottom left image, is that you've got that very small intermuscular section, just a tiny amount anteriorly, which you can see the longitudinal fibers there. And this was actually SM3 invasive cancer, clear margins, no vascular invasion, and now the patient is really making a decision whether they want to have watch and wait, or they go on to have lymph node harvest. They're not going on to have lymph node harvest, but if they wanted it, we could do it, and we could do it safely with a TME after. Similarly here, and if you've got a cancer which is present, we can identify exactly where it is. And if you look at the previous image, then actually this could be a cancer which is 6-7 centimeters in the low rectum from the anal verge, and therefore the patient can go on to have a laparoscopic low anterior section. So doing a full thickness resection at the start, you're going to destroy the mesorectal plane completely. If you've got circumferential lesions or very low lesions, really important here to stick in the submucosal plane, because we need to ensure that we can go back and do an ultra low with a coloanal anastomosis if the patient wants that in terms of lymph node harvest. For circumferential lesions, I think TEMS is very difficult, to be honest with you. So I think circumferential lesions, we need to do ESD because these lesions are very challenging, and doing it circumferentially with TEMS is extremely challenging. So endoscopically, this is the right approach. Multiple tunnels, and then you do a circumferential resection. And of course, then you've got the challenge of trying to dilate the rectum, which will actually stricture because there's 100% circumference. If you've got scarred lesions, again, if you full thickness resection is very difficult, because you may, if you have incidental cancer, then patients particularly will have more difficult first TME. So we would do ESD. Post radiotherapy, these patients, you stick in the submucosal plane, and you preserve that mesorectal area. So I think the most important aspect is just preserving the mesorectum. It is the holy place, and I think we need to think about what the consequences are of doing full thickness, for the patient. So what we would do really is have a very, very detailed discussion with the patient and understand what they want to do in terms of lymph node harvest. We would actually present different scenarios to them before embarking on this. And if the patient says that they're happy with a 10% risk of lymph node metastasis, but they don't want to have any surgery, then actually you could do full thickness resection and then chemoradiation. But if they're not sure, then we need to stick to that plane of resection. And I think endoscopic diagnosis really is a key for that appropriate decision-making, whether we go for ESD or TEMS. Thank you very much.
Thank you very much for two excellent talks. So I think probably in Portsmouth you have expertise in TEMS and ESD, and it can be difficult to decide maybe in your spec. However, in areas where there's expertise in one of both techniques, it might be easier. How do you decide upon the strategy, Professor Khan, in Portsmouth in your spec MDT or lower MDT when you have expertise in TEMS and ESD?
Thank you. That's a very good point. And many places do not have advanced expertise in both. And sometimes you have to look at the regional network to see who do you partner with if you want to run a service like this. We are quite lucky, as I said before, that we work as a team, and those complex decision making have to be done up front. So it's all about informed consent and knowing what options are on the table for each polyp. So we have a polyp or early cancer MDT where Pradeep joins us, and we have a radiologist. We have the same team treating those patients. So discussing them up front, making a decision, and as presented very nicely, that you can have sometimes more than one option for those patients, and no two patients are the same. They may have different approach on how they would want to be treated. So the mistake that can happen is because if you have one expertise available and you just focused on that and you present, or you end up presenting unknowingly a slightly biased view of your options, then that can disadvantage that patient if you have to then send them elsewhere later on. So having a knowledge of what is available, what are the implications of your actions, what else could be on the plate. And if you want to run that service, I think my advice would be to network regionally with your colleagues if you don't have advanced ESD service in your own hospital. You have something to.
No, I think just echo what you say. I think it's, I think, what we've spent. So we have we're quite very fortunate. We have two, early cancer nurses and complex polyp nurses who spend a lot of time with patients prior to them having an ESD in the rectum, particularly. We spend a lot of time discussing the different options. And actually, we really want to know, what they would do if there was cancer. Because there's no point really doing a very long resection. A lot of the circumferential lesions, for example, there's no point doing a very long resection, which may take 3-4 hours to do that circumferential lesion, if the patient would say to you that they would actually end up wanting to have surgery and lymph node harvest. So I think understanding what the patient wants at the start and that informed consent is so important. So we spend a lot of time on that.
Exactly. It's a quick point on that. On what Pradeep does very often with me is that he will see a patient, for example, and if it is a doubtful lesion, which is not very clear, maybe cancerous, but you have got some concern, but you feel enough confident that you can take it on and you remove it, and then we'll bring it back to the MDT after that. But if it's a lesion that he's worried that is obviously a cancerous lesion, or he has enough concern that it is cancer, he'll send it to surgery for us to discuss that, see the patient, explain the option, and we may end up going down back the same route of ESD for that patient, because it may be a frail patient or comorbidities, or surgery might not be the best interest, or the risk of complication might be very high. And then they either get a TEMS, for example, a T2 cancer may not be fit for surgery, and we end up having many who are not fit for a low anterior resection or a stoma, but can have a local excision with full thickness. So my practice with TEMS, I'll echo what Amin said, that the numbers have decreased over the years. We probably do about 10 or 12 a year now, and it's all for cancers who are established cancers beforehand, such as T1 or some T2, where we don't want to do major anterior resection for those. But when we get into T2 realms, we like to use adjuvant or neoadjuvant treatment in those settings, because the risk of lymph node metastasis is obviously 20% or above in those.
Thank you. Unfortunately, we don't have our ESD and TEM surgeon both built into one brain. And so I have Chris Cunningham with me, who's an excellent international recognized TEM surgeon. Certainly often we assess lesions together, endoscopy. One of the things that often comes out in that is this issue about positioning the rectum. And endoscopists are terrible at describing this. Surgical endoscopists are very good, but medical endoscopists don't perhaps completely understand the importance of whether things are anterior or posterior, and how much fat and plane there is, how low they are. And I was interested in this idea of using EUS for low rectal lesions, which we don't have easily available in Oxford at the moment. But certainly, my own experience is, if you can feel the bottom of the lesion, when they feel gritty, it's time to call the surgeon. Do you want to maybe just take us through this anterior, posterior, how high you can go with the TEMS, and the choices to go and grow? Because I think certainly for us in Oxford, just that anatomical thing, above and beyond perhaps some of the vision factors we talked about, drives quite a lot of our decision. Or if you just think it's all ESD, that's fine as well.
Take that.
So I think it's all very relevant, and we spend some time, and especially I think that there's a huge value in combined assessment of these things together. So we started EUS service in Portsmouth some years ago, and one of the key pillars of that service was that we will have a combined assessment with the gastroenterology colleagues at the same time when you do the ultrasound. So you get, I call it triple assessment of low rectal polyps, and you basically put a finger in, you feel for and see the fixity, location, how much mobility we have here, and relationship to the sphincters. Then you perform a flexi-CG and assess the same thing, and you have the endorectal ultrasound at the same time. And then you have the benefit of having a gastroenterologist and a surgeon together to come up with the right approach. And we have a flow chart where we look at all these three things together, and then you either get EMR stroke ESD, TEMS, or you go for a low anterior resection or AP in some cases, because the lower limit, as you said, is very crucial as well as to how far it is from the sphincter complex. Is it going into the intersphincteric plane or not? So I think good units will have a good structured performer for reporting of these cases as what is the key information that you will need as a surgeon and you will need as an endoscopist to know before you can make the right call. So having a dedicated performer always helps. The last point on the distance and the location, and I'm probably going to be slaughtered for this, but I've done 2 cases in the last 6 weeks where the lesion was at 30 centimeters and 20 centimeters on endoscopy. And actually when you go in, it is 5 centimeters, 8 centimeters, 10 centimeters. They're big patients, the buttocks are big. And when you're in a dark room, putting a scope up, and I would say most of them have been done by outsourced endoscopy services, trying to rush through the cases quickly. But for a surgeon, that distance matters a lot because you have then now a tattoo in the rectum. When you have planned for a high anterior resection, patient is probably not even planned for a low anterior or a stoma, and the operating times could be different. So it has implications for those in terms of the height. And that's why we often end up repeating the flexible sigmoidoscopy to assess the actual site of it. In terms of the relationship of the anterior, posterior, how high, how low, I would like to see what Damien thinks on this, because that is very crucial as well in terms of your patient positioning on the table, especially if you're doing TEMS.
Yeah, no, I think, and I think I think the easiest thing, what we tend to say to a lot of our trainees really is just put patients supine. And then when you're assessing endoscopically, and then see what the fluid is. So the fluid is posterior, and that's what the lesion is. You know, it's posterior. You can then work out where you are, anterior, lateral, or posterior. So if you're obviously, once you get good at this, you'll be able to tell on the left lateral exactly where you are. Going left is more anterior, and then right is more posterolateral. So you'll be able to do that. The second thing to say is that insufflation of the rectum actually sometimes can be a bit confusing in terms of location and distance. So what I would also recommend is is to deflate. To look at the lower margin of the rectum and see where that lesion is, the lowest limit is, because often, people will say it's 12, 15 centimeters in the rectum or 10 centimeters in terms of where the lesion is, but actually it's much lower. So deflate, you supine and use fluid.
And we use the clock face as well. I think having a clock face in a lithotomy position to describe the position of the lesion is the ideal. And I hope that there's a consensus. Maybe this event should look at having a uniform language for reporting those things, because you have to be mindful when radiologists look at the scans, they are looking in an inverse way from the scan from upside down. So often when they say 3 o'clock, that means 9 o'clock for us as surgeons looking at it from below. So having a common language prevents all those complications that can happen because of mistakes.
Any questions from the audience? Yes, Cesare.
When I came to Milan, I was locked in the room by our surgeon who started to complain of too many cases who had an ESD attempt and came out with either an aborted procedure for deep submucosal invasion or with an outcome of deep submucosal invasion. So is he fully crazy or not? So is the rate of deep submucosal or even deeper invasion a quality indicator for ESD indication first? And secondly, does this outcome worsen the prognosis of next surgical treatment, yes or not?
So if I understood how common it is to get the submucosal invasion after ESD. Yeah. Is that do you have more experience on that?
Yeah. So, do you mean that when during the procedure you may change your plane of dissection because you stop?
Because you like to
Too deep.
Stop the procedure.
Yeah.
And you call the surgeon.
Yeah, I mean, I think you know, we would obviously in our practice we would know what that patient would want in terms of their treatment. So we would have already made a decision whether we would be going into muscular, if it is deep submucosal invasive cancer, or whether we'd be going full thickness. If we are going full thickness, I prefer, you know, I prefer to do that in the smallest area possible. So, so what I would do is endoscopically resect my ESD and then just go full thickness in the particular area that we deal with and suture it endoscopically. If it's a very large lesion, but if it's a small cancer, you could just do that full thickness from the outset, you know, with TEMS. But I think during the procedure itself, I would not stop in the rectum, because we would actually, unless we know that the patient wants to have surgery and we didn't think it was a cancer and it was an invasive cancer and we've unexpected. In that situation, yes, do stop, take a biopsy to confirm that it's cancer, and then the patient can go on to have you know, laparoscopic TME. The MRI is very important before. I would really recommend everybody, even if you think it's a benign rectal polyp, to do an MRI for all lesions, standard practice. Because if you look at the MRI and if you do it after the procedure, you're going to get some artifact. You're going to get some stranding, you're going to get lymph nodes that are big. And if you've got a baseline of MRI for benign lesions, then actually your radiologist will start to learn about what benign lesions look like. And they won't overcall this being T2 or T3 for a tuberculous adenoma in the rectum.
If your polyp workup is working well, you will not have to encounter that situation very often where you have to stop. I think in the last 15 years, Pradeep has probably called me once or twice when he was doing something, an unexpected finding, and he thinks it's cancer. And you have to make the right call. As they say, that the decisions are more important than your approach and technique. So you make the right call for that patient in that scenario, whether it be surgery or local excision.
Thank you very much. It's been a very exciting session. Thank you for the talks and the questions. And
yeah, I think when we have two surgeons and a rectum, this talk can carry on all day. So we need to stop it, guys. They need lunch. So thank you very much. Lunch is next door, guys. We will be back in 20 minutes. So please bring your lunch back in here. There's no problem. Haynes say? Yes, Haynes. Well, we see UG here as well. So he,
Pradeep.
Oh, Mike.
Are you, Ichi? Are we in the right room, Pradeep?
No, we are not in the right room. I cannot find the appropriate link to the different room.
Yeah, this is the link I was sent.
Yeah, I think I'll go there. Can Michael hear me? Michael and Yuchi, you here?
Yes, I can hear you, but I don't have any link to the room, unfortunately.
Sorry, Yuchi, what are you saying? You don't have the link?
No.
Well, the link brings us here. I've got the same link as Yuichi, Pradeep. It brings us to this room, the link when we click on it.
Sorry, let me hear this clear. Guys, can you pay attention? Sorry, is that Michael speaking?
Yes.
Michael, you have the link and you're live with us?
The link that Yuichi is getting is the same one that I get, and it brings us to this forum.
So are they in the right forum? So I can see you on our screen. I don't know if this is the right forum. So Yuchi and Michael, both of you are in the right forum.
Okay.
We've been
Okay.
running late.
Sure.
So everybody's gone for lunch. They'll be back in 5 to 10 minutes. So if you haven't had your lunch while it's breakfast for Michael.
No, I'm in Italy.
Where are you, Michael?
I'm on Lake Stresa.
Oh, wow. Okay. So just bear with us for 5 minutes
Okay, boss.
and stay on the same link. You're in the right place.
Okay, fantastic.
Thank you very much. See you later.
Michael, looks like I need to congratulate you. I forgot. I didn't hear that very well. Mike.
Congratulate me on what?
Well, I've been told you settling down, Michael.
Oh, I did get married, yes. And so last week after ESGE, we had a mini honeymoon in Venice, knowing that I was going to be coming to Lake Maggiore a few days later. So we've been in Europe for, myself and Vivian have been here for 2.5 weeks. It's very nice.
Wow, fantastic. Well done, man. Finally, time to settle down. I'm really pleased.
Thank you. I appreciate it.
Thanks. Cesare is joined as well. So we're going to start very soon now.
Oh, trouble is here.
Mike, are you coming to live in Italy?
Yeah. Didn't your wife tell you that I'm renting a spare bedroom in your home?
You will be welcome.
But yeah, but Pradeep is also moving in.
So where are you now? In Venice?
I'm in
I lost you. The connection is not very good.
But I'm near Milan.
Sorry, the connection is not good. So where are you now?
I'm in Stresa.
Ah, you're in Stresa. Yeah. It's very nice, Stresa.
Yeah.
I like it. I like it.
Yeah.
Yeah, it's a bit ancient, but it is anyway very nice place where to be.
It is ancient, yeah. I think I'm meeting your fellow on Friday in Milan.
Oh, yeah, he's superb. He's overactive. I mean, he does, I don't know how many publications every year. It's pretty crazy.
Right.
And when are you coming to Milan?
Friday morning.
Ah, Friday morning. Okay.
Yeah, I think I'll miss you. You're in Rome. Hey, is my I sent a recording last night, Pradeep. I think the connection here is not great.
Yeah, maybe it's better to send the recording. Yeah, I will sort it out. Yeah. Okay. Ciao, Mike.
Okay.
Yeah. Talk to you later. Ciao.
You're running very late, so who's just chairing the next session today? So Colin's not joining. So who's it? So that. So John and John and James.
These skills, people. We're not getting paid for it. And stereotyped decision making. What happens when it goes wrong? That's the problem. Cesare, he's the main man. You better sneak in somewhere near the middle.
Yeah. Looks like we're live. Okay, welcome back, guys. Thanks for joining. Now we have the most exciting session of the day. This is the future of endoscopy. Looks like artificial intelligence is coming in a big way in endoscopy. I think the way we practice, the way we treat is going to change. And so we have lined up one of the best panels in the world of AI for you to understand where AI is going in colon. So welcome to our panel. John Anderson is standing in for someone else, but I know he's not an AI expert, but he's a colon expert. So John, your practical thoughts will be welcome. James East, professor of gastroenterology from Oxford. I don't think he needs any introduction. So thanks, James, for joining. And our Einstein, Cesare, Cesare Hassan. He just lives AI, he breathes AI, he eats AI, dreams AI. So he's just AI, nothing else but AI. It's a great pleasure to have Mike Byrne. Mike is an entrepreneur. He happens to be in the AI world, but he is an entrepreneur who seeks opportunity where things can go in the future. He has a special sense of smelling these things out. I'm sure Mike smelled this a long time ago and has been doing a lot of work in the world of AI. So Mike, thank you very much for joining us. Yuchi is a phenomenal guy. I think we knew Yuchi Mori from working with Professor Kudo and Kudo's pit pattern. And from there on, Yuchi has evolved into something big. So Yuchi, I know everybody recognizes you from Japan, but tell us where you are nowadays and what you're doing.
In Oslo, working on clinical trials dedicated to AI in terms of the cancer prevention. That's my goal.
Thank you very much, Yuchi. Brilliant. I think we're going to have a great session. So who's going first? The talk is by Chesbury? Yeah. Okay, Chesbury. Can someone help Chesbury put the talk on? You know?
Yeah, I am artificial, but I can manage.
Can you manage this?
Yeah, don't
Oh,
worry.
wow. Looks like Chesbury knows what he's
It's,
doing.
it's,
Okay.
it's an ESD, okay. It doesn't work. Like this.
I think my team just make us dependent on them.
Yeah,
Otherwise they lose their
that's
job.
exactly. Yeah. Okay, I apologize.
They just too clever.
You make me very nervous. Ah, share screen. Okay.
Share the screen. Yeah.
Okay, it's easy. Okay, thanks so much. Yeah. Yeah. Okay. Okay, so I guess that in these 2 days we realized that advanced resection is very operator dependent. Our goal is to make this different for diagnostic endoscopy, at least, to make it operator independent. And I guess that we are very close to that. I guess that there is no need for us to remind why diagnostic colonoscopy is operator dependent, because we miss too much neoplasia and this become cancer too often. In addition, there is too much variability among us. It is unacceptable that a patient go in one center and have a different cancer protection from another. This is the most unacceptable data in colonoscopy, in my view. And this is that even a very good endoscopy still miss 1 every 3 polyp. Would you ever have a mammogram from one radiologist who miss 1/3 of breast cancer? I guess no. I guess most patients don't know this data. If they knew, they would be really worried about it. And this applies to both proximal and distal colon, so there is no excuse for us, flat or whatever it is. We are just missing polyp. And irrespectively of the risk of post-colonoscopy cancer, there is no doubt that the proportion of post-colonoscopy cancer that is due to a missed lesion is extremely high. If I remember the post-colonoscopy cancer I had, most of them were in patients without any polyp at index colonoscopy. So it's true, incomplete resection is a cause of cancer, but incomplete resection is something that you can deal with. The worst is when you do a completely negative colonoscopy and then the patient come back after 2 or 3 years with a post-colonoscopy cancer. These come from the FIT program in Italy. These are our best endoscopists. And as you may see, it is really ridiculous that in such a homogeneous population, there is so much variety of adenoma mutation rate. And remember that ADR is strictly correlated with the advanced ADR in FIT program. Do we miss neoplasia because we don't spot it on the screen? Yes, we do. This is the Chinese tandem trial with the retrospective evaluation of all the cases. And they realized that 1/3 of the miss rate is actually due to lesions that are on the screen that are not spotted. This is the retrospective evaluation of the methylene blue study that was done by the best endoscopy in the world. And we found a lot of diminutive flat lesions that were actually missed by this endoscopy. Probably in this screen, in this video, there are 2 lesions that were missed by the endoscopist. Why artificial intelligence? Artificial intelligence because it doesn't learn from human as EndoBrain from Uiki did, but it learned directly from data. So deep learning have an infinite potential to grow, because the more data you put, the better output it gets. And it really does it in real time. This was the first prototype of GI lineage that we created from that study that you saw from the methylene blue. And this is somewhat something we are proud in Italy for. How many cases do you need to do a very good AI? This is completely unclear, and I really blame companies because they don't want to reveal this data. I counted from the literature that, for instance, the GI genus was trained by 3,000 polyps, but I don't know if at this stage they are still 3,000 or they are 30,000. The same with any device. So I would really invite all the company to unveil how many cases they put in and the clinical characteristic of this data, because of course the training influence the detection. I mean, the way it detects. If we look at the standalone performance study, that is the ability of the machine to recognize neoplasia that was detected in the first place by expert in a sort of not randomized but controlled trial, both for detection and characterization, I guess we are very happy. In a very few years, any machine is able to detect most of the polyp that would be detected by Doug Rex. In the last study by Doug Rex on gastroenterology, the machine detected nearly 90% of the polyp. Doug was able to detect after 40 years of long lasting experience. So these machines are extremely good. There is no reason why we shouldn't have one in our center. But this does not mean that they are actually useful to us, because the exam is an interaction between ourselves and the machine. So maybe we can discard the true positive of the machine. A very stupid error, but it can happen. But maybe we can compensate a false negative. For instance, in the experience by Doug, he was able in 2 cases every 10 to detect a polyp that the machine didn't detect in the first place. So it is an interaction where you can improve the machine and vice versa. And then there is the issue of false positive, because this may worsen the efficiency of a colonoscopy, and it is time consuming. So for this reason, we need 2 types of study. Despite I dislike the tandem study because they're very boring, very complex, very artificial, they actually come first, because the first endpoint of an AI is not to increase detection, but to reduce the miss rate. So the very basic question is, does artificial intelligence reduce the miss rate? So you need a tandem study. This is the tandem study that we did with GI Genius, but you could have done with any system. And we showed that the AI reduces the miss rate by 40%. And this mainly occurs for diminutive flat lesion, but somewhat it also applies to large lesion or to those that are polypoid. You reduce the detection miss rate more in the distal than proximal, and then there are all the data. 3 additional studies were done, one in US and 2 one in Japan and 1 in China, and all of them were extremely consistent. All of them showed that the decrease of miss rate is about 50%. So every 2 polyp that you miss, 1 is taken back by the system. So the operator dependency of the procedure is reduced by 50%. And this is very reassuring for our patient. But then, of course, after the Kaminsky-Corley paper, you want to know if there is an increased detection. In this case, we have many more studies, probably too many now. We counted 15 randomized trial, randomizing between colonoscopy with and without artificial intelligence. And as you may see, all the data are extremely concordant in showing that there is an increase. And this increase in detection is probably about 30%. So you reduce the miss rate by 50%, and this means that at per patient analysis, every 3 patients, you detect 1 more with adenoma. I guess that the number needed to treat is much less than 10. And this also applies to advanced adenoma, and especially in the FIT population. So you have also an increase in the detection of advanced lesion. Does this system miss size-related lesion? Yes, it is true. These systems are not perfect for SSL because in the training there were too few SSL. But it is true also that we as a human are much worse than the machine. So even a bad machine is able to improve a bad endoscopist. So just now, these machines are able to increase our detection of the size-related lesion, despite we can expect big improvement in SS detection by the machine. If you were interested in the literature of artificial intelligence, you may realize that the Chinese studies came with a basic ADR much less than 20%, and this put a problem. Are these studies biasing our confidence on the estimate of the effect of artificial intelligence? Thus, we did a meta-regression, and we showed that actually this is the case. The lower your basic ADR, the higher the improvement you have with artificial intelligence. This means that if you are very, very expert, like Doug Rex, your number needed to treat is probably about 30 or 40. But anyway, it is less efficient, but you are improving. This is the correspondence between the decrease in miss rate and the increase in detection. You may see that they are going in the same direction. The more you reduce the miss rate, the more you increase the adenoma detection rate, irrespectively of the size, location, and blah, blah, blah. So I get that the literature until now is very robust to support the use of CAD-E. But of course, with UIKI, we focus a lot on the burden of this machine. So the first study we did was a retrospective evaluation of the false positive in one of our study, and the time that you waste for false positive is about 1 minute per colonoscopy. So if your inspection time is 6 minutes, you need 1 more minute. In most of the cases, this is because you didn't insufflate too much, or there is some angulation or some fault. This is ineludible, but it's not such a big problem. This is probably the worst part of artificial intelligence. In the short term, it is going to increase our cost because you do more polypectomy and you do more surveillance. This is the retrospective evaluation we did with the UIKI of all the randomized trial that gave us the data. And you may see that there is a 2% increase in the rate, in the absolute rate of surveillance for high-risk adenoma when you use AI. So this is a problem, but it is not a big problem. The second problem, and this comes also with James, with our cost-effectiveness expert, is with cost, because there is no doubt that the more polypectomy you do, the more money you waste or you spend in the short term. But we hope that in the long term, this is compensated by an improved cancer prevention, reduced cost of cancer, ESD, TEM, and surgery, and blah, blah, blah. And with the CAD-X, you should also further reduce the cost. And of course, Mike Byrne also is very expert in this. So this is the cost effectiveness model that we recently published. And we estimated for the United States a saving of 7,000 cancer per year when artificial intelligence is applied. And this translates in a cost saving analysis. Of course, the cost is now, the saving is in 30 years. So the question is, are we ready to wait 30 years to save $57, or we prefer not to spend in the first place now? This is always a political issue. So the conclusion for detection is that the miss rate and the variability in ADR are universal. Colonoscopy is today operator dependent. We can talk about quality for 2 days, but anyway, quality is wishful. We need something that is more mandatory. And in our idea, deep learning is mandatory. It must, it works. So if you use it, you make it operator independent. The standalone performance cannot do better. After 2 years, any machine is our best endoscopy. The incorporation clinical practice lead to an improved quality, but of course the cost may be a barrier. Thanks.
Thanks. John, before we take a question, can I just correct something that Chazri showed in his old slide, because one of our sponsors picked it up, that Wise Vision from NEC was CE marked long time ago. Chazri, your slide was incorrect, so they just pointed it out. Sorry, I don't want to disappoint our sponsors.
So Pradi, well, I think what we're going to do for this session is we're going to hear the speakers and then have the discussion is what we're going to do. So I think Yuichi Mori's next. Welcome. Good to see you in Oslo. And are we going to run his video?
Yeah, I have submitted some video beforehand. So could you please play back my video?
Fantastic, we'll do that.
Thank you very much. Hello, everyone. I'd like to talk about AI and polyp characterization today. Thank you very much for your invitation, Professor Pradeep Bandali. It's a really exciting topic to be discussed. So I'm going to start my presentation by disclosing my interest of the COIs. And then I'd like to proceed to the presentation of 8 polyps. Actually, it's quite a difficult matter to correctly identify the neoplastic lesions or neoplastic change within the tiny areas of the polyps. So for example, if you look at the right 4 polyps, honestly speaking, they are non-neoplastic polyps, such as the inflammatory polyps or the hypoplastic changes. However, from its appearance, some may say that they would be adenomas. So this is a challenge, and this was actually illustrated in the previous publication by Professor Ladamab in gastroenterology in 2013. The differentiation level of adenomas was limited less than 90%, let's say, in terms of sensitivity and specificity. But how we can overcome this problem? I think the AI or use of the AI will be the way to go, because the use of AI can provide you with the some information about polyp characteristics, such as the differentiation between neoplastic and non-neoplastic. And the reliability of this diagnosis was thought to be higher than that of the endoscopists, according to the pilot studies. So I'd like to explain the benefits and the possible limitations of using CAT-X or computer-aided diagnosis for the polyp diagnosis today. Before proceeding to the performance of the AI, we should understand how many items are on the market in terms of availability. And in the field of CDX, we have 5 or 6 items in Europe or the Asian areas. And the number of the item in the field of CAT-E or computer-aided polyp detection is much higher than CAT-X, probably because of the popularity of the items. But still, we are able to utilize the chance of using CAT-X in our clinical practice. So I'm just presenting a video provided by the Canadian team. To the best of my knowledge, this is the first video or the first presentation focused on the deep learning methodology for polyp characterization. As you can see, this polyp was recognized as type 2 polyp, which indicates the presence of neoplastic change within the polyp. But unfortunately, this software is not available in the world because of the lack of the regulatory approval. However, you have a chance to use this kind of technology if you look at the different companies such as Fujifilm. This product called CAT-I, and CAT-I provides 2 different possibilities in terms of AI. One is apparently polyp detection, the other one is a polyp characterization. So you can detect a polyp and you can characterize a polyp all the time with the aid of AI. But unfortunately, there is no supporting data for the use of this device in terms of the prospective studies or randomized controlled trials. So nobody knows how it works, honestly speaking. But in the future, we are having some studies definitely. But if you look back to the previously conducted studies, there are roughly 8 prospective studies in which the use of AI was in a real-time fashion evaluated. So, but unfortunately, there is no randomized controlled trial, and there is only one comparative trial or a study published in the field of CAT-X. Actually, this paper was just published in New England Journal of Medicine Evenings about a month ago. So I'm just presenting the results and overview of this paper to facilitate the understanding of what is the limitation or what is the benefits of using AI or for polyp characterization today. So this was a very simple study, international collaborative study, including Norway, UK, and Japan. And we did a comparison between the performance of endoscopists alone versus endoscopies plus CAT-X. So if we found the polyp during the procedure, we did an optical biopsy or optical diagnosis of the polyp without the aid of AI, firstly. And then subsequently, we did an assessment with the aid of AI. Then we are able to compare the performance of each arm afterwards. Then what happened in the study is illustrated here. Very surprisingly, there was only a marginal benefits of using AI or CAT-X in terms of sensitivity or specificity. However, there was a big benefit of using AI for polyp characterization in terms of level of high confidence diagnosis. The proportion of high confidence diagnosis was roughly 75% before the use of AI, which increased to 92 or 93% with the aid of AI. This is quite a big benefit, because right now we are allowed to do optical diagnosis only when we have a confidence in diagnosis. So this kind of increment can contribute to the reduction of the polypectomy or unnecessary histological assessment in our practice. And this data is closely connected to the cost-saving data, which was just published in GIE in 2020. And according to this analysis, we are able to save a lot of money by reducing the unnecessary polypectomies for the non-neoplastic polyps with the aid of CAT-X. So from the financial perspective, CAT-X should be accepted from the authorities such as the health insurance bodies with some sort of the idea of providing reimbursement, I would say, but nobody knows how it works. But I think this kind of cost issue should be discussed thoroughly. On the other hand, we have lots of challenges in the field of CAT-X or polyp characterization. For example, prediction of T1 cancer. That's a really important topic because the invasion depth of the T1 cancer is less than 1,000 micrometer from the mucosal muscle layer. Then the risk of the lymph node metastasis will be minimalized. However, the level of the invasion is more than 1,000 micrometer. You should take care of the patient very, very carefully or thoroughly because the patient has a high risk of having the lymph node metastasis. So you should refer the patient directly to surgeon or something like that. But anyhow, there are a lot of the software which is able to identify the invasion depth in a real-time fashion. However, there is only the data from the retrospective studies. If you look at these kinds of pilot studies, sensitivity was presented as over 90% and specificity is 90% or more as well. However, whenever we evaluate this kind of stuff in a prospective fashion, usually we would experience a kind of much lower performance, honestly speaking. So in this regard, we should wait for a couple of years or more before we can enjoy benefits of AI for T1 cancer identification. But before that, I guess we are able to enjoy the benefits of AI in identification of serrated polyps. This is a brand new publication in gastroenterology from our research group, and this software is able to identify the SSL or sessile serrated lesion in a real-time fashion, in addition to the binary diagnosis, such as neoplastic versus non-neoplastic. And I guess this is a way to go as a first step. Then we can explore the chance of developing the AI for T1 cancer detection or characterization. So, ladies and gentlemen, there are two take-home messages. The first one is about a prospective study just conducted by our research team. This shows that both the benefits and the limitations of using CAT-X in our clinical practice. I guess from the sensitivity or specificity perspectives, I guess benefits is kind of marginal. However, when it comes to the level of high confidence, I think the use of CADX will increase our confidence and increase the quality of the optical diagnosis, because we can increase the number of the optical diagnosis based on the high confidence level prediction. But when it comes to the more clinically relevant areas, such as the identification of T1 cancers or selected lesions, there are a lot of things to do for now. So in the field of CADX, I would say that we should wait for years before we can enjoy the full benefits of using AI. Thank you very much for your kind attention.
Terrific. So I think hopefully we're going to have Mike Burns' talk as a pre-recorded one.
Hello, my name is Michael Byrne. I'm in Vancouver. Actually, right now I'm on Lake Maggiore. But anyway, thank you to Pradeep and the Endoport committee for asking me to give this talk. It's always difficult to follow people like Cesare and Yuichi, world experts in AI for polyp detection and characterization, but I'll do my best. It might be easier for me to talk on AI for football teams, because certainly as Colin and Cesare know, my football team right now could do with some help. These are my conflicts of interest. So why is this an exciting time? I do think we're at the point here, like on this slide, where the red rectangle is, where we have somewhat narrow task-specific AI tools, polyp detection, polyp characterization. But we need to now start to really move beyond these so-called modular solutions and have them to be much more fulsome and wholesome and really contribute to the workflow. And that's what I hope to show you today as we move towards the future. So what will all of this AI promise truly mean for GI and for us endoscopists? Well, no doubt we have an opportunity using AI to redefine what we mean by quality metrics in endoscopy, and also what we mean by improving the user experience. So we've just seen two very nice talks on what AI can do for polyp detection, for polyp differentiation. There's been quite a lot of work looking at endoscopy quality assessment, such as the bowel prep and the surface area evaluation, how AI can help us with reporting, automatic endoscopy reports, or pulling out analytic information from the various repositories to find our ADR, for example. How AI can help with some of the painful paperwork involved in billing, for example, in jurisdictions where physicians or their office do the billing for endoscopy. AI can play a role here. And hopefully we'll move to a point where there truly is ambient clinical intelligence in our rooms, not just our clinics, but also in our endoscopy suites, where we can envisage during a procedure that we can ask for the CT or the MRI scan on that patient to be on one of the screens. We can ask for pertinent information from their last endoscopy or pathology or other metadata that we want from that patient that helps us during a live procedure. We've all been there where we are really keen to get something. We take a glove off and go back to the computer and search through the hospital system. Much better if we could do that live during a procedure. So again, as you all know, lots of work in the last few years showing how AI can help with timing automatically the withdrawal phase from the cecum to supervise and tell us that we're not being stable enough, pulling the scope too quickly, to evaluate bowel prep, for example. What about surface area? This is an algorithm from Google that shows us in blue and red bits of bowel that we see and that we don't see. And I don't think any of us are truly surprised to be shown here that we miss bits of the colon during our routine inspection. And it's very clear, I'm certain to all of us, that surface area evaluation it very much equates to quality and to picking up more lesions. So if you slow down, if you get better bowel prep and you see more of the surface area, we're going to perform better. That's very clear, and AI can undoubtedly help us here. It can help us, as we know, with a more accurate assessment of the bowel prep. It can help us in some of our documentation. This is an example for upper endoscopy from a couple of years ago now, but whereby AI tools or computer vision can help in one of the quality metrics, which is capturing the right images. So, for example, an AI tool here will automatically capture images of the parts of the stomach that we should be looking at during a procedure, so that we have little or no blind spots. I think we can see in the colon how this can help as well, beyond just photographing the appendix or the cecum or the ileocecal valve or the retroflex view. Hopefully, though, there are other more automated image capturing tools that will help us as we move forward in the colon. What about text and what we can drag out of textual information? That's really quite unstructured data and can be difficult to get useful information from using machines. But the field of natural language processing, or NLP, is undoubtedly moving very quickly to help us to get appropriate information from unstructured data, such as our clinic notes or colonoscopy reports or pathology reports, so that we can use it for analysis and pull out, for example, the adenoma detection rate. So if we use NLP and allied techniques such as optical character recognition, or OCR, we can pull quality metrics out of endoscopy reports, for example, from multiple electronic health records such as EPIC and Provation and others. So here's one group showing you can extract the polyp detection rate, the ADR, the bowel prep information, and also the failure rate for cecal intubation. All of this done with AI, or type of AI, NLP, compares very favorably to the manual review. So hopefully we'll get to a situation where we can pull information from the data in pathology, EndoWriter, and EMR repositories, and that spins out useful metrics that we can actually use and report on. So I think we can envisage, hopefully in the not too distant future, where not only can we ask Alexa or Siri to play the music in our homes that we want to turn the lights up and down, but that we can ask during our practice for us to be informed about our ADR. Maybe you want to know on one particular day, what's your ADR trend for first-time screening colons during the last 12 months? And your AI can pull that up for you. And then you can upload that type of information to the quality registry, for example. Or maybe you're Professor Biliary and you're doing your colonoscopy, and you realize that you want to know how many patients are on the overdue for follow-up colonoscopy list. I'm sure that's quite a long list, but nonetheless, this is where AI can undoubtedly help. What about the thing that I'm sure we all don't particularly enjoy, which is sitting down after a procedure and dictating reports, or using one of the somewhat clunky synoptic reporting systems that are undoubtedly better than they were 20 years ago, but there's clearly still a way to go. Beyond using things like Dragon or similar speech recognition tools for our clinic notes, in the outpatient setting, what can we do for endoscopy and have structured reports that are done automatically or semi-automatically? Well, we're not there, but we're getting closer. This work is from actually Pradeep and some of the Dutch group in Eindhoven and in Amsterdam. I think one of the reasons that we're not there right now is because we're in a position whereby CAD-X, or optical differentiation, optical biopsy, is clearly very good, but it's decision support, and we are not able or allowed to make these tools diagnostic, so we cannot put that kind of diagnostic information into a report. And right now, CAD-E tools or CAD-X tools are very good at visual assistance with medical decisions, but not at putting that into clinically relevant information into a report. So we need to get there. We need to give some degree of explainability in the report. How does an AI tool make a decision that it has? And hopefully we can therefore give the user a lot more confidence in those kind of tools. So this work here, for example, shows us where this might go. This system is a CADX that automatically generates text from the basic classification of a single polyp. This is akin to narrowband imaging of polyps. It's a solution that's modality independent and will get info from white light and different types of chronoendoscopy. It'll provide text-based suggestions to experts and to novice GI physicians, and it will move us towards a more powerful, explainable AI and hopefully automated report generation. So here you can see the human descriptors on the left, which we used here as the ground truth for this model. The machine is able to synthesize some sentences, some key sentences from those human inputs. And then when a polyp is seen, give suggestions as to the image captions that come with the polyps that are evaluated. So here is a polyp on the left, and you can see caption generation here, whereby the machine comes up with this suggestion of the types of information that we want to see, and then put it in a readable form into a report, hopefully. So these tools need to work with our daily workflow. We need to know how to incorporate various types of data, not just endoscopy. So we've got pathology, radiology, many omics, proteomics, metabolomics, microbiomics, genomics, and on and on and on. And all of the aspects that encompass what we now call personalized or precision medicine, and know how to link those together and harness the power of all of that kind of data that is both accurate right now in diagnosis and predictive going forward. We need to know how to use these different sources of data together. Of course, it's not just about polyps. There are groups such as Takanaka here and his colleagues publishing a couple of years ago in Gastro, looking at how you can use AI to look at UC activity in the colon, linking it to histology remission. My own group looking at using a tool for central reading of colitis and how it can help the reader to abbreviate the process of central reading. So what's ahead? How can we learn from unlabeled data? How can we improve collaboration between AI and the endoscopist? We've seen how we can use AI for quality control, and we've certainly got a ways to go. But we really need to know that AI can and does and will see what we cannot see or what we cannot even conceptualize. So we need to get past that. So AI can help us with CAD-E, CAD-X, will help us with endoscopy report generation, quality metric assessment, pulling data from EMRs, for example, looking at our ADR, helping with task automation, like the reports, or with billing, and helping us hopefully to harness the power of true big data. So in the future, I'm sure AI will help us to standardize quality metrics. It'll help us improve outcomes by removing the subjectivity in measuring those quality metrics. And it will undoubtedly help to augment the intelligence of the clinician and remove a lot of the non-value added work that we don't like doing or are not very good at doing. With that, I thank you for your attention, and I'll pass you back to the panel.
Terrific. So 3 great talks there for something that I think is going to really be a big part of our practice coming up. As people start to think of questions, I wanted maybe to start with Yuichi and CAD-X. I remember a time in about 2005 when I was sat with Brian Saunders, and he told me about this great new technology that was coming from Japan that was called narrowband imaging. And I spent 3 years of my life doing my MD with Brian and demonstrating that narrowband imaging could improve detection. And it was actually really, really good for polyp characterization. And we assumed that it would just take over clinical practice in GI. And in fact, I even went and sat on a nice diagnostic advisory panel who agreed that we could do resect and discard an optical diagnosis. But that was about 5 years ago, and we're still not doing it. Why do you think that AI as a technology it is going to completely sweep the board, when previous technologies that seem to have offered the same thing didn't quite seem to go anywhere?
Yeah, thanks, James. It's quite a critical question. But if we look back the clinical practice right now, or the on the market status, I'd say the implementation of AI still is ongoing. It's not fully implemented because of some barriers which we might find in the situation related to NBI implementation. So I guess the strength of the AI or CDX is apparently the reduction of the inter-observer or inter-operator variability. So it can reduce the learning curve apparently. However, we should also take care of the implementation phase, which usually requires the financial support or reimbursement from the public entities such as the payers or the health insurance bodies. This is going to be the biggest hurdle before the full implementation of this kind of new technology. I think if you look at the Japanese situation, NBI diagnosis has been widely adopted, probably because of the payback from the financial body. We can get roughly 20 euro for the use of NBI for polyp assessment in Japan, but this cannot be applied to the rest of the world because of the lack of this kind of system. So I think we have to take care of two things. One is the quality of endoscopy or improvement of the quality. The other one is the financial payback from the public entities.
Mike, did you want to make a brief comment on that? I think Pradeep's bringing us gently into hand.
Yeah, I think I agree with everything Yuichi said. In addition, I would say that the comfort zone that we've been in for the last 15 years or 10 years, James, since MBI, for example, showed that you could do optical characterization, is exactly the problem. Most endoscopists just want a scope, get in, get out, and move on to the next one. I know it's a slightly bold statement to make, but it's the truth, in my opinion. And taking extra time to learn to do accurate characterization and nice or whatever it may be, basic, most people won't do. We live in these academic cloisters, corridors here, and we all think we can do it, but most people don't and won't do it. So if it means that we need to use technology to drive that, and then ultimately technology will show that if you don't meet a certain performance standard, either with your own eyes or with tools, techniques, cuffs on your scope or AI, you're not getting reimbursed or you're not getting your license for next year. That's how it needs to be driven. It's kind of horse and cart, and which is the horse and which is the cart. And unfortunately, with human nature, I think we may have to use more of a Trojan horse approach here to get some of these technologies in.
Okay, thanks, Yuki. Thanks, Mike. I guess that AI evolution is very fast. We should not under-evaluate the importance of CAD-E. The fact that it's already incorporated in several centers does not mean that it must be underrated. I guess that CAD-E is a big revolution in endoscopy. Of course, for CAD-X, we need much more time. Maybe we will end up as with NBI, but anyway, we need to strive for it. Okay, Pradeep.
Thank you very much. I think this has been a brilliant session, guys. It's good that you guys can join us. I know how busy you guys are. We got a very good insight into it. So we now know how to diagnose, how to characterize. Mike, we are going to move to something more important now, which is about how to do ESD. So AI is not going to help us for the time being, but as you are an entrepreneur, I'm giving you an idea, Mike, that we can design something where AI can help in ESD, and we share something. Yeah. So I think thanks a lot to our chairs. Thank you guys very much. We have, as you know, that the evolution of ESD started in Japan. So we have three great Japanese godfathers of ESD who's going to join us now. But before that, we have a queen of ESD who happens to live in UK. Can we invite Dr. Noriko Suzuki to take the chair? Noriko, thank you very much for joining us. Please take the seat. We have Yutaka Saito joining us from Japan. I think Yutaka was on his way. Oh, you're already home. I was told, Yutaka, you were on your way home. Looks like you've taken a flight home. NCCH to home already. Good. Thank you. We have your colleague Sachiro Abe, who's been with us since yesterday. Thank you, Sachiro, for joining us again.
Thank you so much.
And we have Professor Yamamoto. Can we bring Professor Yamamoto on the screen, please? Hiron.
Hello.
Nice to see you.
Yes, thank you for the invitation. Nice to see you.
Thank you very much. So we're going to have a fantastic session on ESD, and we're really eager to get on with this, starting with, I think, the classical technique, the old-fashioned technique. So we're going to, I don't think you're so old, Yutaka. I don't mean it like that. But the classical technique is the old technique. You are one of the innovators of the old technique. Doesn't mean that you don't do the new way, but please give us your insight into the classical ESD technique. Do we have Yutaka's video? Okay. We're going to play that now.
Yeah, please.
Right, TXI1 mode, the NBI revealed that this tumor clearly. Magnified NBI revealed the genotype 2B in this location, and the pit pattern with injury display and crystal bite staining show type 5I low irregular pit in this slightly depressed component, and the cytoscopic imaging was also done. We are using dry cut 4.7 for marginal resection and spray coag 4.5 for submucosal dissection. Now we are using retroflex position and injecting glycerol first, and then injecting mucoap, the sandwich technique.
Yutaka, looks like we started your video after you played. Can we start the video again? Because it just started like as if, is this the right talk, Yutaka?
Yep.
It is. Okay, sorry. I misunderstood it. Okay, it's not my team's fault. I thought they made a mistake again. No, so carry on. Sorry.
Rectal sigmoid column, white light, TXI1 mode, the NBI revealed that this tumor clearly. Magnified NBI revealed the genotype 2B in this location, and the pit pattern with injury display and crystal bite staining show type 5I low irregular pit in this slightly depressed component, and the cytoscopic imaging was also done. We are using dry cut 4.7 for marginal resection and spray coag 4.5 for submucosal dissection. Now we are using retroflex position and injecting glycerol first, and then injecting mucoap, the sandwich technique. And we are using Boston Ori's Pro knife for marginal incision. And after partial marginal incision, we immediately start submucosal dissection using the same Pro knife. And we use the short type ST food for every colorectal ESD. And we could inject glycerol through this Pro knife. The power of injection is really nice. And we are coagulating the small vessel. Now the short type ST food is really nice for visualizing the cutting line directly. And additional injection is really effective. And we are dissecting lower third SM layer using Pro knife. additional injection. And some causal dissection. Now it's really important to visualize the cutting line directly using a short type ST food effectively. And for thick vessel, we precoagulate the vessel using a very low setting of the first coag mode. Now additional submucosal dissection. Now this is so-called expanded pocket creation method using a retroflexion. Now the benefit of this pro knife is the power of some causal injection through the knife. It's really effective. And when the bleeding occurs, we change the mode to RDI, and we could visualize the bleeding point clearly. Now you could understand the clinical usefulness of RDI mode when the bleeding occurs. And now at this moment, we change the scope position to a straightforward view and change the patient position considering the gravity. Now the lesion, the half of the lesion is under the water, so we change the patient position to the prone position. And then we could get a really nice position of the lesion. We are continuing some causal dissection using pro knife. Now this is outside in cut using the pro knife. But this is a needle knife, so both directions are possible. That's some causal dissection. Dissect the lower third SM layer. So we always think about the direction of the muscle layer. Now the injection through the knife to the normal mucosa. So it's amazing. We could inject the glycerol through the normal mucosa. So at this moment, it is not necessary to use the injection needle. And at this moment, we are starting the marginal incision of the anal side. This is a straightforward view of the scope. And we are making the marking around the tumor in this straightforward view and starting the marginal incision of the anal side using pro knife. And it is important to start the submucosal dissection, deeper cut of SM dissection immediately after partial marginal incision. This is one of the tips of colorectal ESD. And now additional injection. And at this moment, the marginal incision of oral side and the anal side are completely done. So we are starting the lateral side cut using IT knife nano. IT Knife Nano is also designed for colorectal ESD with smaller insulated tip. Now, as you know, at this moment, the most of the submucosal dissection are completed. So after marginal incision of the lateral side, the most of the dissection already completed. And still using the short type ST fluid effectively, we could visualize the cutting line like this. And the marginal incision of the anal side using IT Knife Nano. Now, and additional marginal incision using IT Nano like this. The IT Nano is very safe due to the insulated tip, so the risk of perforation is really reduced. This is the anal side. So marginal incision is very easy. And then we are going to start the final marginal incision of right side using IT Knife Nano. Again, this is retroflex position. And this is a IT Knife Nano dissection. Like this. We are using short type ST fluid effectively and making the gentle pressure for the resective specimen, and we could visualize the cutting line directly. And using IT Knife Nano, so it is not necessary to change for the coagrasper, even for this kind of, there are lots of thick vessels in the SM layer. Now this is the final endpoint. That we could effectively dissect without bleeding using IT Knife Nano. Now, the basic technique of IT Nano is to find the edge of the dissection plane and set the knife and move the scope along the muscle layer. Now, this is almost the final part of the dissection. Now, to find the edge of the dissection plane and set the knife, IT knife, and using the long blade effectively for faster dissection. Yes, using the long blade of IT Knife Nano effectively. The gentle cut. The en bloc resection completed without complications. Histology was well to moderately differentiated adenocarcinoma, intramucosal cancer, budding grade 1, lymphatic invasion negative, and horizontal and vertical margin are negative for tumor. And curative resection was achieved. Histology was like this.
Thank you very much, Dr. Saito. That was a very good demonstration of a very complex ESD, and you made it look very simple. What we'll do is we'll move on to the next talk, and then we'll have discussion together. So I think our next speaker is Dr. Sachiro Abe, who's going to tell us about the conventional technique for upper GI ESD, if that is different in any way. So Sachiro, can we play Dr. Abe's talk, please?
And I'd like to talk about the conventional ESD technique for upper GI tract. No COI. First, I'd like to show you the anatomy of the esophagus. Esophagus is a thin, narrow, and straight tube. Thanks to the anatomy of the esophagus, near from the mouth and straight tube, scope access is very easy and anatomical variation is small. However, the scope manipulation is limited and the gravity-assisted traction is less effective. Also, the risk of perforation is higher than stomach. One of the technical tips and tricks of esophageal ESD is optimal insufflation. I would say that optimal insufflation level of the esophageal ESD is much lower than screening and diagnostic EZD. A less air condition will make a submucosal space thicker and softer, which allows us to facilitate esophageal ESD. Let me show you the video. In the standard air condition, it is very challenging to enter the submucosal space because of thin and extended submucosal space. When we suction air, our minimum air infiltration allows us for entering the submucosa like this. This low air condition greatly contributes to efficient submucosal dissection while preventing perforation like this. When it comes to the mucosal incision using IT-NAC nano, it is very important not to press the mucosa too much. If you press too much, you may experience an injury or perforation. And as you can see, so we can safely and efficiently perform the longitudinal mucosal incision by just pulling back the device or scope. For the mucosal incision using the dual knife, you need to hook and lift up the edge of the mucosa, then advance endoscope. This scope operation is in the opposite direction of the IT-NAC. And next tips and tricks, during esophageal ESD, we need to consider the gravity direction. When we perform esophageal ESD, the left side is a gravity-dependent side. As we continue the submucosal dissection, a lesion gradually shifts distally and towards the left side due to gravity. Thus, the distal left side here is the most challenging part during esophageal ESD. If you leave the area, the following procedure, and particularly the end of ESD, will be very much challenging to obtain sufficient traction and identify the edge of submucosa. In order to overcome the limitation, we normally perform the C-shaped mucosal incision to maintain the tissue traction towards the anti-gravity dependent sides. I can show you the video. Because the submucosa of the esophagus is soft and loose, we apply the ceramic tip backside electrode of IT-NAC nano to the submucosa and dissect the tissue from inside to outside. This allows us to identify the submucosa and muscle direction. We can also dissect the submucosa distally. I would recommend to complete the submucosal dissection of the left distal side until the distal end, like this. The most challenging part of esophageal ESD In contrast, the right side is an easier path because the right side is naturally open and exposed due to gravity. As the gravity traction is less effective during esophageal ESD, a traction-assisted ESD has been developed. A clip line traction is the most popular technique. A line, typically dental floss, is tied to the endoclip, and a clip line is deployed to the backside of the specimen. When the line is pulled through the mouth, a submucosal layer was well exposed and lifted up with good traction. We hook the IT knife nano to the edge of the submucosa, and submucosal dissection was nicely performed parallel to a muscle layer. A randomized control trial demonstrated the superiority of the traction-assisted ESD compared with conventional ESD. As the current Japanese guideline weekly recommend using the traction-assisted ESD in the esophagus. And stomach is something like a thick and wide balloon rich in vessel. Owing to wide operation field and thick muscle layer, the scope of operability is good, and the risk of perforation is low. However, the intraoperative bleeding is one of the major concerns in some locations. Scope access is challenging. I mean that it is difficult to obtain close and tangential scope approach for the target lesion in the stomach in some area. So, the gastric ESD is a battle against the bleeding. One of the key points of successful gastric ESD is to control bleeding. It is more commonly occurred in gastric polyps, particularly the anterior and posterior side, because of these areas are rich in vessels. As shown in the image and published by Professor Toyonaga, the vessel-penetrated muscle layer branch in the middle of the submucosa making a vascular network here. Now, therefore, if we dissect the submucosa superficially the concerning perforation, you will encounter the many branched vessel and frequent hemostasis is required. Moreover, the superficial dissection will leave the deep submucosa, which makes the following histological assessment insufficient. I don't recommend doing it. And if we look at the bottom of the submucosa, we can appreciate the space with low vascularity. Here is the optimal dissection level during gastric ESD. There are less vessel, which makes the bleeding less frequent. Here it's the optimal dissection level during gastric ESD. Say here, I would recommend you to dissect just above muscle layer. As you can see, the IT knife is applied to the bottom of the submucosa, and we can manipulate the endoscope parallel to a muscle layer to dissect the submucosa just above MP layer. And when we perform gastric ESD, and sometimes we see the very thick vessel, as you can see. In that case, prophylactic coagulation is helpful to avoid massive bleeding. And if we encounter the large vessel larger than the hemostatic forceps, I would recommend prophylactic hemostasis using hemostatic forceps. And then following submucosal dissection can be safely performed like this. Finally, not just least, I'd like to show you a challenging case, gastric ESD with clip-line traction. Here you can see that the early gastric cancer are located in the greater curvature of the upper gastric body. It is very hard to obtain the good traction during ESD because of the gravity. A puddle makes it more difficult to visualize the submucosal plane. I can show you the video on how I overcome the limitation. In retrofraction, the left side is now retracting due to gravity, and however, a submucosal plane of the right side is not yet exposed. And after a clip-this line is applied to the right side of the specimen, by pulling the line through the mouth, our submucosal space is well exposed and lifted up with good traction. Now we are able to obtain the excellent traction of the right side. And we are able to maintain the sufficient traction and until the end of the procedure. And finally, the umbilical section was nicely done without any muscle injury. Also, resected specimen revealed a well-differentiated tubular adenocarcinoma 35 by 30 millimeter in size. The procedure time was less than 1 hour. In conclusion, ESD is different among esophagus, stomach, and colon. In order to learn and perform successful ESD, it is essential to obtain the optimal scope position and approach in appropriate strategies, considering the anatomical difference. And thank you so much for your kind attention.
Thank you, Sachiro. That was very, very beautiful and elegant demonstration. So please stay with us. We have Zach has been resecting a very complex polyp in the rectum since morning. So we would go there very quickly to see if Zach has achieved his aim and see what it looks like very briefly. And then Professor Yamamoto, we will be with you. So Zach, we are live with you.
Hi, everybody. Sorry, this is a finally exactly 3 hours and 45 minutes procedure. And this is the polyp, as you can see, in the rectum, which actually starts from here. We can show you the specimen. Charlie, can you show the specimen, please? Give me a second.
Zach, are you showing us the endoscopic? Well, we got the room view now, so we can see the specimen.
Can you see the room view?
Yes, very nice. We can see end block excision with your ruler next to it.
I just want to point.
Very nice. Thank you very much. Can we see the endoscopic
Thank you for your patience.
Endoscopic view quickly?
Endoscopic view,
Yes.
please.
Endoscopic view.
John?
Endoscopic view. Endoscopic view.
Excellent.
I don't see those mass layer.
Yeah.
But,
Very nice.
Mass, please.
Looks like there were a lot of blood vessels there, Zach. You must
Yes,
have been
it was
microwaving those vessels.
Yes, we did use all microwave all the way through. We didn't use any car grasper. The last 2 bits was really vascular.
Yeah.
But it was actually on a normal side. So thank you very much for your patience.
Thanks a lot. Yeah.
Thank you very much.
Yes. Take some rest, Zach. Catch up later.
Thank you. Thank you.
Bye,
Thank you.
bye.
Thank you. Thank you. Thank you. Bye bye.
Yeah. So can we play Professor Yamamoto's talk now, please? So Professor Yamamoto is another pioneer in the world of ESD. I remember very well in 2004. I was just going to say how I remember Professor Yamamoto in 2004-05 when I went there. He was the only man doing ESD with needle knife, and that too in duodenum with a 6 millimeter needle knife. So if Professor Yamamoto could do with needle knife, I thought, gosh, this is everything is achievable. But I think you moved on now, and you're going to tell us about pocket creation and tunneling. So can you please play his talk?
Thank you for inviting me to Endoport. I am Hironori Yamamoto from Jichi Medical University in Japan. Today, I will talk about evolution in ESD techniques, pocket creation, tunneling, and traction, mainly focusing on pocket creation method of ESD. Pocket creation method stabilizes procedures of ESD. Therefore, It is useful for standard cases because it provides good learning curve and high quality specimen for pathological examination. Pocket creation method is also useful for overcoming difficulties such as fibrosis, easy bleeding, and lesions on a prominent fold. The key feature of the PCM is creation of a large submucosal pocket using a small caliber tip transparent fluid with minimum mucosal incision for the entrance of the pocket. This is the illustration of the pocket creation method. The tip of the endoscope is inserted into the submucosal pocket. Then we can obtain a stable control of the endoscope tip. And the recognition of the blood vessels is easy, and the dissection plane can be selected at right above the muscle layer. At that level, blood vessels are sparse, just trunks of the vessels. Because we can recognize the blood vessels easily, we can coagulate them before cutting. In this way, prevention of bleeding is possible, so we can maintain good endoscopic view throughout the procedure. And these are 4 advantages of pocket creation method. One is prevention of leakage of injected solution. So we can maintain a good mucosal elevation throughout the procedure, and good traction by stretching the submucosal tissue by the ST hood, both to the muscle side and the specimen side. That means we can open the wound and we can get a good view. And adjustment of approaching angle to the muscle layer is possible. And the respiratory movement is lessened by synchronization between endoscope and the pocket. Endoscopic resection for early GI cancer is for the curative treatment of the cancer. So in order to achieve curative resection, you have to resect the entire lesion en bloc without leaving the tumor tissue. R0 resection is very important, but it's not good enough. The risk of lymph node metastasis should be negligible to tell that resection is curative. So the risk of lymph node metastasis correlates to the depth of invasion and lymphatic involvement. These information to determine the risk of lymph node metastasis can be obtained from the findings in the submucosal layer. Therefore, the dissection of the submucosal layer should be deep enough. So the dissection plane should be close to the muscle layer. Now I'd like to show you some difficult cases and explain how to overcome in those difficulties. This is a lesion at the gastric angle. With gas insufflation, approaching angle becomes vertical, but without insufflation, we can approach to the lesion tangentially. And after making a mucosal incision for the entrance of the submucosal pocket, then we immediately start dissection, submucosal dissection, right above the muscle layer. In this view, muscle layer is at the 12 o'clock position, and even the lesion is located at the gastric angle without gas insufflation and in the submucosal pocket. Endoscopic approach is possible, and submucosal dissection can be continued to pass the gastric angle. This is outside of the pocket. Without gas insufflation, you can follow the marking like this. But if you insufflate the gas, then approaching becomes difficult. So suck the air and collapse the stomach lumen. That is important for the successful pocket creation method. So after the submucosal dissection under the lesion is completed, then we start opening the pocket. By opening the pocket, then, but in this stage, endoscopic approach becomes a little bit tricky because the insufflation is necessary outside of the pocket, submucosal pocket. So a little bit distant view, like this, with insufflation, the approach becomes vertical. But anyway, envelope section is completed. Next case is a lesion beyond the pyloric ring. The gastric cancer extends beyond the pyloric ring, and the right endoscopic picture shows the retroflex view from the duodenal side. Using the pocket creation method, the pyloric ring can be visualized, and dissecting the submucosal tissue above the pyloric ring and press down the muscle of the pyloric ring and complete the dissection in the duodenal side. I will show you that in the video. This is the gastric cancer, and past the pyloric ring and change to the ST hood, and marking of the distal side of the lesion is placed. This is the duodenal side. And after elevation using the sodium hyaluronate solution, the mucosal incision and width of dissection is performed. And now this is from the gastric side and creating the pocket. And you can see through the pyloric ring upper side. Right above the pyloric ring, the dissection plane is made, and now with the tip of the ST hood, the muscle of the pyloric ring is pressed. And now I used clip and line technique and assisted the opening of the dissection plane. And with the combination of the pocket creation method and traction method, ESD with envelope resection can be completed. How about lesions with fibrosis? This is an illustration of cancer with fibrosis. Usually fibrosis is in the upper part of the submucosa, so the dissection below the fibrosis is often possible. I will explain with the real case. This is another example of a lesion with fibrosis. This is a dysplastic lesion arised in the rectum of a patient with long-standing ulcerative colitis. Even with indiocarmine spray, the extent of the lesion is not very clear. By the way, this is a recurrent lesion after piecemeal EMR. This patient was referred from another hospital for ESD. And because of the unclear extent of the lesion, I performed multiple biopsies to determine the extent of the lesion. Of course, the long-standing inflammation by UC and multiple biopsies can cause severe fibrosis. Multiple biopsies are performed and the extent of the lesion was determined. Using the pocket creation method, submucosal dissection can be performed under the lesion successfully. Then ESD was completed like this, and fortunately the lesion was limited in the mucosal layer and complete resection was confirmed by pathological examination. This is the again the pocket creation method. After creation of the submucosal pocket, I used reopenable clip. In this case, I used a sure clip, grasped the specimen, and then open again and hooked it to the wall on the other side. And just by using this single clip, the traction can be applied effectively. So the amount of traction can be adjusted by the amount of the insufflation. With the good traction, the opening of the pocket is easy, as you can see in this video. Then stable control can be maintained throughout the procedure, and you can finish the ESD like this. Conclusions. The pocket creation method, tunneling method, and the proper use of traction make the procedures of ESD stable and are useful for overcoming difficulties in ESD.
Thank you very much. That was amazing. I think our whole audience is completely mesmerized. We thought we were in a cinema theater watching some art movie. Very, very beautiful techniques. We'll take some questions now. So the audience be ready to ask, but Noriko has made a lot of points. So we'll start with you, Noriko.
先生方ありがとうございました。Firstly, Professor Saito, Professor Bandari was very disappointed. You showed very structured, very nice ESD. The title was conventional ESD, so he was expecting to see some mucosal flap making ESD. At the moment, is it still exist in Japan? Mucosal flap, very old type, conventional ESD.
Mucosal flap.
Yeah, making a mucosal flap and opening up, and then like enlarge mucosal flap bit by bit.
Yeah.
At very early stage, I think that is a kind of mainstream initially. Does it still exist?
Yeah, still exists, I think. And the case I showed you today, also the first step is like a mucosal flap. But I'm using the short type ST food for every colorectal ESD. So the entering to the submucosal layer is relatively easy compared to the conventional stretch type food. And the mucosal flap method is also, maybe if we start from mucosal flap, and then we are making some pockets first. And then for us, I prefer to use the retroflex position if possible. That's why I'm making the relatively large pocket.
Yeah. So what we noticed is, although we have different terminologies for different types of techniques, but when it comes to treating the lesion, looks like we're using a combination of techniques, whether it's creating a pocket, then using a traction, going back to conventional method. I don't think it's a pure single way of doing ESD, because even Professor Yamamoto showed in his final video how he created a pocket, then used the traction to finish it off. So I don't think we need to stick to just one way of doing ESD, just using different ways, whatever is the best way for that lesion, I guess.
Yeah. So as Dr. Abe also, he was trained at the National Cancer Center, and Dr. Gotoda and Dr. Oda. And also, but still, he also developing his original IT knife technique. Its technique is now the little bit or completely different from Dr. Ono's conventional ESD using IT knife.
Any questions from the audience? Can I ask Dr. Abe, what is the basic difference in ESD between, maybe it's a wrong question to ask you, maybe Professor Yamamoto can chip in as well. What is the main difference between performing ESD in the stomach and performing ESD in the colon? Apart from the vascularity of the lesions, in stomach, like we know, cardiac, greater curvature is a bit vascular. What is the main difference? Sachiro, if you go first, and then Professor Yamamoto can comment.
Thank you so much. One of the differences is, of course, anatomy. So gastric ESD is likely against bleeding, and colorectal ESD is likely against perforation. That's the difference. So in order to do safe ESD, we are really pay attention to the bleeding for gastric ESD and take care of the perforation for colorectal ESD. That's the point.
Yes, I agree with Dr. Abe. And the biggest difference is the thickness of the muscle layer. In the stomach, the muscle layer is thick, so you can use IT knife from the lateral side safely. But if you do the same in the colon, that is risky, because you make a wrinkle in a colonic wall, so you can make perforation easily. So in the colon, it's better to use a tip type knife and directly visualize the submucosal layer and maintain the thickness of the submucosa and dissect. So for such technique, for such purpose, flap making or pocket creation, that kind of technique is better in the colon.
So one of the other things I noticed is that when we start doing ESD, because we don't see the planes properly, or when we, as an endoscopist, is struggling, they tend to overinflate. We put more gas. That makes ESD even more difficult. So when you become more experienced, when you are very when you are very good with your technique, you also understand this concept and you put very little gas, which makes ESD even easier. So it's a very paradoxical phenomenon when you observe different people doing ESD. So for our audience, it's very important to know that less gas it makes ESD easier, although the views do get compromised. So it's very important in the last video, how you showed in that gastric ESD is such a complex lesion. You made it look so easy by deflating it. Most of us will inflate, try to see where the margins are, and then we'll struggle a lot. So very beautiful illustration of how to use the gas in favor or against us.
Yeah, thank you. Thank you. Thank you very much. Exactly. You are right. Today I performed duodenal ESD, and duodenal ESD is the most difficult, but the combination of different techniques, then we can overcome the difficulties. One is the no gas and underwater technique, and the pocket creation and traction and the injectable needle. I used such combination, and then the procedure was successful. So the not sticking to the only one method, you can use any technique which is suitable for the difficult situation.
I think Professor Yamamoto, you made a very, very good point there. I think which is moving away from the conventional way I was thinking Japan used to work, where everybody had their own knife, everybody stuck to that. There was no role of combination. When I suggested that when I was in National Cancer Center, can we use a combination of hook knife and this? I said, no, this is a no-go area. Today we saw how you combining various knives, how you combining various techniques and various different kinds of injecting solution. So I think combination is the way forward. That is the message here. Traction, injecting solution, different knives, whatever makes it safer and time efficient. For Western endoscopists, time is a big concern. So that combination will reduce the time as well. I think we had a great session. We're running a little bit late. So I think we would like to close this session. So thank you very much, guys.
Thank you.
Thank you so much. Thank you so much.
So we could have a 5 to 10 minute coffee break. The tea is being served. So please grab your tea and we move to the final session of complications. Hopefully we never have complication, but this session will prepare you for that. Thank you.
So have a good night, and please join Endo 2022 this weekend.
We will. Thank you very much.
Okay, see you.
Arigato
Thank you so much. Have a good night.
おやすみなさい。
おやすみ。
ありがとうございました。
So that's how we begin. That's how we begin. That's how it's kind of. There you go. What are you going to say?
I'll get everybody to sit down. Yeah, you can hear. So welcome back, guys. We're going to get going with one of the most important sessions of endoscopy, which is about complications. Can we settle down, please? Thank you very much. Have a seat. We're going to get going with the complications. We are towards the final end, but this is the most important talk. You need to pay attention to this. So can we get our chairs? Who's chairing the complication session? Complications, Eduardo, maybe you can take a seat there rather than here. Helmut is not joining, afraid. As Dr. Bape joined in from India, can you check Amol Bape?
Hi, Pradeep. I'm here.
Yeah, can we? Amol, hi.
Hi.
Nice to see you.
Nice to see you too. And congratulations on a wonderful course.
Thank you.
I did manage to attend whatever I could between my busy schedule, but nice.
Yeah. Thank you.
Very nice.
Well done.
Great.
So Amol joined us. Has Rehan joined? Yeah, I can see Rehan is in as well. Thanks, Rehan, for joining us virtually. Although you were in person, I don't know how you disappeared, but thanks for joining.
No, I apologize, Pradeep. I had to get back for a meeting.
Sure. And we got Dr. Eduardo Albanese from Spain, who's been patiently waiting. Thank you, Eduardo. We're making you work hard. Thanks. And Noriko is going to get a cup of coffee and join us again. Noriko, thank you. See that. Good. So shall we start with Dr. Hadri's talk on strictures, please? Yeah. Can we play? Oh, Rehan, you sharing the screen with us and you're going to talk, not the video. Okay.
Yes. Okay. Just give me a few moments to, can you give me the, just let me know, Pradeep, if you can see my screen in just a couple of moments. So Pradeep, can you see the slide deck?
Yeah.
We're getting a screen.
Okay.
All right. So Pradeep, thanks for including this session. I think it's a really, really important session, and it's one that's underplayed in a lot of these congresses. And so I think there's a lot of learning here, not just for the delegates, but also for people like us, from looking at each other's cases of where things have perhaps gone less well, because this is not an algorithmic approach to treating these things like perforations, fistulas, strictures. So I'm going to just start with a very short talk on the management. I'm going to focus really on non-malignant esophageal strictures. We all see these. There's plenty of them out there. Common causes: acid reflux, post-radiotherapy, caustic ingestion, EOE, and then things like bowel reflux. You also see this now a lot more as a byproduct of esophageal resection, not just in the esophageal, but also sometimes in the colorectum. And most of these are often very straightforward. They can be treated in community centers with a single balloon dilatation to make patients asymptomatic. And normally just a single session will suffice. Now, before we start to talk about the management of any stricture, it's really important to classify your stricture. And this is a really important consideration when deciding on which therapy you're going to use. So there are two types of strictures. There is a simple stricture, and these are the strictures that we will see most commonly: peptic strictures, short strictures that are less than 2 centimeters. These will be symmetrical strictures, very easy to treat. It's the complex strictures that we need to define early on, because this will help to prognosticate and inform your decision-making in terms of what therapy they will need. So these are your longer strictures, your asymmetrical strictures, your anastomotic, post-endoscopic therapy, post-radiotherapy, post-caustic injection strictures. These are very, very difficult. Now, I get sent a lot of patients who get sent to me as a refractory stricture. Now, actually, you have to be really careful before you define a patient as having a refractory stricture, because these are rare And unless you've exhibited a lot of energy in trying to overcome this stricture with sequential dilatations to a minimum of 14 or 15 millimeters with a Bougie balloon, then do not classify this as a refractory stricture. It's only once you've done this and the patient remains symptomatic and you have endoluminal narrowing, that's when you can define this as a refractory stricture. Now, before you start talking about the endoscopic management, it's really important, treat the cause. And that will be simple things like acid suppression, bile suppression, looking at simple causes, delayed gastric emptying. Now, do not be caught out by a stricture being sent to you as a benign stricture. Biopsy, biopsy, and biopsy again. I have been caught out with patients who have been sent to me as a quote unquote benign stricture when actually they've had cancer or indeed pseudoachalasia. So please look out for this. Now, there are many guidelines, and I'm just going to go through a sort of 6 steps of management of esophageal strictures. This is how I do it, and this is what I advocate in our unit. The first one is endoscopic dilatation. There are really 2 modalities, ladies and gentlemen. One is the Bougie, and one is the through the scope endoscopic balloon. Now, it's really important that you treat the stricture, treat the patient, not the stricture. You will have patients with quite narrow lumens who will be asymptomatic, and leave them alone. Inform your patient that this is not a one and done. They're going to need to come back for sequential dilatations. Now, the difference between the balloons and the Bougies, the balloons are, everyone has used them. You get this rapid insufflation and you get a good radial force. The benefit of a Bougie is that you get not just the radial force that you exhibit with the balloon, but you get this sort of longitudinal shearing force, which is extremely attractive when you are treating patients with asymmetrical complex strictures. Make sure your environment is optimized. Make sure you have access to a slimline transnasal scope. Use carbon dioxide insufflation and sedate these patients. There is no difference in the data between balloon and Bougies. There are a few randomized controlled trials. Bouginage is best done with fluoroscopy. So again, choose your weapon and stay consistent. So balloon dilatation, this is really very, very straightforward. You do not need fluoroscopic guidance if you know what is on the anal end of the stricture. So in these patients, if you can't pass the scope, then as long as you know what's going on the anal side, then you can pass the balloon and inflate this very easily. Now, fluoroscopic guidance with balloon and contrast are asymmetrical strictures in patients who have previous perforations. You can see the waist of the balloon, and also in patients with long strictures. There is this anecdotal sort of rule of 3s for Bougies, that you don't go for 3 consecutive dilators in increments of 1 millimeter. This is not gospel, but just be careful that as soon as you start to feel resistance, that you pull back and you bring the patient back for another session. There is data, this is historic, to show that actually the rule of 3 doesn't really increase the risk of perforation and poor outcomes. So what we do know, however, is that the minimum dilatation diameter should be in the region of about 16 millimeters before you get symptomatic relief. So that's what you should be aiming for. And this was published by Janine Van Hoof's group very nicely in Surgical Endoscopy some years ago. Now, intralesional steroid injection, we talked about this yesterday in the context of endoluminal therapy and iatrogenic strictures. The data on this is really from anastomotic strictures. And the hypothesis here is that after balloon dilatation, you create these tears and then you inject triamcinolone into the tears. So you're actually putting that into the muscle layer so that you're reducing fibrosis. Now the data on this again is sparse and is confined mostly to anastomotic strictures. So what you want to do here is you really want to inject the triamcinolone into the tears that you have created to reduce fibrosis and reduce the number of dilatations. And that is shown here in this study, which showed that dilatation versus dilatation in steroids just increase the dysphagia-free period in these patients. Incisional therapy. This is extremely attractive for refractory strictures where they are simple strictures. So this is an example here of a peptic stricture. The knife of choice really here is your insulated tip knife, like the IT Nano. This is in the esophagus is extremely effective because you have an insulated tip, so it reduces the risk of deep muscular injury or transmural perforation. And what you're doing here really is trying to just lift the knife over the edge of the stricture and incise down to the muscle layer so that you are basically opening it up as you would. And it's important not to overdo this because the more fibrosis and tissue destruction that you create, you may actually make things worse. So this is a neat little trick for simple strictures and very good also for anastomotic strictures. Again, the data on this, there's one randomized prospective study that suggested that incisional therapy was slightly better in terms of reducing the mean number of dilatations in patients. Stent placement, this is something that there is guidance on from the ESGE, and one has to consider what stent you use. You want to avoid putting in a partially covered or uncovered stent, so you want to look at a fully covered metal stent. They come in various shapes and sizes. The long-term outcome was slightly disappointed in this study published by Alessandro Repici's group. Now, one of the issues with this is stent migration. And so the biodegradable stent was used in previous years. This is a woven polydioxanone biodegradable stent, which this was the only randomized control trial that showed that in patients with benign refractory strictures, the insertion of a biodegradable stent improved dysphagia-free days, but also reduction in the time to the next dilatation. This is evidenced here in this graph here. So I'm just going to move on now to self-dilatation. Now, this is a patient here at UCH. This is extremely attractive in patients who are extremely refractory. So you can see here we have probably over 100 patients now on our books. And what they do is they basically self-bouginage at home once to twice a day. This is not for everyone, but this keeps patients out of hospital. It is safe. It is overseen by a member of our clinical nursing staff and is really effective in a lot of patients, but also will transform their quality of life. So please think about this. Again, the data on this is very sparse. We have some data that's just been submitted from our group to DDW, again, showing that the dysphagia scores were improved. Finally, ladies and gentlemen, surgery. Please don't take your patient on a long journey, only then to find that you're not winning. Have a low threshold to send for surgery, especially in recurrent strictures with large hiatal hernias, and especially patients who've had a previous transmural injury. Very briefly, just because we're a bit short on time, the prevention in ESD, really the majority of data here is on not just topical steroid, but ingested steroids. So a randomized controlled trial from the Mayo Clinic, but also from Michael Burke's group, look at budesonide slurry post-endoscopic resection in circumferential ESD in terms of reducing strictures and dysphagia scores. So ladies and gentlemen, in summary, please control the acid, control the bile, heal the insult first, consider anti-reflux surgery, dilate. That's the first thing. But then also consider things like triamcinolone, incisional therapy, avoid stents at any cost due to the risk of migration and granulation tissue, and surgery is very rarely indicated. So thank you very much for your time.
Excellent, Rehan. I think in a short time you really covered the strictures very well. I believe Pradeep also wanted to, highlight some of the issues regarding complications in this session. So, since you've not touched upon that aspect, may I ask you, what is your, what do you do, and when do you feel that things have gone wrong, and what's your, what's your protocol if things go wrong and you have a perforation during.
Yeah, I'll hopefully I'll touch a little bit on that in the next slide, but that's a really important, first of all, is to counsel your patients about the risk. The risk is low, but also anticipate the fact that you will have a perforation if you do enough of these. We quoted a perforation rate of between 1 to 2% in esophageal dilatation. The thing, Amol, is that actually the mediastinum is a very unforgiving place if you have a perforation, as you know. So the priority is to prepare. And if you have to remain calm, to optimize your environment, so use carbon dioxide insufflation, have a low threshold for diagnosing a perforation. So use fluoroscopy, use all means to see if you've got a deep muscle injury. And then, I don't really worry too much now about perforations because we're we're blessed with endoscopic tools to be able to fix them, from simple endoscopic clips to the early placement of temporary self-expanding stents, which you can suture in, but also now with endoscopic suturing. They do happen, and I think the key here is optimize the environment, treat the mediastinitis early, address the nutrition, drop a nasovaginal tube, make sure they have TPN, and also speak to your surgeons very early unless they're aware. And once there is a mediastinal connection, these patients will need intrathoracic drains to ensure that there is drainage of the mediastinal space, because that's where they get sick from, not from the perforation.
Right. Thanks. Regarding the strictures, are there certain strictures that you would prefer a balloon vis-a-vis some strictures where you prefer a bougie? So
yeah, Amol, that's a really good question. I think for the simple symmetrical strictures like your peptic strictures, your post-EMR strictures, your anastomotic strictures, a balloon will suffice because all you want is that rapid radial force. With the more complex strictures like your post-radiotherapy strictures that are longer, more complex, a lot of the caustic strictures, bouginage is better. It gives you a far more controlled longitudinal dilatation as well as a radial dilatation, which is safer and more controlled.
All right. Eduardo, Noriko, you have any questions? Are there any questions from the floor? I can't see this.
From floor? Yes, please. One question from floor.
Okay.
Free air, or they don't get interpreted, as we don't see free air in the chest that often. Do you have a protocol for checking chest X-rays, or do you do a cold water swallow? How do you assess whether the patient's fit enough to be discharged?
So the majority of in fact, almost exclusively all of the stricture work in my unit is done in a room where we have access to fluoroscopy. So at the time of the dilatation, if I'm concerned that there is a deep tear or indeed a perforation, we'll just do an on-table esophagram with contrast. If there's still a concern, then we'll do a water-soluble a CT with contrast, not a chest X-ray, because actually you want to really see that extravasation of contrast beyond the esophageal wall that will be diagnostic of perforation.
Right. Rehan, proximal esophageal strictures, particularly the post-cricoid strictures vis-a-vis mediastinal or mid or distal esophageal strictures, any difference? Meaning, because these patients, these strictures, if there is a perforation, they can land up with mediastinitis much more easily. Vis-a-vis, a perforation in the neck is much more easier to treat. So, we usually have a policy of we might put in a nasogastric tube if it's a post-cricoid stricture which perforates as compared to mid-esophageal, where we would be more keen to put in a stent right away sometimes.
Yeah, I couldn't agree with you more, Amol, because the cervical space is quite close, and you see that very rarely after a Z poem where they have a bit of a leak. They settle down very quickly. So I agree with you. A lot of the head and neck patients who have high strictures It's also very, very rare to perforate them. There's something about that cervical fibrosis that you get in the cervical esophagus. You know, they do happen, but they're very, very uncommon, Amal.
That's true. Right. Thank you.
So, Lihan, would you like to continue your fistula talk?
I'll do whatever you want me to do.
Yeah, because you are here. Would you like to continue your fistula talk?
I can talk for all afternoon if you'd like. Yes. Let me just share. Just a moment. Right, can you see my slides, Nora?
Yes. Now, yeah.
Perfect, thank you. So I think this is a really, really important subject. This is poorly taught, poorly studied, poorly managed. Actually, this is probably one of the first congresses that I've seen this this lecture on. So a fistula really is a communication between two body cavities. Now, the majority of these will be as a result, in fact, almost exclusively will be as a result of something that we have done. Now, whether that is a surgical anastomotic leak, or as Amal talked about, an intraprocedural, I don't call them perforations, I call them a transmural transgression, where we have a full thickness defect. These will then develop into fistulas, which is a chronic communication between two body cavities. And I think that's really important, is actually we need to move away from being endoscopists to actually begin to understand the anatomy in a more surgical way before we think about which fistulas need treating and which ones don't need treating. Now, the approaches to intervention will vary. I think it's really important to stress is that not all fistula / perforations need to be treated. And this will depend on the size of the defect, the location, but also when it was recognized. Is it an acute defect, or is it something that is more chronic and can be left alone? So asymptomatic patients, you don't need to treat these patients with aggressive endoluminal therapy. They can be treated conservatively with drainage and antibiotics, whereas patients who demonstrate systemic upset with sepsis or indeed mediastinitis and cardiopulmonary insufficiency, these are patients where we need to think about intensive care intervention, but also urgent endosurgical intervention. Most of these can be treated endoscopically, and I'm going to share that in my slides that will follow. So when you're considering an intervention for a fistula or a perforation, you need to think about what are you able to deal with the different sizes and shapes of defects and fissures depending on where they are in the gastrointestinal tract. And then you also need to think about the reliability of your closure technique. If you're going to place an endoscopic clip, will it still be there tomorrow? Will it still be there next week to allow the mucosa to heal? And you also need to adapt to different conditions. The GI tract is a highly motile environment. So by putting a stent in, for example, how confident are you that stent is going to stay there? And what measures are you going to take to ensure that that stent stays in place for the short to medium term? Let's talk a little bit about esophageal injuries. Now, Amal talked about this. The most common areas that you will see esophageal injuries, hyperpharynx and cervical esophagus. This happens at the time of intubation in senior patients who will have a pouch or a Zenker's diverticulum. It would also happen when you're blindly intubating with either a side viewing scope or patients who are having TOE with our cardiology colleagues or indeed EUS. You will also see it in the context of we don't see this very much now, but I've seen several perforations in the context of acute variceal bleeds, Western Star and Blackmore tubes that people have erroneously inflated the gastric tube in the esophagus, and very rarely at the time of insertion of enteral tubes. Now, it's really important that before you start talking about fistulas, you know your anatomy. Let's talk about the esophagus first. The esophagus is a muscular line tube that actually traverses through the back of the mediastinum down across into the the posterior chest wall and then through the diaphragm. So when you begin to think about fistula closure or defect closure, especially in the mediastinum, and it's really, really important to understand that this is a closed system. So if you close the hole off in one place, then you need to have drainage in another cavity to make sure that the collections, the abscess, the effusions are drained, because that's what the patients will die from. That's when they will have a poor outcome, not from the fistula or the perforation, from the subsequent collections that will happen in the mediastinal cavity. And the same in the abdomen. So the perforations in the colorectum are very rare, but it is really important to have a surgical mentality to this, to know when you're going to get a retroperitoneal collection. And if so, how are you going to drain this? Because that's when the patients will mount a systemic response and have a poor outcome. Again, we get referred a lot of patients for fistula management. The important thing is exclude cancer. It is probably the most common non-iatrogenic cause of fistulas. So, you know, we have had patients referred to us with proximal esophageal fistulas actually end up being a cavitating cancer. Know your anatomy. And as I mentioned, you do not close undrained cavities. The patients will have a poor outcome. So engage early with your surgeons, with the interventional radiologists. And as I mentioned, not all fistulae need closure. You will have seen on the industry stands, you will have seen during the live courses, the live cases over the past day and a half, we have a plethora of endoscopic clips. These are by far the most effective, cheap and cheerful way of closing small acute on chronic defects. Know about the clips that you have in your unit. They all have very, very different properties in terms of the way that they are deployed, in the way that they can be rotated, but also now in terms of the aperture and the jaw opening. So know about which clip you have, know about how they are rotated, how they're deployed, and engage with your nursing staff, because these are not elective procedures. They happen when adrenaline is running high and you don't want to waste time and you want to know how to operate these. So endoscopic clips, probably the most easy to deploy. This is a gentleman with chronic hepatitis C who presented with a GI bleed and had a Singstaffen Blackmore tube inflated in the stomach. What you can see here subsequently on the chest radiograph is a leak and then a large clot overlying a defect. First thing in here is to make sure that you're doing this in a stable environment. And what we can see here is a very large clot overlying what appears to be a mucosal defect. Now, I know there's a perforation here. The first thing I'm doing is just optimizing my environment by putting in some submucosal injection of 1 in 100,000 adrenaline, just to give me some local vasoconstriction. And then the second thing I'm going to do is I'm actually going to remove this clot. I'm less worried about bleeding here, but what I'm most concerned about is in making sure that we can get closure. This patient, before this had even happened, had bilateral intracostal drains in intensive care. And you can see that once the clot has been removed, you then begin to appreciate the severity of the mucosal injury and the perforation, which is linear. So in this sort of patient, Noriko, Amol, it's entirely acceptable to use endoscopic clips. And as we've seen in the ESD closures, have a plan. Always in this sort of injury, start from the anal end to the oral end and use the insufflation, use a distal attachment to stabilize your scope position and rotate your clips. And remember, you don't always have to open the clips to their full capacity. So always start with some normal tissue on the anal side. And this is really very straightforward. You know, this can be done by most of our fellows. And I'm just going to forward the clip just because of the confines of time. And you can see here, this patient had complete closure of the defect just with straightforward endoscopic clips. And they rode out a rocky time on intensive care and then were extubated and eventually had tips for their portal hypertension. Now, over the scope clips by Ovesco, these are a fantastic adjunct to conventional endoscopic clips. and come in different shapes and sizes. So again, it's important to understand which ones are more suited to your particular needs. I think that the OTSC, the GC, the elongated teeth with the spikes is probably the best. We use this quite a lot in our unit, and there are different properties and different tools and tricks that you can use, such as the tripod, the bilateral tissue grasper, to allow you to oppose mucosa and tissue to close defects. This is a schematic showing how this would work in a patient here with a distal esophageal injury. This is a patient who had a perforated duodenal ulcer, and you can see here that I've made an attempt previously to close this with endoscopic suturing, and actually this is often a stepwise procedure, Amol, because you can't you bring the tissue together and then you come back a few weeks later. So this first thing I'm doing is I'm just placing a jag wire into distal stomach just so I know where my lumen is, and then I've defined exactly where the defect is. I can see that from my previous suture device here, and then you can see the over the scope device here, mount the Evesco clip over the scope. I have wonderful visibility here. I don't actually need to use a tissue grasp, I can just use the apposition with the endoscope, but also suction to deploy the clip, and then a real-time fluorogram on table shows complete closure. But very easy to use and very good for sort of young fistulae. We talked about this yesterday in terms of the endo loop. Now this is quite fiddly, is best performed with a double channel scope, and can be used with a very careful approach in terms of clipping the sides of the endo loop and then closure. It can be quite fiddly, but can get you out of prison if you are in a tricky situation. Very quickly, going to talk about stent insertion, as Amol talked about, especially in the mid-esophagus. Know about your stents, like I talked about clips. Know about the diameter. Know about the dimensions of the proximal and distal necks. This is really, really important. There are asymmetrical stents, which will be preferential in cervical injuries. And the migration rate with uncovered stent is not insignificant. And also, when the stent goes in, it has to come out. So here, there's a trend here in our unit about posting starting buffer jaw perforations here. This, you can see a large, mature fistula here in the distal esophagus. You can see the mediastinal fat. Again, this patient has a intercostal drain. So the first thing you want to do is you want to go into the mediastinal cavity and you want to drain as much of this crud as possible. You can use a snare, you can use endoscopic clips to try and remove as much debris from the chest cavity before you think about closing it. Now this defect is too big. This is in the days before I had access to endoscopic suturing. So what I've done here is I've cleaned the mediastinal cavity, and then actually, just to fast forward here, most of you will be able to do this. We have placed a stent. Now this stent will migrate because there is nothing to hold it in place in a normal esophagus. So our approach now is always to suture these in place at the proximal end with the Apollo device. This is very easy to do, takes just a few minutes, and then remove this stent at 6 weeks to see what is left. So this is the Apollo device, which Barham showed yesterday. And you can see when the stent was removed 6 weeks, 8 weeks later, sorry, the defect had healed and closed. Apollo overstitch, very good for small fistulae, especially in the stomach. This is a post-gastric perforation patient who had had a previous PEG tube. Actually, this was a chronic PEG tube. Now, I have stopped using APC, but this is what we used to do. The important here is to try and create some mucosal irritation so that when you oppose the tissue, you will get apposition and healing. What I do now is I do a circumferential ESD around the defect and remove the the mucosal layer so that when you bring the tissue together, it will heal. I also, you can see I've placed a clip here just to give myself a little bit of anchorage, and then using the endoscopic suturing device, you can get full thickness closure here. And again, a very straightforward procedure, and will save this patient having a chronic fistula, a stoma bag, and a cutaneous, an intracutaneous fistula, and surgical intervention. So I'm just going to forward this through. You can see here, all it does is a couple of crisscross uninterrupted sutures, and this is closed very quickly. How to suture, I'm not going to spend too much time on this. There's lots of different patterns that you can adopt. And there are some retrospective data on this showing that the Apollo device is really very good. Now, this is another case of a esophageal, a mature tracheoesophageal fistula. So this is a site that most gastroenterologists don't want to see. And so you can see this is a patient who had had a previous esophagectomy, cured of their cancer, but has a chronic lower esophageal trachea. So it's just, you can see the surgical clips there. Re-intervention in surgery for this, I'm sure Norika, Amol, you would agree, would involve probably a subtotal gastrectomy and a gastric interposition, and so big surgery. So now we're very lucky that actually with the Apollo overstitch device, I'm going to forward this through, you can suture this defect. So this patient here has lots of healthy tissue around this mature fistula, and actually starting from the oral end to the anal end, and actually using some of the pleural cavity and the lung tissue, you are able to close the defect. This patient needed 3 sessions before they had complete closure using this technique. And I'm just going to forward on to the end here because I'm sure you're very bored of seeing lots of us suturing. But a good option in these patients. This is what I was talking about. What I do now is I do a circumferential ESD around the fistula site, and then oppose the tissue with the suturing, and this allows better apposition. Last video, I promised Noriko, and then I'm going to shut up. This is a very recent one. This is a patient who had a Boerhaave and was referred to us 6 weeks on. Really, really important that before you close the defect, that you clean the cavity. This patient is intubated with bilateral drains. Now, I was unable to go into the defect, and so what I did is I used a 35mm achalasia balloon to actually dilate the fistula and then enter the mediastinal cavity. And you can see that once you're inside the mediastinal cavity in these mature fistula, this is a bit like a necrosectomy. You've got all sorts of crud in here. And before you close this, you want to, so you can see in the distal, you can see the lung parenchyma. So what I'm using here is a combination of endoscopic clips to try and clean the mediastinal cavity. And because you have intercostal drains in here, you can actually flood the mediastinum and put negative pressure on the intercostal drains. And actually, you can see at the end, this is the lung parenchyma here. We've completely cleaned the mediastinum. So again, here, what we're going to do then is just use a little bit of APC just to irritate the mucosal edges. And we will then again use the Apollo overstitch device to very quickly close this defect. And then what I have done at the end is actually use some methylene blue and put negative, just flooded the esophagus, sorry, with some methylene blue, you can see here, and put the drains on negative pressure. And as soon as you see no methylene blue coming out of the intrathoracic drains, then you know that you have full closure. Endoscopic vacuum therapy. This is a fantastic but very work-intensive intervention for chronic fistulae. But the data on this is really impressive, and most cardiothoracic units should have this on site. So I'm just going to finish there. So in summary, These are often high-risk procedures, so please have surgical backup, intervene early, decompress the compartments, drain them antibiotics, think about nutrition. Size of defect will define what modality you use. Endoscopic suturing is very good, especially for mature fistulae, and will facilitate good outcomes and reduce the rate for readmissions and possibly surgical intervention. And don't undertreat these fistulae; they can really cause a lot of problems. Thank you for your time.
Thank you very much, Lee-Han. We want to ask a lot, but we are quite behind. So we can take a quick questions.
So Rehan, congratulations for the talk. What do you think that the role of vacuum therapy is for bigger leakage, bigger fistulas? So your first option is always to closure before, or what do you think? What is your approach?
I mean, I think my first approach is actually not to clean and not to close fistulas if I can avoid it, because unless you decompress the connecting cavity, then closure alone is just not going to work. So if you have, if you're draining the mediastinal cavity, if you've got drains into the peritoneal space, then you can think about closure. I think that the sponge is probably better for defects that are in the region of 20 millimeters or less. Bigger cavities, they just won't work. But it is work intensive, but is actually very, very effective.
Thank you. Amo, would you like to make a quick comment?
Well, I think Rehan has covered the topic really well, and I will fully agree with him that decompression and getting control of the necrosis and the sepsis in the cavity is most important. And what happens is often there is a lot of pressure from all our peers to close the fistula. And that's where things start going wrong if we try and close it too early. So I fully agree with Rehan that I think decompression, that's something that we also follow, and we would not want to close the fistula very early. One point I would like to make about stents. Earlier we used to use stents very often, but we've really had quite disappointing results with stents, because stents will often seal off the fistula temporarily, but it doesn't really cause healing of the hole. And you take the stent out after a few weeks and the hole is still there. So that really makes things difficult, and then you have to start all over again. So I am a little bit against using stents whenever possible. We would rather close using clips or sutures whenever. That's all, I think.
Thank you very much, Rehan. So we are going to move the next talk from Dr. Edward Albeniz from Spain.
So thank you, Brady, for this invitation. I'm honored to be here because it's a really big event. So I am going to talk about delay bleeding, but talk about delay bleeding of every technique. So my main focus I'm dedicated to delay bleeding after EMR or large colorectal lesions. So everybody knows that it's the most frequent major adverse event for EMR, with an incidence about 6%, more or less. But we don't have accepted guidelines to manage this complication. So the definition is a clinical evident digestive bleeding after endoscopic resection with a timeline about 30 days, more or less. The risk factors associated to this complication are location, size, interprocedural bleeding, use of electrosurgical units not controlled by microprocessor, the older age, hypertension, the anticoagulants, and comorbidity. Okay. So in this paper, we tried to validate the two previous scores from the Australian group and for our Spanish group. So in the validation, we display suboptimal validation of both scores. So we tried to create a new one with only four meaningful variables, trying to identify the bleeding risks a priori. Okay. So this is the score. So this is major comorbidity or SAS classification with 1 point, lesion size over 30 or 40 millimeters with 2 points, right side lesions for 3 points, and the use of anticoagulants or antiplatelets. So again, with 3 points. So we have measured the risk from 1 to 20%, divided in three risk cohorts: low, medium, and high risk. We have medium risk about 2, 4%, and 50% in each group. Okay. So more or less, this kind of this kind of scores are not a dogma. So, but we can bear in mind, we can have in mind all these risk factors. And now we know how to identify patients at risk, but can we prevent delayed bleeding right now? So this is the measures that we have in our portfolio. So this is the adrenaline, the prophylactic vessel coagulation. So what happened with this? We have scar evidence or evidence against or conflicting results. So adrenaline mainly works in a medium bleeding, but we don't have proofs that it works in delayed bleeding. What about prophylactic vessel coagulation? So we don't have any evidence that supports the use of APC. But with the snare soft tip and coagulation forceps, we have conflicting results in some papers. And everybody knows that, for example, when we perform ESD, we have less percentage of delayed bleeding. So probably it's not proven, but it has a role, and probably we agree with this. So the only measure that we have randomized trials that prove the value is with clips. This is the only measure. So what happened in previous meta-analysis? Previous meta-analysis say that the clipping didn't decrease the occurrence of delayed bleeding, but it was the reason that different studies, different techniques, different size of polyps, a mix of pedunculated polyps, a mix of non-pedunculated. So the conclusions were ready to support that good evidence. But in 2019, the group of Rectal published in Gastroenterology this big randomized trial, proven that clip closure significantly reduced procedural bleeding. But the effect was restricted to the proximal colon. In distal polyps, they saw some strange results. It worse to clip than not to clip, 4% measures, 0.4%. Our group also performed another randomized trial, and we use our score to select patients. So we reduce a lot the end of patients to be included. So we only include 235 patients. And we also proved that clip closure reduced delayed bleeding from 12% to 5% in the intensive treatment analysis, and to 12% or 1.5% in the per protocol analysis. So afterwards, we performed with a group of Cesare Hassan, Repici, and Marco Spadaccini meta-analysis. And also we proved 2 different cohorts. Clipping doesn't work in small polyps, but it works, but the reduction of bleeding is very poor. But we saw a clear effect in large lesions, over 20 millimeters. Also, the other risk factor that we could measure is the location, and large lesions and right side lesions are the 2 combination factors proven in this meta-analysis. But if you can read all the paper, nobody does normally. So if you go to this supplementary figure, after doing a leave one out analysis and excluding one study, the Rectal study, because this kind of strange results in distal polyps, we also see a significant effect in distal polyps. But what happened in distal polyps? I believe that clipping works everywhere, but the reduction effect is much less powerful. So this is the reason that everybody says that we must clip only large lesions on the right side, in the right side column. But after I will say you a more global approach. We also performed another meta-analysis with a group of the Netherlands, And we saw that prophylactic clipping is effective, especially in patients using antithrombotics. This is another proof that we must consider the patient in global, not only location, size. So we must consider all these kind of risk factors. This year, the group of Michael Burke has published another meta-analysis focused on the right colon, and they saw a difference between non-clipping and clipping between 3.4% and 10%. And the effect was more significant in the second, especially in the second. So now we are preparing with the last 4 randomized trial focusing on the right colon, and the difference goes between 9 and this is an unpublished results. It's from 9 to 2%. So this is probably the most studied measure. So clipping works. Now we have preparing a review in American Journal. So we try to show that we must keep in mind that patient consideration, age, comorbidity, SAA, size, proximal location, medication, of course, anticoagulants and antiplatelets, and the technique also. The technique we know, and now we have evidence about the hot snare technique and the cold snare technique, and of course to use microprocessor control electrosurgical units. Technical tips for closure, because we can closure many lesions, but large lesions in our randomized trial, maybe 30–40% of the lesions couldn't be closed due to location or big sizes or access. So please assure optimal access. Consider change position, the position of the patient. Do the procedures with medium insufflation, not insufflate very much. Start one side from the other, and start from the most complex area. So it's important to perform a continuous placement, and you can put the clip in the healthy mucosa, suction air before clip closure to assure inclusion of mucosal layer. I'm sorry. And please keep close enough to have a non-minimal submucosal tissue. Ideally, we can use all the clips that we want, but ideally we don't permit gaps more than 5–6 millimeters. Otherwise, we have a lot of submucosal tissue without clipping. Okay. And why not we have another adjuvant techniques, mucosal incisions to hold better the clips, or to use elastic bands, thread, polyloops. So now we have many possibilities only just with clips without considering other over the scope clips or other techniques. So this is our our flow chart of management that we are going to publish in American Journal. So when you have a large non-pedunculated polyp, so please estimate the bleeding risk and consider using a risk score, but this is not a dogma. So this way we can individualize a procedural management of antithrombotics. Why not consider a cold snare technique when possible? And if we have serrated polyps, so cold snaring, as we saw this morning, it could be our first option. We have a distal location and additional risk factors. So we must to have individualized decision, because we have limited data, but we believe that clip is work here also. So we have proximal location or combination of risk factors. So a complete clip closure is a good measure. It's a proven measure. And if we have distal location and no other additional risk factors, the efficacy is going to be very poor. So because we are trying to decrease, for example, a risk bleeding of 2% is very difficult and it's not very cost-effective measure. And after this, we can give a patient recommendation based on bleeding risk assessment and personal circumstances. It's not the same if the patient lives 100 kilometers after a hospital or something like this. So we also have published a cost-effective analysis, and clip closure is a cost-effective measure in patients with a high risk of delayed bleeding, even cost saving in our environment. We have created this is a formula, but that you can use it everywhere in the world, but it depends of your cost the cost of, for example, the cost of the clip, the cost of a delayed bleeding in your hospital. So there are many factors included, but it's a cost-saving measure in our environment that we are using clips around, I don't know how much does it cost here, but in Spain it's around 80 euros, from 60, 40 to 80 euros. Maybe in all of Europe is more the same. In United States it's around $150, so it depends on the cost of the polyps. And in this paper, we have an idea of what is the minimum delayed bleeding cost to be cost effective, or for example, this is in our environment in Europe. If the cost of the clips is over 80 euros, is not cost effective, so we can pressure to the companies. But in the United States, the price could be higher, as high as $154. And this is the cost that we can use in all the mucosal defect, near 400 euros in one mucosal defect, and in United States near $400. This is the minimum intervals to be cost effective. It's around 4 millimeters. And apart from cleans, now we have another options like gels. Okay? So you had a really nice symposium of Purastat. So you can use right now Purastat not only for hemostasis, but the wound healing properties is going to be something very interesting in the near future. I will show you a video. And right now we have small data, but after the POP study, I think that things are going to change, because now we are more robust data, and we have another indications. For me, it's very interesting, for example, in ulcers, radiation proctopathy, and any other measure. Of course, in this kind of situation, we can clip the ileocecal valve. So this is an example. For example, it was a very difficult case because a lot of jumps of the endoscope, but we had an adenoma inside the valve and inside in the distal ileum also. 3/4 of the circumference of the distal ileum, you can see. We are a little late, so I will show you. So it's very important in this kind of situation to begin the resection in the worst part, or in the most difficult part, so inside the ileum. Because if you inject first of all the valve, it's every time it's difficult, more difficult to go inside the ileum, more with a big cap, with a colonoscope and with a cap. So after the resection, so the only this is is right side over 3 centimeters, each patient. So okay, it's a good option to apply Purastat in this case. It's not easy because of the jump, but the application is very easy. It's transparent, and you have seen the complication. In ESD, the delayed bleeding is less, but okay, clipping and gels are a good option right now. But okay, but the rate of delayed bleeding is much more less. And in the stomach, if I can, apart from the coagulation of the vessels, also we can apply these measures if we want to reduce to near zero our delayed bleeding rate. And I will finish my talk with a last video. It's a combination of prevention of two situations: prevention of bleeding and prevention of strictures. This is a very nice case. Anybody in the audience know which is the illness of the patients, which happens in this esophagus, apart from having a cancer? Which is the no? This is a esophageal lichen planus, okay, and this is a woman who made a squamous cancer over a lichen planus. So it wasn't diagnosed in the endoscopy room, and there were two circumferential cancer, one 10 centimeters in the distal part, another of 5 centimeters. So as you can see, the diameter of the esophagus is just like a cup. So I was afraid to having a a big stricture. In this situation, this is a phenomenon called the phenomenon of Koebner. So when you damage a little the mucosa, you worsen the damage of the tissue. So the more inflammation, and so it's better not to dilate if not necessary. So another quite new thing in this video is that I am doing a single tunnel technique. So I am doing a single tunnel in the anti-gravity, in the anti-gravity part, in the most difficult part, doing more than 200 and maybe 50 degrees. So first of all, I do a tunnel, just a tunnel, and afterwards I connect both sides. So it's a very, very quick procedure, and I'm using a spike quack. And in 1 hour and 15 minutes, we perform the first ESD. So it's very quick if you do only one tunnel. Okay. So after cutting, we are a little late, so after you can clip this kind of mucosal defect. So the only measure that we have now is the gel pugastat. So this way we can prevent delayed bleeding. It's not very frequent in esophagus, but sometimes it happens, and sometimes it could be severe. You can see when we apply pugastat, the color of the blood change, and it's very easy to apply even in a circumferential, and with not many millimeters, we can cover all the defect. So in one session we did the distal part, and the second day I was waiting what happened, big stricture or not, but we had the stricture, so I was happy. And this is the other one. The other one after MBI and after Pinson, we saw that it was a circumferential look in the distal. So I cut again. So we cut the distal part, we cut the proximal one, and in one cut I made the circumference. And then again the same technique of single tunnel. So it's I do quite a lot of poems, so maybe it's due to this that I'm doing this technique right now. Okay, it's not about ESD. So again, the lesion was 5 centimeters, but it's compressed. And we made another application of pugastat in the other scar and in the new one. And we have made 2 controls right now. Again, circumferential application. And we didn't have, this was really fresh right now, but with no stricture in both sides. So we are waiting for a third control, and I will tell you the result afterwards. So our conclusion is select patient at risk. You can use the score or not, but you have in mind that the use of anticoagulants, right side, size over 3-4 centimeters, or comorbidities to treat high-risk patients with clip closure, or knowing that clip closure is cost-effective or even cost-saving in our environment in high-risk patients. And of course, other ideas. If you want to reduce the bleeding to maximum, please clip the defect. So you have any kind of situation, you have a private practice or everybody that lives very far from the hospitals. And it's important to know that all previous studies has been done with 11 millimeters clips. So we have now more clipping possibilities, 16, 17, 20, combination with loops, threads, and why not combination with gels if we have a partial clipping or just gels. Okay. So we have a research group in Spain. So we are doing quite a lot of studies. So we are invited, of course, invited to join us and to follow us and to share science with that. So thank you for everything. That's all.
Thank you very much. Can I ask quick question? Thank you very much for developing that score, post-polypectomy bleeding score. And do you give any different advice according to the score, high score patient, low score patient? Are you going to give any different advice? That is the first question. And second question, after EMR, if you do very shallow resection, sometimes we can see vessels in a EMR bed. Are you going to do something on this kind of vessels?
About the first question, it's I don't make the sum, of the 1 point, 2 points, 3 points, but I have in my mind that it's a right side lesion, large lesion in an age patient. So I try to close. If I can't close, okay, at least if I have Purastat, of course I put Purastat. But if I can do anything because whatever the reason is, I tell the patient, okay, you have a very high risk of bleeding, so please stay close to a hospital or stay with a relative. And in the opposite way, if it's a small polyp, distal polyp, no anticoagulants, anything, okay, you can be quite comfortable. It's very rare to bleed. And the second question is, with standard vessels, I don't touch standard vessels. But there is a Chinese paper that pay a lot of attention to cut vessels. So we must pay attention after our procedures to see some seconds or minutes to baromucosal defect. So if I see cut vessels, I coagulate it with the snare. So in EMR, in ESD, of course, I coagulate many things in the rectum, but not so many in the right colons.
Excellent. Thank you very much, Eduardo. It was a great talk. If you come and join us, finally moving on to the thing that we dread, which is the perforation. Making holes. Noriko is going to tell us about fixing holes in the colon. We should never make holes in colon, but if you do, then Noriko is going to share her experience of how she made a hole and why she made a hole, and then how she fixed it.
Yeah, unfortunately, I don't have much sharing experience for perforation.
Very, very good answer.
So if I cover from upper to lower, that is a very extensive talk. So I want to focus on colorectal perforation. Sorry, this is. Just a moment. Go back to. Sorry, my talk has gone somewhere. Oh yeah. Thank you. So perforation happens even from diagnostic procedures. So risk factor for the perforation from diagnostic procedure are older age, comorbidity, inflammatory colonic disease. So basically weakened wall. And if you are experienced endoscopist, you are more likely to perforate, unfortunately. And common perforation places from diagnostic procedures are sigmoid colon and RS junction. So tip or even shaft will the force will stretch the bowel and then perforate. So let's now move on to the endoscopic resection. Of course, these are associated with perforations. So without much supplies, ESD has got the highest perforation rate, 5%, around 5%. But normally, ESD perforation is a pinhole perforation. Therefore, clipping is really effective, followed by FTLD. And some people may worry about underwater EMR, but this morning I said this is very safe procedure. And of course, corded snare is zero perforation rate. Having said that, there are some cases of perforation reported. So just don't consider this is zero risk perforation for any kind of procedures. So I'm just going to talk about the risk factors of perforation in ESD. So right-sided lesion and piecemeal resection. What do you mean by piecemeal resection? Which is technically very difficult. So therefore, the operator has to change the snare resection, become piecemeal. So difficult ESD has higher rate of perforation rate. And then in LSD, if you are going to compare G type, NG type has got the fibrosis, therefore much higher perforation rate. And I just want to show you this sign, muscle retracting sign. Maybe it is worthwhile remembering this sign. So during the ESD, you can see some area you can't appreciate any submucosal layer. And basically, muscle was pulled into the lesion, couldn't separate it. It is called muscle retracting sign. This sign can be often observed in protruding lesion. And if you see this lesion, this case has got a higher risk of incomplete resection or perforation. So if you do ESD, if you see this sign, just think about maybe rectum, maybe you can carefully dissect, but maybe above the peritoneal reflection, maybe you had better back off. So I want to talk about Sydney perforation score. So everyone wants to do grading everything. So this Sydney perforation score, basically type 1 is muscularis propria is exposed. Type 2, heat damage to muscularis propria. Type 3 is muscularis propria is shaved off. So endoscopically, target sign is really relating to this type 3 grade. And type 4 is full perforation, and if fecal contamination, this is type 5. And type 3 to type 5 perforation, you have to do something. This is a clinically significant perforation. And this is observed 3% of endoscopic perforation. And what we can do as endoscopists is a clip application. And risk factors for type 3 to 5 perforation was reported. So transverse colon location and en-bloc resection or high-grade dysplasia or submucosal invasive cancer. I think this is some kind of fibrosis is relating to this phenomenon. So how we can minimize occurrence of perforation? So if you do ESD, please observe the line of muscularis propria layer, and the knife movement has to be parallel or away from the muscularis propria, if you use forward cutting knife especially. And if you can't see well, don't do it. Just wait to create a better view. And if you do EMR, I'll say do underwater EMR. And I know I'm quite one of the minor endoscopists, but I like to close the snare, especially when we apply. I apply diathermy. So I don't know, in the future, AI might calculate the resistance from the tissues. So if you grab fat tissues, scar tissues, muscle, you feel very, very tight. But nowadays, diathermy is so clever. They are calculating, try to cut very smooth dissection or cutting. So I really want to see some kind of resistance, maybe indicated by number, or at the moment, I'm really try to feel by myself. So really in the future, it may change something. But we try to minimize the occurrence of perforation happens, unfortunately. So let's stand by for perforation. Firstly, we have to optimize the situation. So optimal valve preparation is essential. So please do clear before applying endoscopic resection and use CO2. And you have to make sure you have got the assistant familiar to handle equipment. And just to, sorry, no. So equipment, please make sure that is in your room, not in the next room or in further office. And you have to be competent in clip application if you do endoscopic resection. I just want to show you, this is my friend kindly shared this video. Edward, you may know this case. So this case had surgery for colorectal cancer, and LST-NG was observed. So during the EST, they did the retroflex approach, and you can see this yellow tissues. But fortunately, because of the colon cancer operation, that part tissues really backing up. So therefore, this is type 4 perforation, no contamination. So devastating endoscopists still try to remove the rest of the tissues. And then they use clip line method to close this defect. So if the perforation is big, as you can see, the line was tied onto the clip, and then they fired onto the normal mucosa. And the second clip is grabbing this line and take this line to the other side. Dr. Ihagi probably do the other way. There are another way to do this. And fire. And what these two clips does is, so by pulling this line, you can see the big ulcers now become quite linear. So therefore, further clip application become possible. Quite a lot of clips were applied.
Within so many clips?
Yes, but I think at this situation, you just couldn't, you shouldn't count the cost of the clips. You have to save the patient.
You clip till you cannot clip anymore.
Yes, indeed. Okay, can you go to the next? So this is a CT scan afterwards, and there is no extra, like a leak. So this patient was discharged 4 days after clip application. Can you go to the, can you play the video? So
we were still working on the esophageal tunnel, but we noticed that actually the patient, if the cameraman can go to the abdomen, actually the abdomen is swollen and is tight. If I, not sure you can hear there. So there's definitely a pneumoperitoneum. There's no problem with anesthesia yet, but we want to desufflate it because this is too much. And yes. Professor Inoue will give us some education on desufflation. This is an important thing for therapeutic endoscopists nowadays. You have to be able to desufflate the pneumoperitoneum.
Yeah. So patient is actually a pneumoperitoneum. So we tap the abdomen. So we use a 16 gauge needle. That is just for intravenous catheter. And then I attach the saline and the 20 millimeter syringe like this. And then first thing is a pole, make an empty stomach. So suck the old gas.
I think gastric.
And now the stomach is totally empty. And then abdomen is very tight, so straightly, like this. And
show then, it, yeah. No,
yeah.
Get the endoscopy away, please.
Okay.
Yeah.
And then a little bit advance, and then carefully, slowly, Okay, now we can get the CO2, and then advance a little bit, and then we place the outer sheath into his abdomen. I take out the needle, and then I confirm the CO2 is like this. Okay, now you can see like this. So CO2 is coming out. So, this can easily avoid the compartment syndrome. So if the patient abdomen is extended, so we tap the patient abdomen like this. And
how do you normally, because we still have like half an hour to go, do you normally leave the catheter in or you just take it out?
Yeah. So at the end of the procedure, we put.
Yes, but right now for the next half hour you leave it. Leave the catheter inside the abdomen, or do you tap again?
No. We always keep it.
Yes.
Until the end of the procedure, and then you can insufflate as you want.
So this is nothing for Professor Inoue.
You should do this.
This is post-poem, I think. Must be a poem patient with pneumoperitoneum.
To ventilate, they'd be getting hypotensive. You need to do that emergently. At what point do you say, we really need to do it now rather than wait?
I think it's important to feel the patient's abdomen occasionally, and just mention. And there was a little bit swelling maybe, but now it was really quite big, and we still have half an hour to go. Plus, if you don't tap it and you have the patient wake up, he probably will have a lot of pain.
Yeah.
So I would always tap it if it's like this, probably immediately. Don't wait. We're still working.
So in case of pneumoperitoneum, I think we probably have to know what we should do. So perforation occurs, clip closure first, and maybe up to type 3, if serosa is still kept, maybe you can discharge patient. And in case of further, like a full perforation, if necessary, need aspiration for pneumoperitoneum, and you have to hospitalize patient and manage, and if necessary, please consult surgeon. So this is the end of my talk. Please keep calm and manage perforation. Thank you.
Thank you very much. I think that was very good demonstration of the most crucial factor. Even if you can't close the hole, it's very important to relieve the pneumoperitoneum, because very quickly patient can become very unstable. They drop their blood pressure and they can even have a cardiac arrest. So that last trick that you saw is very, very crucial for us to know. I think we're running a little bit late. If you don't mind, we could move on to the next talk, unless somebody has a burning question. Looks like John wants to ask something. He always wants to ask. So can we?
It's not a question, it's just a point. So you showed the Sydney deep mural injury classification, and in their study, the type 2 injuries over a scar, they had 2 perforations in about 200 cases, something like that. But on the back of that, they advocate clipping the type 2 lesions. Now, it looks like clip overkill, but we're hearing more and more clips are probably better. It's just, I think we need to mention it because they are advocating clipping those type lesions where you've got muscular whitening, largely in relation to scarring, but I think you need to clip those. So, there's not a big hole. I think we should probably clip them. I have moved on.
I think, John, some clips are, clipping happens because we want to fix something in the patient. But a lot of clipping happens because we want to fix our own thought process. It makes us feel better. Doesn't do anything for the patient, but makes us feel better that you've done something. Because sometimes when we walk out of the situation and then patient comes back with pain, you miss the boat. That's why endoscopists think like that. I think there's a point at the back.
I tailor individually, so I can't give you the
That's a typical Japanese reply to everything, case by case.
Case by case.
I think follow the guidelines. That is the easiest answer. Dan.
prophylactic clipping in the right colon. Often when you come back several months later to review the site, whether the clips are still there, it could make it very difficult to review the site to look for recurrence. So I've tended to move away from that and use more Puristat. And do you think that is a reasonable thing to be doing in this current state with the evidence that we have on?
Yeah, we're sitting to Mr. Clip here, so he's going to say we need more evidence. But I think you need to go case by case. Clipping is expensive. Clipping is challenging. Clipping can cause harm. You need to see where the lesion is, how the access is, how good you are with clipping, how good the nurse who's supporting you is with clipping. All those things count. Eduardo has shown very well in his study that in only 50% of the patients, they managed to do proper clipping. In 50%, they did not. And if you cannot achieve proper clipping, it makes you feel better, but it's not doing a lot for the patient. So it's a balance. I don't think it's one way or the other. I know if we engage more, we'll drag on. So I think we should move on. Can we get Mark's talk? Mark, thanks, Rehan. Thanks, Amol. Please stay on. It's a very exciting talk from Mark. He never gives a simple talk. So Mark is going to challenge you to show you the future, what can be done through EUS. Mark, thank you for joining us. Are you there, Mark? No? Is this talk there?
Yes, I'm there.
Thank you, Mark. We got a little bit nervous, but thanks a lot for joining us. Mark Bate is a phenomenal endoscopist, but I think more of a EUS endoscopist rather than a simple endoscopist. He does everything, even a gastroscopy through a EUS scope. So I think Mark is going to show us where this world of EUS is going. Thank you, Mark.
So, I will try. So do you see my slides?
Yes, we see your laptop with all your slides.
Okay.
Beautiful place. Is that your place, Mark? Is that your house?
You see, the mountains are close to my house, 15 minutes, and I'm doing a mountain bike. This is a Vieux-Port in Marseille, and this is my hospital, which is called Hospital North, in the north of Marseille. Okay, so I start. So why developing therapeutic EUS? Because of course it's incisionless procedures, and it clearly reduced the hospital stay. You see, just today I did 2 EUS-guided biliary drainage and 2 EUS-guided gastroenterostomy, and so the patient will eat tomorrow and will discharge from the hospital in 2 days. And also you can treat some lesions or disease that are not accessible to any treatment, even sometimes for surgery. So what I want to point out, it's a therapeutic EUS, in fact, is not, because we are treating an organ out of the digestive lumen. So I will try to speak a little part of these topics, biliary and pancreatic drainage, EUS gastrointestinal anastomosis, direct antitumoral treatment, and vascular EUS-guided therapies. So just to underline that you have now 2 recent ESG guidelines for therapeutic EUS with clinical guidelines and technical guidelines. I think it's helpful for a lot of us, and also for me. Even I participated a lot to these guidelines, you can imagine. So I will first to speak about biliary drainage with the example of alter anatomy, because you know it's a challenge with PTBD and also with URCP endoscopy. So this is a challenge in alter anatomy, and I will show you some examples showing that you can do a lot using biliary drainage. And the recommendation of ESG is to use it when you have a malignant disease, and to discuss if it is a benign disease. But I use in all the cases. Why? Because if you look to the challenge with enteroscopy, you see the main studies have only a 70% success rate and a long duration. And if you look to PTBDs, the morbidity is very high, more than 30% of the cases. So this is the recommendation I told you about. We have in altered anatomy, gastrectomy, bariatric bypass, Whipple procedures, case of stenosis of the biliary anastomosis and or intrahepatic biliary stones. I will show both examples. This is after 2 weeks after doing hepaticostomy in a case of patients with Whipple procedures and stenosis of the biliodigestive anastomosis. So you see, I pass through the fully covered metal stent, and now you see it's like PDBD, but you do that from the gastric lumen. So for the patient, it is an output the patients. So you see ambulatory procedure. You see now the jejunum, okay, and you see we did a dilatation, and after you can retrieve the stent and put two double pigtail stents. You see the fistula created between the gastric wall and the biliary duct, and you can treat the patient during 1 year without any difficulties and in output patients. You can do that also if you have intrahepatic biliary stones, and it's also the case with spyglass transgastric investigation after EUS hepaticostomy. You see the spyglass coming through the gastric fistula inside the intrahepatic biliary duct. You can see clearly the biliary wall, and you see this is the stones just upstream to the biliary anastomosis. And now, so we can treat with lithotripsy, laser lithotripsy, the stones. Okay, you see the small probe guided with the colonoscopy, and it is only possible because we did a previous access with hepaticostomy. And now you see we are going to find, you see we have a complete stenosis, and we are going to find the biliary jejunal anastomosis with the guide wire, and you will see, okay, we try to find it, and now you see the guide wire passing through the tiny anastomosis, and so after it you can put a balloon, do dilatation, and after you can put a double pigtail stent with pigtail into the gastric lumen and pigtail into the jejunal lumen. And after every 6 months, you come back and to exchange the double pigtail stents until you reach a good calibration of, you see the waist of the stenosis. So this is a very simple and for me elegant and also for the patient acceptable treatment. You see, this is one pigtail into the jejunum, and this is the second into the gastric lumen. So you have no risk of migration, and it is very efficient. You can add 2, 3, 4 pigtail stents until you dilate the patient. So we have 2 series which are retrospective, and we are just publishing our experience, which is the same. You see 17 successful biliary stenting out of 20 patients, and clinical success in 37 patients, 91% of the cases. But you have to do a 2-step procedure, because if you do a 1-step procedure, you have a risk of biliary peritonitis because you have no adhesion between the stomach and the liver. And this is very important. Do a 2-step procedure. First one, hepaticostomy, and with a fully covered metal stent, and second one, 2 weeks later, at least, you do the integrated treatment. What about comparison with endoscopy? And you see in this international multi-center study, you can see the technical and clinical success rate is much better with this treatment than with EE and endoscopy. But of course, you have more adverse events, of course, because you are doing hepaticostomy. But if you follow the 2-step procedure, it's okay. You have a morbidity about 10% of the cases. So ESG suggests to do that in high volume center. Of course, it's a question of experience, and also suggests to do that after failed USCP in symptomatic patient. But as it is alternatomy, this is for me much better. I show you for pancreatic ductal drainage. Okay, you see it was a patient with previous Whipple procedures, and he did an attack of acute recurrent pancreatitis. You see the dilated pancreatic duct, and you see also the anastomosis with a gastric wall, because it was a virsongo-gastric anastomosis and not a virsongo-jejunal anastomosis. So we pass with the EUS-scope and the 19-gauge needle inside the lumen of the pancreatic duct. And so after we push the guide wire after filling with contrast, and we saw the guide wire. I was afraid it was into the peritoneal cavity, but in fact, it was doing a repermeabilization of the previous virsongo-gastric anastomosis. This is the first we have done. And at the distal part, you see this was a virsongo-gastric surgical anastomosis. And so we put a double pigtail stent with the anastomosis we have done, and distally the previous anastomosis of the surgeon. And the patient was completely asymptomatic after. So the last one, in case of bariatric bypass, of course, you know everyone about EUS-guided gastrostomy, which is called EDGE for EUS-guided URCP transgastric. And you see we have recommendation of ESG, and we have a large series about 180 patients. And you see the technical success was very good through transgastric and transjejunal access, because this is bypass. It is a procedure following bypass, and the mean of the duration of the procedure was 92 minutes, and one-step procedure in half of the cases. But the recommendation is to delay the USCP at least 7 days to avoid any stent dislodgement, which is lamp stent after. So I will show you, this is the recommendation. So of course, to do that in expert centers, but what is important is to try to diffuse the technique, because now it's a simple technique and we have to train the people. And this is the new challenge, is not doing EUS-guided treatment, but to train all the gastroenterologists for that. And I show you a new technique which is close to EDGE technique, which is called ED, transenteric URCP, EUS-guided. And in fact, it's in patients with Whipple procedures, when you are, or hooks and Y procedures, you put axial stent through the jejunum, through the stomach, into the jejunum, and you can access to the biliary anastomosis. I will show you this example. It was a patient with previous Whipple procedures, and then metastasis at the hilum of the liver and atrophy of the left liver. So we decided to put axial stent between the afferent limb and the gastric wall. And so you see, this is a direct technique for EUS gastrojejunostomy. So you see we access directly to the lumen of the jejunum, and we release the distal flange. Now we are on the endoscopic part into the gastric lumen, and we are releasing the proximal flange. For those who are using the stent, you can also release the proximal flange inside the working channel. I prefer to do that endoscopically to be sure to avoid any migration of the stent. And you see the distal, the axial stent, 20 millimeter inside. And so 8 days later, we went back with the scope, and then with a regular scope, not EUS-scope, because gastrojejunostomy anastomosis of the afferent limb was done. And so we have to enter inside the lamp stent, which is an axial stent in this case. And so we push the scope until we reach the anastomosis. Okay, this is very quickly done, because in fact we have a very short limb, and so we access to the biliary anastomosis. You can see on the upper part of the video, and you see after you have to do an endoscopic treatment, which is a biliary drainage, like for hilar carcinoma, because it was a metastasis at the hilum of the liver. And so we push a guide wire in the right lobe, and after a stent, and after we push in the left lobe another guide wire. This is okay, so, and then we release the two Biliary stent, and you can easily come back and change the stent for the patient. So, and this is in an outpatient. So this is for the patient very acceptable, especially when you receive chemotherapy because you have a recurrent malignant disease. So this is ED. Now, just a few words about drainage, EUS-guided. We, of course, now we know we have a recommendation. One is treated with lamp stent, and pancreatic pseudocysts are treated with double pigtail stents. This is clear, and this is very easy to do, and this can be done in intensive care unit for one very easily without any X-ray in the bed of the patient. So I just moved to EUS-guided gastroenterostomy. So you can do directly. The West technique, it's a wireless endoscopic simplified technique. I will show you. And one of the first technique was done with single balloon or double balloon occluded gastroenterostomy by Kashab and Itoi in Japan. I will show you the in patients with gastric outlet obstruction due to gastric carcinoma, and I use the EUS scope to push a guide wire inside the jejunum. Okay, you see the jejunum downstream was flat. Okay, and we push the guide wire inside the first jejunal limb, and after with a pump we push a lot of water inside, you see, and we use glucagon to decrease the motility of the small bowel. Okay, and after we use the wireless technique with free hand, you see, we push like in a one, we push the 20 millimeter axial stent, and we, okay, you see, we release the distal flange, we pull back very gently, because if you pull back too much, of course, you have a risk of dislodgement. And you see, when you have the black ring, you can release the proximal flange and push it from the working channel. And so you have your gastrojejunal stenosis, which is done. So you can treat a lot of patients with gastric outlet obstruction. There is actually a randomized series comparing duodenal stenting to this kind of treatment. And what I can say, we have less reintervention with gastroenterostomy than with duodenal stent, and the functional aspect is much better for me with gastroenterostomy than with duodenal stent. Okay, so the comparison have been done between diary technique I show you and assisted balloon, and this has a similar efficacy and success rate. So direct technique are more and more used, and I recommend this technique because it's difficult to get some balloon. And if you look to the results in the literature, you see about 90% technical and clinical success rate, but ESG recommends multidisciplinary discussion and careful evaluation of patients undergoing EUS-guided gastroenterostomy, because if you have any disturbance, it's a problem. So I just show you. You saw my video with another nasocystic drainage. It was a patient with Whipple procedures, and so we use the diary technique without any cystic drainage, and the recurrence, and you see the flat jejunum downstream to the stenosis with recurrence in the operative site of the pancreatic duodenectomy. So you see I push the 19 gauge needle until I reach the lumen of the jejunum, and after I will inject some saline and contrast inside. You will see, okay, you see the contrast filling the jejunum, and after you have, in this case, because it was alternatomy, you have to push after the guide wire, but slowly, because if you push too much the guide wire, you have the risk of pushing away the small bowel and have dislodgement of the stent. So you see the guide wire is inside, and now you can push with pure cutting current the Axios device until you reach the lumen of the device. So you see after at EUS you do not see anymore because you use the current, and you see you release on X-ray the distal flange and you pull it back gently until you reach the lumen of the stomach. Okay, now you see we are just reaching it, and you see the black ring, and we are going to release the proximal flange, and the anastomosis will be done very easy. The duration of such a procedure, you see the release, is about 30 minutes. Okay, and now with the biliary drainage use catheter is safer. So we move more and more to benign obstruction, and not only for malignant, because malignant is a recommendation of ESG. And you see on this series, benign indication were about 16% of the cases, and we have a series of 22 patients with only benign indication. It was successful in almost all the patients, and we move in 18 patients out of 22. And my personal series, we did 35 patients, and we have 41 benign indication: chronic pancreatitis, Crohn's disease, gastroparesia, and we have more and more increase of benign indications. I show you a case of Crohn's disease. It was patients with Crohn's disease without, and he was completely refractory to any biotherapy, and he was operated 6 times. And the surgeon told me, okay, not possible to treat this patient again with surgery. So we did the direct technique, and so we push, you see, contrast and saline inside the lumen. And after the guide wire, after we push our axial stent, lamp stent, inside the lumen, and after you know the way to succeed. And after we will release the distal flange, and after we will release the proximal flange into the gastric wall to do the gastroenterostomy. And you will see thereafter the endoscopy, because 2 weeks later we pass through the axial stent, and to see how was the small bowel just below this gastroenterostomy. So this is the release of the proximal flange. Okay, you see now. Okay, and now I will show you the video just after. So this is the proximal flange into the stomach of the patient. You see kind of stenosis due to the evolution of the Crohn's disease with ulceration, and we saw a lot of ulceration, and we saw a lot of stenosis and ulceration, and we went through the small bowel directly, and we dilated all the dilatation, and the patient was much was ill from the Crohn's disease. And now it's much better. It can work and eat normally after this kind of treatment, and we let in place the stent for 1 year, and then we retrieve it. So you see more and more indication of benign indication, and you see we have more and more direct technique, and you see the technical and clinical success is about 90% with 11% of complication. Most of them are dislodgement or misdeployment. I show you a case with rescue, and so in such a case, it's very important to have this patient had previous duodenal stent, and which was not working, and we did the treatment, and in fact the proximal flange was released between the small bowel and the stomach. So we push over the guide wire. We push, you will see, a fully covered colonic stent, you see, inside. So to have a good tightness, okay, and this is the control thereafter, 1 month later, and you see we have complete adhesion, and we can pass into the small bowel without any problem. So for the safety, use the guide wire, because if you have any dislodgements, you can work over the guide wire and do what is necessary. Just to finish with a direct antitumoral treatment, I will speak only about EUS RFA, because this is the new treatment since 5 years, and we have now more and more evaluation assessment of this treatment. And we conducted a study in 30 patients, 12 net and 18 with cystic tumor. The complication were 10%. So we use now prophylactic NSAID and antibiotics treatment in this patient. And so at 1 year, the complete disappearance of net, which was between 1 to 2 centimeters, and only G1 of the WHO classification was 85%. So this is very important. You see, this is how we do. This is in the incident process, a net tumor. This is a mesenteric vein. Okay, you see this is the net tumor. And you see with E-flow, you see vascularization inside. We are close to the mesenteric vein and to the mesenteric artery, but it's not a problem for doing RFA. And so we push the RFA needle, which is now an 19-gauge needle, inside the lesion. And you see the active part is 10 millimeters. You see the white bubbles filling the lesions. And when you have white bubbles flowing out, you have to stop, and you can do a second shot. And in this case, we replace the 19-gauge needle inside until we burn completely the lesion. And again, the result at 1 year are about 85% of complete disappearance of net. So I think we have to change completely the algorithm for managing net between 1 to 2 centimeters and G1 classification. We can do that also for pancreatic cystic neoplasm, and we have a response in 70% of the cases, which is less, but complete disappearance of the mural nodule in 100% of the cases. So I will show you not this case. Okay, I will show you the long-term results. And the long-term results are stable. Looking to the literature, we have 3 prospective studies, but follow-up only less than one year. And the mean success rate was 83%. And we follow the patient at least 3 years. So mean 45 months. And the final results were 85% of good results. And now if you look to pancreatic cystic neoplasm, we have 3 series, and also a follow-up less than 1 year. And you see the efficacy was less than for net. But you see in this case, we have a complete disappearance in 40% of the cases, significant response. I mean, less than half of the previous diameter in 25% of the cases. But in all the cases, a complete disappearance of the mural nodules who were indicated for endoscopic RFA treatment. So now we know that we have a good response for these patients with pancreatic cystic neoplasm or net, and which are stable following the patient with time. And now I just finish with vascular EUS treatment, because it can be useful. Usually embolization are done by the radiologist, but you can do also that with EUS approach. And we published a series with deep varices, aneurysm, and duodenal ulcer or any varices. And we have success in all the patients. And there is a US series with 88 success rate. I just want to show you the series from the team of Ken Binmoller in 152 patients. They did gastric fundal varices with embolization and endoscopy, and they had a success nearly in all the case. But take care about pulmonary embolism, because if you inject too much volume, you have a risk of embolism. So I show you a case, special case in patient with gastric carcinoma, with a huge ulcer, which was bleeding, and with liver metastasis. He was 85 years old, And the surgeon told us, no, we do not want to do any surgery, but the patient was bleeding. So I decided to treat this patient. You know that in such case, you cannot do anything with conventional endoscopic hemostatic treatment. So we decided to perform EUS-guided embolization. You see the feeding vessels, you see, and the tumor is just close to the probe. And we pass with a 19 gauge needle through the vessel. And after you have to adjust the tip by retrieving your needle. And after you inject the glue, we inject the glue in such case with a mixture of lipiodol and cyanoacrylate. And you see you have no more Doppler signal because you completely inject this feeding vessel, and the patient was no bleeding anymore. So I went to, I'm going to my last slide about the future of EUS. Of course, I told you that for me, therapeutic EUS is the main future of NOTS, because what about NOTS in the between 2000 and 2010, and it completely disappeared except pancreatic necrosectomy. But in fact, looking to the concept, therapeutic EUS is allows you to treat organs far from the digestive lumen. So I think we'll have less and less diagnostic EUS, except for doing FNA and FNB, because we have great improvement for imaging means. But EUS-guided treatment, I think, is the future of EUS. And endoscopic management now, I think, of biliary pancreatic disease is required now to be trained both to RCP and both to EUS therapy. But I think the main challenge which is remaining is to train in EUS-guided treatment, and we are trying to develop some box, ex vivo box, to train our fellows to perform EUS-guided treatment. So I thank you for your attention.
Thank you, Mark. That was a brilliant talk. It is a state-of-the-art lecture, so we're not going to take any questions, Mark. But it's brilliant. I who don't do EUS, I learned so much from this. So I'm sure others understood and learned as well. So thanks, everyone. Thank you, Mark. We'll let you get on and we'll catch up with our next session now. Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you.
I feel, guys, that we've exhausted everything. The two remaining talks about ESD is too much. We had a lot of ESD, so I don't think we need to go through any more ESD talk. And Professor Rapici has already told me that he's too tired to talk on disposable endoscope. We are tired as well. So I think we're going to thank everybody. Thank you for coming. We will announce the date for next year soon. Please stay in touch and come again. Thank you. Thanks, virtual audience as well. We'll be in touch with you soon with the next year.